Good morning, all of you, to this paid Pulmocon in Kolkata. All of you are requested to take your seats. Those who are outside, I don't know whether I am reachable there. Please come inside and take your seat. We will be starting within 2 minutes.
Uh, a very warm welcome from the team Pulmocon, and this is the yearly CME that we have of the West Bengal chapter of Pediatric Pulmonology, and we are very grateful to all of you that in spite of all the problems that we are facing at the present moment, with our heavy hearts, we had already planned for this session long time back, but and that's why we decided that we will continue with this in spite of all the issues that we are facing. Thank you very much for your cooperation and attending these sessions in such large numbers. And without wasting any more time, we will start off with the first session. That's the session on pneumonia. And I would request Drs. Arup Roy and Dr. Prabhavati Banerjee to please come and chair the session.
Hello, good morning to everybody. Thanks our West Bengal Pulmocon for the annual conference. And without wasting time, this is our session by Dr. Reshmi Ranjan Das on recent advances in pneumonia and management, for session for only 15 minutes. Dr. Reshmi, please.
Thank you so much.
Now today it's a special day. Actually, we all are shocked in some daily and day-to-day news. Still, we are in such a session where we will get some pleasure, relaxation, I think so. So the first very important chapter, that is pneumonia in children. All of us know that how important it is, and it is the main cause of mortality in young children and infants. So the important chapter is going to be discussed by Dr. Reshmi Ranjan Das, who is, and he is a professor, Department of Pediatrics, AIMS, Bhubaneswar. Yes, Dr. Das, you please start.
Thank you so much, ma'am and sir, for the nice introduction. Very good morning to all of you. And my special thanks to Subhashish Rai sir, Pallab sir, and the entire organizing team for organizing the conference in a kind of difficult situation. And my hats up to all the doctors of West Bengal for uniting for a cause. So my topic is recent advances in pneumonia management. So management has two parts basically. The first one is diagnosis and second part is treatment. Okay? So if the diagnosis is not proper, the treatment will not happen. And when the basic investigations fail, so you need some kind of advanced investigations. So coming to why pneumonia is still an important disease. So it is the leading cause of childhood morbidity and mortality in spite of a kind of dramatic increase in the vaccination coverage by pneumococcus and Aedes influenzae. And pneumonia is not an acute disease, it has also long-term impacts that in the long term it leads to decreased lung function and development of chronic diseases like asthma and COPD. So there is a drastical change in the etiology of pneumonia in last 50 years. So before 1980, you can see the most common causes were pneumococcus and Aedes influenzae, but after 2015, after the kind of increase in these vaccinations, now viruses are the most important cause, and studies have shown that almost 70% cases of pneumonia are caused by the viruses. So they may be isolated along with the bacteria, but they are the underlying causes. And if you see this data, in young children particularly, the viruses are the most common causes, and the viruses, they have a different prevalence according to different ages. And as the age increases, the bacteria will predominate. So in older ages, bacteria are the most important causes, including the atypical organism. But if the child is younger, like less than 5 years, then the viruses are the most important causes. So this is important because whenever a child comes to you with kind of pneumonia, we have an odds of starting antibiotics. So we should kind of wait and watch if the child is stable. And if you are not convinced, you should not start actually antibiotics. So then coming to the advances in diagnostics. So what are the newer modalities that will help you in diagnosis a child with pneumonia if your basic investigations fail? The first one is the ultrasound. So that is known as point of care ultrasound or POCUS. The second is chest MRI. So MRI is most commonly used for neurological diseases, but nowadays it has found a way in diagnosis of various respiratory diseases. Then you have the telemedicine. So whenever you are not able to diagnose something, so you can take expert consultation and you can have an online discussion also. You can send images, you can also send the recordings, so that will help in the diagnosis. Then nowadays there are digital stethoscopes available. So if you are not able to interpret a particular sound, something like that, so you can just record it and send it, or you can hear it later also, just to be precise what is the underlying cause in that particular child. So besides this, we have kind of different lab investigations, and to kind of do the investigation, you need appropriate samples. So if you see, the respiratory tract has two parts basically, the upper and lower, and accordingly you have to collect samples from different areas. So from upper respiratory tract, you can collect the pharyngeal swab, nasopharyngeal aspirate, and you can subject them to multiplex PCR and antigen detection test. And in the lower respiratory tract, you can collect the sputum. So sputum, if the child is not producing, you can induce it with 3% saline. Then you can take the tracheal aspirate if the child is intubated. So that is known as mini BAL, mini bronchoalveolar lavage. Or else, if the child is not intubated, you are not able to diagnose, you can do bronchoscopy and collect the bronchoalveolar lavage. In addition, if the child is having complicated pneumonia, you can take the fluid, and you can also do some lung aspiration that is not performed nowadays. So based on that, you can subject the sample to Gram-Stain culture, PCR and antigen detection test. And blood you can send for the culture, and you can also do this biofire assay, and different testings facilities are available. So that will tell you the diagnosis also. So whenever the diagnosis is not clear, you have to send multiple samples. And in some cases, urine antigen testing might be helpful, like Legionella or your leptospira. So coming to the POCUS, so this is a kind of very recent and emerging investigation. And now the evidence shows that you have to do ultrasound first rather than doing X-ray, because X-ray is not usually necessary, and it is not going to give you adequate information. It will show you some airspace opacities, but what may be their underlying or any complications, it will not show clearly. So what is this ultrasound? So if you see the images, so when you do it over the chest, so these are the images you will get. So in normal case, you will get this A line, okay, then second part is B line, and third, if you see, that is, you are not able to see any A or B line. So the lung architecture is distorted. So here we could see some air bronchograms, those are the white one. And before interpreting the ultrasound, let us kind of reiterate that in X-ray, the air looks black, but in ultrasound, the air will look white. And the fluid will look black in case of ultrasound, and if it is a consolidation or any soft tissue shadow, that will look hypodense. So if you remember this principle, so if you see any ultrasound chest image, you can easily interpret. So this is one case, this is pneumonia in a 6-year-old child. So if you see the left panel, the chest X-ray, so there is a airspace opacity in the, you can tell in the lower zone on left side. And when the ultrasound was done, you can see, so these are the hyperechoic areas, okay? So these are the air bronchogram because the air will look white. And now you see the lung is looking white and there are no air B lines. So that tells you that probably this is a consolidation. And the second one, you can able to see some septated collections. And here it is black, so it is probably a complicated pleural effusion. So in the single setting, it will tell you the diagnosis, and the most important part is that you can also take the sample. In X-ray, that is a 2D image. You are not able to visualize. So in ultrasound, you can visualize and take the sample then and there. So that is the beauty of ultrasound, and that's why in future, ultrasound may be performed before doing an X-ray in a given child. And this was a systematic review that showed that compared to X-ray, the sensitivity and specificity of ultrasound is almost more than 90%. So I was telling that in future, so ultrasound may take precedence over the X-ray in all cases of pneumonia. And the added advantage is that there is no risk of radiation exposure. So next, coming to the MRI. So in children, the problem is that they cannot hold the breath, and the MRI is a lengthy procedure, usually takes 45 minutes. So now there are rapid sequence MRI that can finish the whole procedure in 10 minutes. And this MRI is done in case of your CNS pathology, and there are 2 sequences in MRI. So if you see any brain MRI, the T1 images, T1 weighted images, the CSF will look black. So fluid will look black in case of T1 weighted, but in T2 weighted, the fluid will look hyperechoic or white. So the same principle applies to your MRI chest also. So T2 sequence are useful, and if you see in this case, so this is a consolidation, and here it is kind of looking white. So probably it is a consolidation with some kind of maybe necrosis or that contains some fluid or lung abscess, so that's why it is looking white. And it has been shown that this MRI may be better than your ultrasound on CT, and it has added advantage that there is no radiation exposure. So this is another case, a 7-year-old child with fever, cough for a week. The child was on oral antibiotics, now progressive increase in breathing difficulty since last 3 days. There was coarse crepitation on left infrascapular region. So let us see the X-ray in this case, okay? So on the left side, if you see, so there is a opacity with some areas of breakdown. So that areas of breakdown, we don't know, probably it is a necrotizing pneumonia. But when you are doing MRI, so this is a T1 image, so this is showing a thick capsule with a hypodense area. And in the T2 weighted, it is looking white. So probably it is a long abscess. So you compare with the X-ray, X-ray is telling you necrotizing pneumonia, but in MRI, you are getting long abscess. So this is another case, 9-year-old child with complicated pneumonia who had long abscess. The child received 2 weeks of IV antibiotics followed by oral antibiotics, and after 4 weeks, the MRI was done because the child was having some signs in the right infrascapular area. So if you look at the MRI, so this is the corresponding X-ray. So you see the lung abscess there in the initial MRI, and same in the X-ray, though X-ray is not clear here. And in the follow-up, you see X-ray is totally normal, but the MRI is still showing some kind of areas of consolidation, but there is no lung abscess. So if you stop antibiotics at this point of time, the child may worsen also. So MRI versus focus in pneumonia. So this is another case scenario, 3-year-old child with fever, cough and shortness of breath for 7 days, coarse crepitation, right memory area will decrease the air entry. And you see, so again there is a consolidation with probably a evolving long abscess. In X-ray it is showing air space opacity, but in ultrasound again it is showing some kind of, you can tell, hypodensity, probably consolidation, but it is not showing in features of abscess. So if you do MRI, it can pick up this abscess very early also. So in that way, so MRI may be better than this ultrasound, and both have the added advantage of no radiation exposure. So digital stethoscope, what you can do? So in a BG OPD also, you can just auscultate, that will record the sound. You can hear it later on, whether it is crepitation, what type of crepitation, if it is wheeze, strider, anything that you can easily interpret. And if you are not sure, you can send it to experts also, kind of for evaluation, so that you can clear-cut know what is the underlying clinical diagnosis. So I was telling that respiratory samples you have to use, suppose you are not able to diagnose in a particular case, complicated cases. So these are the different samples like induced sputum, BAL, mini BAL, so those can be used. So induced sputum, you can use 3% saline to take out sputum if the child is not producing. And there have been conflicting results in different studies. Some studies show that the induced sputum may not be useful, and some show that it may be useful. So this is one of the studies that show that induced sputum may not be useful because it reflects oropharyngeal carriage. This is the second study that shows that it is a safe procedure, and the findings corroborate with your other investigations. So there is a conflicting result. So whenever you are not getting in diagnosis, you can induce sputum, send the induced sputum just to see whether you are getting an organism. Then BAL fluid. So in difficult cases, complicated cases, or the children who are prolonged hospitalized, you are not getting anything, child is not responding. So this bronchoscopy and taking out of this BAL sample may be helpful. So this is a case now admitted with us. The child is 11 months and he presented with persistent pneumonia. So when the child came, he was having oxygen requirement and there was dense airspace opacity in the X-ray. We are not getting anything, blood culture, everything was sterile. We did bronchoscopy and take the BAL sample. You see, it grew this Pseudomonas aeruginosa. And you see, it is resistant to almost all the antibiotics. So we gave this ceftazidime avibactam and the child responded. And as we could isolate the Pseudomonas, we thought of cystic fibrosis because the child was also having failure to thrive, and it was positive. So the child was diagnosed to have cystic fibrosis. Then induced sputum versus BAL. So these studies show that both sputum culture and bronchoalveolar gram stain are helpful in predicting single bacterial pathogen from BAL fluid culture among children with community-acquired pneumonia. Sputum culture and BGS can provide early clues for your BAL fluid pathogen when culture results are pending or bronchoscopy is not performed. So you can kind of do both of them, and if you are not able to do bronchoscopy, you can do induced sputum because it can predict that probably with what organism the child is kind of colonized or is harboring. Then next generation sequencing. So this is another test. Again, it is a nucleic acid based test. So blood pleural fluid culture has poor sensitivity because many of the children, they receive antibiotic and come to the facility. So NGS can be kind of helpful in those cases because it is not affected by your prior antibiotic use, but it has some limitations because it cannot determine the susceptibility, and you can isolate organisms which are not potentially harmful. So these are the problems. So this is evolving test. Then multiplex PCR. So all of us know this BioFire. So this is the latest version, that is BioFire film array that can detect almost 33 organisms, and it can perform well on this BAL and sputum sample also. The sensitivity specificity very high, and also you can tell you the organism and their sensitivity pattern. But again, the problem is that it may isolate some inoculous organism, and it is relatively a kind of costly investigation. And still you have to do the culture to see the antimicrobial susceptibility pattern. And sometimes you may get false positive result. So that's why you have to correlate the finding with gram staining. So it is a costly one. So that's why. And it may not add sometime, but in case-to-case basis, you can still use. Blanketly, we cannot recommend this, but in selected cases, you can use this BioFire. So there are different biomarkers that has been tried to differentiate between bacterial and viral causes. So for bacteria, you have PCT, then interleukin 6, 8, CRP, and viral, you have different biomarkers. So in a recent study, we found that this biomarker like PCT may not be very useful. So this was a study done by us, multicenter study. Kabra sir was the leading investigator in this case. And then there is a debate regarding whether to routinely monitor this saturation in all children with pneumonia. So mind it, any child with even a non-severe pneumonia, you have to look for the saturation, because if the child doesn't have distress but the saturation less than 92%, the child will qualify for severe pneumonia. So in that case, saturation monitoring is very, very useful, and that should be done in all the cases. And hypoxia is an important cause of mortality in any child with pneumonia, so we should give oxygen. And we found that monitoring saturation is helpful in increasing the diagnostic sensitivity of pneumonia in a given child. So this study again done by us. And regarding the antibiotic dose and duration, this study, very important study, CAP-IT trial was published in JAMA. And it showed that the low dose, that is 35 to 50, is equivalent to your high dose, that is 70 to 90. And 3 days is as good as 7 days in children with non-severe pneumonia. And this is another meta-analysis that also showed, they compare different antibiotic duration. You see there was no difference between 3 versus 5 days, 3 versus 7, 3 versus 10, and 5 versus 10 days. So steroid, there has been a lot of debate because steroids have been tried in adults and they have been found to be useful. So this Cochrane review was done on that, and they
Dr.
included
Das,
4
time
studies.
is
Sir,
over.
2 minutes more, sorry. 2 minutes. Sir. 4 RCTs including children, and they found that steroid may help adults with severe pneumonia, but it is yet to find its place in case of children with pneumonia. So we should not recommend steroid in all cases of pneumonia as of now. We need more studies. And please mind, there is no role of zinc, vitamin A, vitamin D, so that was the Cochrane review done by us, and we have also done this systematic review. This zinc and vitamin D, they do not have any role in case of pneumonia. And so what is the take-home message from this presentation? So focus, this point of care ultrasound is emerging as the first line imaging modality, and in future it may replace chest X-ray. MRI chest, future role in particularly complicated cases and detecting early complications, as I showed you in that case. All children with community acquired pneumonia, even if they look stable, please measure the saturation, because if there is hypoxia, it will increase the make the child into severity classification, that is severe pneumonia. Low dose and short duration, that is less than 5 days amoxicillin, is recommended in children with non-severe pneumonia. And nucleic acid based tests like multiplex PCR, NGS, they have role in selected cases, so they cannot be blanketly recommended. So thank you so much for your patience hearing. If there is any doubt, I can take.
Thank you, Dr. Das. You have nicely elaborated the recent investigations and management regarding the pneumonia, especially in older children above 5 years of age. I think there is no question can be
No,
invited.
we will take questions. Please write down on a piece of paper. We have a doubt clearing session at the end of the day, that is Chai Pe Charcha, where all the faculties will be there. So please write down on a piece of paper and give it to us, because we have to complete all the sessions in time.
Thank you. Thank you.
Thank you so much.
Thank you, sir. Thank you.
So the next,
Our next session for the 40 minutes by the panel discussion, community acquired pneumonia, the new lights on an old disease, that will be moderated by Dr. Joydeep Chaudhary, who needs no introduction. And our Dr. Chaudhary will introduce panelists, Dr. Mir Sarkar, Dr. Parthapotim Haldar, Dr. Amitav Pahari, and Dr. Ajit Chetri. Dr. Joydeep Chaudhary, please.
This is a very important, this panel discussion is very important because community acquired pneumonia, which is very commonly we find, so there should be a discussion and questions on this. Now Dr. Joydeep Chaudhary is the moderator, who is professor in Institute of Child Health. Everybody knows about Dr. Joydeep Chaudhary, sorry. He is a professor, Department of Pediatrics, Institute of Child Health, and he has many involvement in our Academy of Pediatrics, that is in West Bengal and also in India. He is the Vice President in Executive, East Zone Vice President, and also he is the, he is intimately involved in our Indian Academy of Pediatrics.
So good morning. It's a pleasure to be in an academic forum, and thanks Chairperson, thanks the organizing team of Pulmocon, and we have a elite panelist here, Dr. Amitabh Pahari, who is a renowned consultant pediatrics, expert in infectious disease and nephrology. He's a consultant at Apollo Hospital. Dr. Mihir Sarkar needs no introduction, professor at Medical College, Kolkata, also the secretary of West Bengal Academy of Pediatrics. Dr. Partho Haldar, associate professor in Institute of Childhood, and Dr. Ajit Chhetri, who is from Siliguri, renowned pediatrician. Now, first of all, I am grateful to Dr. Rashmi Ranjan Das for setting the tone rightly and doing all the groundworks of this session, which is a purely case-based session on community-acquired pneumonia, some new lights on an old disease. So what we will take forward is what Rashmi has already created the base. So let us go to few cases. Now this is a 5.5-year-old girl with fever for 5 days and a mild cough for a day. On examination, the child had tachypnea. Saturation was 94% in room air. Air entry was reduced on the right side with crepitations and bronchial breath sound. Total count was 4,000, CRP was high, and this was a X-ray. So what could be the probable diagnosis? Very briefly, because we have already discussed some common causes. So anybody, please, any expert? Yeah, Dr. Chhetri, want to take, please? What could be the common causes in a 5.5-year-old girl?
With the clinical scenario and the WBC count and the chest X-ray, it looks like a viral illness.
Yes, it's actually, if we see the age-related pathogen, the more common are the gram-negative bacteria in the lower age group, then 3 to 5 years. 1/3 of the cases are viruses, then comes streptopneumonia, H. influenzae, staph, and others, and above 5 years, again, the streptopneumonia is the leading, followed by atypical mycoplasma and others. So 1/3 are viruses, then among the bacteria, the commonest is streptopneumonia, and of course, we have to think of the atypical organisms. Now, in this situation, are we justified in not starting an antibiotic thinking it's a viral infection, or if we start an antibiotic, which antibiotic you think is the right one? Any expert, please? Yeah, Dr. Mihir Sarkar, please.
Yeah, thank you. So this patient, if you look at this patient, the 5 days fever and followed by cough, now the patient has already got the signs of respiratory distress in the form of subcostal and intercostal retraction. So this patient now going to be a downhill course a bit. And as you look at this, though it is a viral, looking at the clinical pictures, but always the demarcation between the viral and bacterial through clinical markers is not possible. It is, we can say, is most probably it could be a viral, but looking at the patient, the course of the disease, if it is the downhill course, the age of the patient, and previous immunization status, and of course, taking at the clinical background, you can start the antibiotic at this moment. So if you want to start the antibiotic here, as you have already shown, the Streptococcus pneumoniae is the most common organism and the age of this patient. So the right antibiotic, if we start, this would be the oral inpatient will be the amoxicillin.
Yes, as this explanation Dr. Sarkar has already told that, again, we have to think of the probable organism, because fever with tachypnea by definition is pneumonia. And in children, unless otherwise proved, we better start with an antibiotic. And if it's below 3 months, of course, hospitalization. Then above 3 months, the first line is amoxicillin. Now, ideally, we must start with the standard dose amoxicillin of 40 to 50 milligram per kg per day. And that cures most of the infection. I would like to ask the experts, what are the indications of high dose amoxicillin that we often hear now? Dr. Pahari, you want to tell?
I think Dr. Rashmi Ranjan Das recently actually, just now shown us the recent meta-analysis that was published in JAMA, which clearly a non-inferior study showing that low dose or the usual dose of amoxicillin and a shorter course is possibly as good as a high dose. High dose amoxicillin was initially studied for suppurative acute otitis media. And subsequently, in the guideline published by American Academy of Pediatrics, which has been actually inculcated by us as well here, and we used to treat with high-dose amoxicillin, particularly when we are giving domiciliary treatment of community-acquired pneumonia. In all our patients, when they're admitted in the hospital, we always treat them with high-dose amoxicillin or amoxicillin clavulanic acid as per the recommendation. In the day-to-day practice, I think high-dose amoxicillin should always be given if you are treating moderate to severe pneumonia, either in the hospital or in the domiciliary setting. Still, we are getting more information from our community.
Thank you, sir. Actually, the concept of high-dose amoxicillin came from the fact the increasing MIC, the minimum inhibitory concentration. Now, if it's above 2 MIC, then we must be cautious. If it's above 4, then we have to go for high-dose amoxicillin. Fortunately, in India, generally the MIC is still below 2. There was a Delphi study done also, and it was published for acute otitis media, of course. But for pneumonia also, when Streptococcus pneumoniae is the most common organism, the MIC in most of the isolates is still below 2. So we need not right now increase the dose of amoxicillin to 80 to 90 or 100 milligram per kg. But there are some specific indications, though Dr. Pahari has rightly told it was mainly with acute otitis media. But if a child has received standard dose amoxicillin in the last 1 month and has responded, then again has presented with pneumonia, then it is justified to start with a higher dose amoxicillin. Otherwise, initially with normal dose amoxicillin is quite justified. As of adding clavulanic acid, the question often comes. Now, the mechanism of resistance of streptopneumonia is by alteration of the penicillin binding protein. So there is no role of beta-lactamase inhibitor. H. influenzae, only about 1/3 the resistance is by enzyme. Other than that, it is the penicillin binding protein. So there also, plain amoxicillin is justified. And then mycoplasma pneumonia, there also, there is no enzyme production. So to start with, plain amoxicillin is justified. Only if there is a recurrence within 30 days, similar infection, then we are justified in starting higher dose amoxicillin and maybe with clavulanic acid combination. We will move on to another 5-year-old boy. High-grade fever for 4 days, cough and rapid breathing 1 day, respiratory rate 36, temperature is high, 94% room air saturation, mild retraction, diminished air entry. So it's a non-severe right upper lobe pneumonia. Quite clear cut. Started on oral co-amoxiclav and paracetamol, and the parents were explained about the danger sign. Rightly, the child was called back for follow-up after 48 hours. On follow-up, temperature 100, respiratory rate 30, saturation 94, retractions and others are same. Now, is this a complicated pneumonia? How do you define complicated pneumonia? Dr. Partho Haldar, please, if you want.
So, if a patient fails to respond to appropriate antibiotic by 40 to 72 hours, then probably he is developing complicated pneumonia. So this patient, came back after 48 hours, and probably this patient is showing some improvement, accepting oral feed, temperature range has reduced, saturation 94 in room air in a more than 5-year-old child is acceptable. Smaller children, we should be more cautious. Retraction is also mild. So probably we can continue antibiotic under observation.
Yes, rightly. Actually, what Dr. Haldar has rightly told, that tachycardia, hypotension, fever, tachypnea are all expected to recover within 2 to 3 days. Cough may take a long time to recover. Similar is the X-ray features, it may take long time. But following up after 48 to 72 hours is very crucial, because we have to detect the complications early. So complicated pneumonia has to be suspected within 40 to 72 hours. That's why follow-up is very essential. Otherwise, it may land up into more problem. Moving on to a third child, who is an adolescent 11-year-old boy with a community-acquired pneumonia, treated and recovered. Now, mother repeated the chest X-ray on her own after 1 month. The child was asymptomatic, but she was scared to see the same shadow persisting. Is this non-resolving pneumonia, and what's the normal timeline of resolution of pneumonia, and do we need to repeat chest X-ray following treatment? Yeah, Partho, you want to tell? Yes, Partho.
Okay, so this patient doesn't have any symptoms, but there is a shadow. So this cannot be called non-resolving pneumonia because the timeline for X-ray resolution varies depending upon the organism. For example, it may, so it may resolution may take from 2 weeks and it may up to 12 months. For example, adenovirus, X-ray shadows may persist. So we don't need to treat the shadows and repeat X-ray unless we are thinking of that patient is developing complication. Routine repeat X-ray is not required.
So that's right. That's why we must counsel the parents beforehand that please do not go and repeat an X-ray, but repeating an X-ray is probably justified in very small infants where there may not be many symptoms. So that is one of the situation, and of course POCUS is another option which we may do early.
Just
please,
adding
please,
one point,
please.
Because Partho very rightly mentioned about one virus, adenovirus.
Yes.
Because we have actually had our
Plethora
share of
of cases.
adenovirus associated pneumonia giving rise to bronchiolitis obliterans and persistent infiltrative kind of changes in interstitial pneumonia. Those patients might benefit from repeat radiological investigations that we have to keep in our mind. Because those patients are often symptomatic as well.
Absolutely. Adeno is a totally different entity, and that's a Pandora's box with the cases that we have seen. 4-year-old boy, fever for 7 days, distress since this morning. Tachypnea is there, retraction there, saturation low, hemoglobin 9.5, WBC high, CRP high. Patient was treated outside with ceftriaxone, blood culture was sent. After 48 hours, child still febrile, dyspneic. You see the chest X-ray, and vancomycin was added. I think by this time it's quite justified because we do not know the organism. Now, after 4 days, the child was still running high temperature, dyspneic, hemoglobin 9, WBC same, high, CRP 100. Resident visited the microbiology department where it was told that blood culture showed MRSA. And you see the repeat chest X-ray now. This one to the left was the first one, and this is the next. Any other investigation at this stage? Mihir, you would want to take? Okay. First
So from the X-ray, what we can see, there is a deterioration. The patient, you can see the obliteration, the bilateral, both the costophrenic angle, and that indicates there are a fluid collection, and that may be due to empyema, and the patient is deteriorating. So what bedside investigation that will help immediately us to take further decision on the treatment and the further management, as Dr. Rashmi has told us, that the lung ultrasound will be very much effective at this stage, because not only we can diagnose this consolidation and air bronchocum, but the fluid collection, empyema, or if there are the septations are there, or it is just a fluid, so we can measure the amount also, and we can take the decision immediately to put a ICD drain and further management. And if there are requirement of some fibrinolytics on that, if the strands are present or not. So the bedside ultrasound will be one test that will be help us to take the immediate decision on the further course of management for this patient.
Yes. So, yes, bedside ultrasound was done, and there was significant amount of thick fluid with fibrin strands. Pleural fluid was more than 1,000 cells, all polymorphs, glucose 20, LDH 1,000, VATs done, and chest drain placed, as you can see here. Now, the culture report showed Staph aureus, which was resistant to oxacillin and coamoxiclav, sensitive to vancomycin and linezolid. There was no improvement after 2 days. The distress continued with high fever. WBC from 23,000 now was 14,000, neutrophil 74, CRP from 200, it is now 200, and you see the repeat chest X-ray here. So what could be the cause? Dr. Pahari, you want to take?
Since
Aditi, please.
already the culture is showing staph and the appropriate antibiotics has been given, but still the child's clinical condition refuses to improve. So here we have to again think of whether some viral element is there or not. That has to be kept in mind. And, and as Dr. Rashmi had said, even I think here MRI will be very helpful. Although we are not doing routinely because of the logistics and because of the cost and so many things involved. And
Yeah.
So I would like to add something. The total count is falling with high CRP. There is no clinical as well as radiological improvement in spite of giving sensitive antibiotic. So probably you are dealing with some toxin producing staph that causes the count to fall, and also the patient is not improving. So PVL staph may be the reason even after giving vancomycin. So we need to add something like clindamycin, which has also toxin neutralizing property.
Dr. Sharkar, any other opinion?
Yeah, so that's the Partha has pointed out. So the toxin production and also sometimes the co-infection could be a possibility. So these are the two possibilities we keep in mind.
Yeah, absolutely. So the markers that the experts have already pointed out is the dropping total count, rising CRP, and the chest X-ray is worsening. Clinically, of course, the child will continue to be sick. So it is suspected to be a PVL producing staph, is a penton valentin leukocidin produced by the leukocytes, and it has to be diagnosed clinically. We have to think about PVL when such complications arise. And here, definitely, we have to give clindamycin type of antibiotic. Now, whether to continue vanco or to switch to clinda, that's a clinical decision, but it's very difficult at this point to stop vanco and continue only with clinda, because clinda is again a bacteriostatic. Yes, Dr. Pahari.
Question to
Yeah, please.
Dr. Chaudhary. I think, we do not know the exact prevalence of PVL producing staph in our community. But in a number of institutions that I have been working with, I have found that whenever you are actually thinking of staph, you are often combining vancomycin and clindamycin together till you are absolutely certain that the patient are not deteriorating. How far this is right? And the second thing, linezolid is an antibiotic which is going to be active against toxin-producing staph as well. What is your take on using linezolid instead of vancomycin and clindamycin together? Two questions, please, for you.
Any experts who want to take it? Linezolid, yes, Mihir, lung penetrant.
No, so you can just a point. So if when to start clindamycin empirically. So if the patient have some necrotizing infections, that the tissue destruction in the form of either staph, necrotizing fasciitis, or the necrotizing pneumonia with empyema or lung abscess, in that case probably we should start clindamycin empirically at these patients. And regarding the linezolid and things, I think linezolid, though the lung penetration is better than the vancomycin, but if the vancomycin is sensitive, and we can continue because we have to preserve it if for the vancomycin resistant or the MIC of the vancomycin is high, in that cases we can consider.
I'm not talking here about just this patient.
He's telling that to start initially with a vanco-clinda combination.
Or you give just linezolid, because that is going to cover your toxin-producing staph as well. Because toxin-producing staph, as Mihir very rightly said, whenever you are actually seeing any toxin-mediated illness, not necessarily toxic shock syndrome, be it is necrotizing fasciitis, be it is necrotizing pneumonia, I think it's very sensible to cover with an anti-toxin kind of staphylococcal antibiotics rather than any other staphylococcal antibiotics. So whenever we actually suggest treatment of a toxin-mediated staph in whatever the clinical scenario is, you should be giving one penicillin and a toxin-inhibiting kind of anti-staphylococcal antibiotic as well. So that's the take I wanted to have your opinion.
Very pertinent point Dr. Pahari has raised from his clinical experience. Now, number one, see, PVL producing or toxin producing organism, that is a totally clinical detection. As per the recommendations, we are justified in starting with a vancomycin if there is an MRSA. Now, mind you, PVL may be due to both MRSA and MSSA. So that's a point. Now, if there is deterioration, that's why we have to detect early. Then there is definite indication of adding an enzyme inhibitors like clindamycin. Now, whether to go for linezolid at the very beginning, that's again a debatable, but as for the recommendations that we have, still vancomycin is the drug for MRSA. Of course, there is a debate whether to start ticoplanin in place of vancomycin. But let us not go.
No, we are not going there.
Yes.
That's my renal head. I'm a little bit worried about vancomycin all the time.
Right, I understand. So, when do you really clinically suspect necrotizing pneumonia? Are there any way to clinically suspect necrotizing pneumonia? Anybody, please. Yes, Dr. Chetri.
When the child becomes toxic and not responding, even despite all the antibiotics that we have given, and somehow the child, we can understand that the child is not looking good. Basically, no clinical improvement.
Exactly. Again, that 48 to 72 hours margin is very important. We have to suspect early. We have to see the condition of the child, the response, and then we may go for, may think of necrotizing pneumonia and go for other studies. Now, what's the ideal imaging method to diagnose necrotizing pneumonia? Yes, Dr. Pahadi, please.
I think Dr. Rashmi Ranjan Das very rightly pointed out during his presentation, focus will be the ideal method, and obviously most of the time we still go ahead and do a CT chest to have a better delineation of anatomy, and at the same time the surgeons, the VATs, they are not going to actually go into any procedure
without
unless
a
you're
CT
doing
scan.
a CT chest.
Yeah,
Jaideep, I want to go back to the X-ray of this child, please. Just go back. Yeah, I think, for a clinician like me, with the first chest X-ray, if I'm not suspecting necrotizing pneumonia, that means I'm not doing my X-ray interpretation right. Even in the first X-ray with the right upper lobe pneumonia, there is tissue breakdown here, and an astute clinician should be suspecting necrotizing pneumonia by looking at that chest X-ray alone. I think that is very important.
Absolutely, sir. Thank you, sir. Now, are there any biomarkers for diagnosing necrotizing pneumonia? Or any clues for PVL producing staph? I think that we have discussed already. Any biomarkers for necrotizing pneumonia? Would you like to highlight? Yeah, Dr. Sharkar, please.
Yeah, so there are biomarkers like if the count is very high, or the high CRP, though this is the very soft biomarker, not a very distinct one. And the hypoalbuminemia, what the literature has shown, could be associated with the necrotizing pneumonia. And also clinically, if the patient have hemoptysis and erythematous skin rash or the leukopenia, these are the biomarkers that can guide us that the patient is probably having the necrotizing pneumonia and start appropriate therapy for that.
Right. So close monitoring, anti-staph, antitoxin therapy, that's what. Then another 13-year-old girl, fever, cough for 3 days, oral coamoxiclav. There was breathing difficulties from the 5th day, admitted in a hospital outside, chest X-ray showed bilateral opacities. So they started meropenem and vancomycin. Now the child is complaining of leg pain, right leg pain. Admitted, saturation low, febrile, hypotensive, not able to move the right leg, tender right thigh, and azithromycin was added. WBC was 18,900, neutrophilic CRP very high. The child needed ventilation. What is happening now and how to manage? And you see the X-ray. Yes, Dr. Haldar, please.
So the X-ray is very bad and patient is also clinically very bad. So probably azithromycin is not the right choice here because we have a clue the patient is having a tender right thigh. So probably this is some disseminated staph infection I will think of. The primary focus is in right thigh and lung is involved via bloodstream infection. So we need to look for the focus. We need to evaluate the thigh. Imaging will be a good choice to see whether there is pus collection. Depending upon that, the next step of management can be decided.
Now, yes, the imaging was done. Pus drained from the right hip on day 5. Fever spikes decreased but persisted, and there was persistent raised inflammatory marker. Now this is you can see the swab test done, and it was staph aureus, and it was sensitive to most of the antibiotics that you can see. So why this child is not responding despite good coverage with meropenem, vancomycin, and do we need to change the antibiotics? Yes, Dr.
Yeah,
Sarkar.
so before going to that, you can see the patient is very sick with the disseminated staph with the multi-system involvement. Patient has hypotension. If we look at the patient is fitting the criteria toxic shock syndrome as well for this patient, because the child is very sick and the hypotensive requiring mechanical NIV support. So if the patient is toxic shock syndrome, then I think what we can think also is that intravenous immunoglobulin. So that is the recommended treatment for toxic shock syndrome. So that we have to consider. And regarding this antibiotic here, you have seen this this is the patient with MSSA. So this, as it has been shown in the also in the literature that if it is MSSA, even if it is a vancomycin sensitive, the cloxacillin, the penicillin group will be more effective, and the better killing of the bacteria will be, and the faster killing with the cloxacillin group. So I think at this moment that we have to de-escalate the antibiotic from the vancomycin to cloxacillin. Even we can stop the meropenem in this patient. And if we are not suspecting any gram-negative or other organisms at that moment. So the cloxacillin changed into the cloxacillin will be effective, and if it is toxic shock syndrome, then starting intravenous immunoglobulin.
Yeah, Dr. Pahadi, any comments?
I think there are three things here. This patient is actually critically unwell, as Mihir very rightly pointed out. And if you are again thinking of this patient fulfilling a criteria of toxic shock syndrome, you are supposed to add one anti-staphylococcal antitoxin antibiotic, which is an enzyme inhibitor. And of course, there is a role of IVIG as well. But most important here will be the source control. So proper drainage of the thigh and proper drainage of abscess is going to be the key for reducing further toxin production of the staph. Other than your antibiotic change, you need to look at this patient holistically and possibly, continue the antibiotics for 6 to 8 weeks, the way you do for your bone infection with Staphylococcus aureus.
Yes, sir, absolutely right. Drainage of pus was done definitely, and what Dr. Sarkar and Dr. Pahadi has rightly told, that flucloxacillin was started, vancomycin was continued for 6 weeks, and then it was orally continued also. And the message is that though it was looking very ominous, but because it was an MSSA, here cloxacillin did wonders. So cloxacillin is superior to vancomycin for MSSA. 5.5-year-old girl, high fever 10 days, respiratory distress 1 day, there was a convulsion, tachypnea was there, saturation was low, there was retraction, there was bronchial breath sound. WBC was 4,000, CRP high, procalcitonin high, chest X-ray, right-sided pleural effusion. POCUS was done, right-sided effusion with consolidation. Admitted in PICU, ceftriaxone, vancomycin, cloxacillin started, seeing this X-ray. Pleural fluid was 1,100, glucose 2, protein 3.8, LDH 5,000, Gram-Stain culture negative. Due to convulsion, CSF was done, negative. The child worsened, deteriorated, intubated, ventilated. Repeat X-ray, increasing pleural effusion, right-sided intercostal tube drainage done. Again, this is a complicating. So what could be the cause of this deterioration that we have to keep in mind? Yes, anybody? Oh, Dr. Mihir Sarkar, please.
So the deterioration here, you can see that the patient has, again, the multi-organ involvement, the patient has CNS involvement, lung involvement. Even after the drainage and adequate antibiotic, the patient is deteriorating. So, and the patient, I think the organism has still not identified. We have not any growth still now. We have not taken any growth. So what we have covered is that with this and ceftriaxone, vancomycin and cloxacillin, both covering the streptopneumonia, H. influenzae, but also the staph. So bacterial coverage has been given. Unless there is any ESBL producing gram-negative organism associated with that, then that antibiotic should will be suffice. But there may be other possibilities that we know that in smaller children, any viral co-infection could be a possibility. So that viral infection actually gives the seed for the secondary bacterial bacterial infection in many of the times we have seen in patients. So these are the possibilities we have to keep in mind. One is that if we can, patient is intubated, we can do a mini bell or the bell of this patient, or even at least can say the tracheal aspirate for culture of any growth, and that is any resistant organism or any viral co-infection should be keep in mind, and sending the nasopharyngeal PCR will be helpful in this patient.
So we have seen adeno cases also presenting typically as bacterial pneumonia. Now on day 5, WBC was 16,000, CRP 90, respiratory PCR was done, and it was influenza B and streptopneumonia. Mind you, influenza B, though influenza A is more commonly associated with streptopneumonia, but this is a real case. Now how to manage, whether to add antiviral at this point of time or retrospectively when we should have started antiviral. Yes, Dr. Chetri, please.
Ideally, antiviral is always said to be more effective and to be used as per recommendations before 3 days. But in scenario like this where particularly if we have a biofire and we are able to actually find out that yes, it is viral, like here it has been seen that influenza B is there, then personally I would say empirically there's no harm in starting that, because how effective it is something to debate.
Fine.
But yes, why not go for it?
Any other opinion from other experts, please?
I would also add oseltamivir because it's not going to do any harm. But I will specifically look about whether we are actually giving adequate dosage and adequate coverage against resistant strep pneumonia as well.
So 2 aspects coming out. One is resistant strep pneumonia, another is starting oseltamivir. Now, in hindsight, whether we should start oseltamivir earlier. Dr. Sarkar, please.
Yeah, so the recommendation is we should start within the 48 hours for within the symptoms for the better result. But yet, whether we should start the empirical oseltamivir in patient with a severe pneumonia, presenting community-acquired pneumonia, yes, if there are risk factors and there are seasonal variation, if it is the patient, the various cases of the H influenza are identified, if the patient is having the requiring the hospitalization or rapidly deteriorating course, or the patient has comorbidities like the congenital heart disease or the broncho, or previously patient had any viral infection that leads to the PIBO or the chronic lung disease, these are the patient we have to must think of the starting the empirical oseltamivir in this patient.
Sure, thank you. 2-year-old boy.
I'll just.
Yes, please, Ajit.
Dr. Mir, as you have already outlined these high-risk cases, but the biggest problem for everyone is that respiratory PCR is costly and
there are
not
limitations.
readily available.
Yes.
It takes time in certain centers. So in those institutes where it is readily available and the report is available, then there is no debate at all. You have the report in your hands and you can immediately start. But for people where we are not having the adequate resources,
Yes, we have to
that is the time I think when
achieve
we
that
would like to
balance.
overtreat,
Right.
rather than wait for the reports for 2 or 3 days it takes. Sometimes it goes to other cities.
Yeah, thanks for the input. 2-year-old boy, cough, coryza 4 days, fever follows, rapid breathing, then tachypnea is there. You see the chest X-ray. Nasopharyngeal swab was done and it yielded human metapneumovirus. Oxygen started, nebulization, antibiotic coverage, and the child deteriorated, ventilated. Now, how severe is metapneumovirus and what could be the cause for this deterioration in this perspective? Dr. Partho Haldar, you want to add?
So, this biofire report, this can be a big trap sometimes. Because in biofire, especially if we are taking the upper respiratory samples like nasopharyngeal swab, if you get multiple organism, or if you get organism that usually doesn't cause so severe pneumonia, so it is sometimes very difficult to tell which are the innocent bystanders and which are actually causing the disease. So in this X-ray, it looks like a lobar pneumonia. So, and the patient is deteriorating very rapidly, ventilated. So probably this is not the only cause. So we are dealing with something else. It can be a co-infection of bacteria and virus. And as the patient is intubated, it's better to go for a lower respiratory sample in form of a bronchoalveolar lavage or tracheal aspirate and subject that sample to respiratory PCR for confirmation.
Yes, I actually wanted to pass on this message, and the person rightly, Dr. Partho Haldar, who has been doing these procedures routinely. So we have to think twice before considering the upper respiratory yield. Any other opinion from the experts?
Yeah, so yes, Partho has rightly said. So this metapneumovirus, the typical presentation is typically RSV-like presentation, bronchiolitis-like presentation, or sometimes croup. But it can also cause ARDS. But lobar pneumonia, though typically found in some patients with the adenovirus, but it is very rarely reported in metapneumovirus. But there are some viruses, if we identify them in a patient with upper respiratory tract sample, but patient have pneumonia and acute symptoms, like if the patient have influenza is identified, then the rhinovirus, this parainfluenza is identified, and also sometimes the metapneumovirus, then we can think is the pathogen. But if it is the rhinovirus or the adenovirus, that may be the commensal or just a dead bacteria or the previous infection could be.
Yes, Dr.
Just
Bahari.
one point, because Mihir mentioned a very important thing. Metapneumovirus is one of the most important cause of acute bronchiolitis nowadays, other than RSV, that we should all keep in our mind.
Absolutely, absolutely. I think the limitations of nasopharyngeal swab, Dr. Partho Haldar has already mentioned. So there are definitely, it can only detect targets that he has already mentioned. Now, bronchoalveolar lavage was done in this child, as Dr. Haldar has suggested, and you can see here streptopneumonia detected and also human metapneumovirus detected. So this is the thing that we wanted to highlight, that upper respiratory sample may be misleading sometimes. So what is the significance now? Is this any other points? I think we have discussed these points. It is a significance and whether it's an infection or colonization. Anybody want to add anything on this?
Yes, so whenever we are thinking about any biofire, the PCR panel for multiplex PCR, especially when we identify simultaneously multiple organisms, we have to be very thoughtful in that considering the test and also the interpreting the cost, both. So as already Dr. Chetri has mentioned, the cost is associated. So we have to very clear which group of patients we should do. So patients who are rapidly deteriorating, admitted patient or ICU, these are the group of patients we need, and we are not able to take some clinical decisions. So we need to be very clear when to test and how to interpret the report if there are multiple colonization. So it sometimes that we have discussed that the isolation does not always equate to the pathogenic organism. Even we isolate the single organism, this does not indicate that it's a single organism, maybe the other co-infection associated with it. So look at the patient, look at the symptomatology, take your decision, and also consider the report according to that. And also not all organisms are identified or included in this panel, so some organisms maybe are non-identified even with this based of this methodology available.
Just to add one point, it might be neither infection nor colonization. It might be just a past infection. That we have actually dead viruses, dead bacteria might be still there. We have had our patients with adenovirus, went home, readmitted after 4 weeks, and still, again biofire has been done. Adenovirus has been detected again, and all hell is actually breaking loose. We didn't manage to cure our child doctor. So you have to remember that the biofire is actually going to detect even dead viruses with their PCR signal still remaining there.
So the message is quite clear that ideally the lower respiratory sample should be taken, but it's not practically always possible to take the lower. So if we at all take the upper sample, then we must be cautious and judge the situation accordingly. So the upper respiratory panels like throat swab, nasopharyngeal and lower discordants we have already discussed. There are some molecular tests in respiratory tract infection like influenza AB, adeno, expert, express, TrueNat, biofire. There is a host which and when to test, interpretation, and does it guide antibiotic, very briefly to summarize from the experts. Because there are so many tests available, which one to select, your decision.
Yeah, so this first one, 2, 3 you have shown is that there's the single organism is identified, so it is the RT-PCR or the real-time PCR. But the last 2, 3 is the biofire, biofilm and the multiple organisms, the multiplex PCR. So if there is already the epidemiologically there are some epidemic of some organisms is already there, then we can choose the single organism, the simplex PCR. If it is not there, but the patient is sick or ICU patient, we can go to the multiplex PCR. So that's how we can decide. And also the upper respiratory and lower respiratory is very important. The patient is pneumonia, lower respiratory tract infection, try to take the sample from the lower respiratory tract. And interpretation, rhino as entero, as already have said that some viruses, if you take the from upper respiratory, like rhino, adenovirus, or sometimes the Boca virus, even the corona species, if they are identified from upper respiratory tract, that does not indicate that they are causing the lower respiratory tract infection. But otherwise, influenza, parainfluenza, metapneumo, they can be, if identified from upper respiratory tract, can be considered if the patient is acutely symptomatic in the lower respiratory tract. Dual pathogen, yes. So again, we have to consider these things in the dual pathogen. And if it is the lower respiratory sample and the bacterial overgrowth is associated with it, with the virus, then always we have to take in consideration is the pathogenic if it is from lower respiratory sample, and you have to continue the antibiotic if the this dual pathogen is identified, one is bacteria and one is virus.
So brief comment from Dr. Pahadi, then Haldar. Dr. Haldar.
Before I hand over the mic to Dr. Parthu for his comment, just a quick word about rhino and entero. We always get rhinovirus and enterovirus report together because they actually, have the same kind of nucleotide sequence that has been detected by the biofire. So it can be either rhinovirus or enterovirus. Doesn't mean that both rhino and entero is there, and you have to actually go by the patient's clinical symptomatology to detect whether it's rhinovirus or enterovirus. Doctor.
So the main problem is the cost. 10,000 rupees you are offering an investigation for a patient coming with a fever of 48 hours or 72 hours. So as Mihirda has mentioned, probably we are currently going through almost an epidemic-like situation of influenza. We are getting a lot of influenza cases. So depending upon the epidemiology, sometimes doing the single test like influenza or adeno can be helpful, but adenovirus can stay there for a long time, as Dr. Pahari has mentioned. So sending these tests, we should be very careful, and also the interpretation we should be very careful.
So thank you. I think we could just highlight a few aspects. Pneumonia is a never-ending topic, and there are so many possibilities. But I am grateful to the panelists for such highly knowledgeable input. And again, thank you all.
Thank you, Moderator Dr. Rajdeep Chaudhary, for nicely elaborating, and please sit down, nicely elaborating the important cases, both OPD and IPD. But as there is our learned panelists, moderator, and the audiences, so 2 or 3 or 4 questions may be allowed. We can't wait at the last of the session. So few of you are requested. If they have any questions, be quick. Please.
No.
Dr. Resmi. Dr. Resmi, please. No.
So thank you so much. We conclude the session.
The lung ultrasound that we use for pulmonary pathologies, but there are some limitations, especially in the viral pneumonia. The typical this consolidation we cannot see. There are limitations. There are different, maybe interstitial edema or just subpleural some consolidation, and even the deeper tissue we cannot penetrate through the lung ultrasound. If it is the perihilar lesion and the deeper tissue, so what is your take on that?
No, particularly because this is kind of upcoming modality, so it has been tried in particularly peripheral diseases like you can see pneumothorax, then consolidation, any kind of necrosis, but central lesions like lymph nodes, all those, so it will be very slightly difficult. So for central lesions, you better need CT or other invasive modality. And even if you see lymph nodes also, then necrosis you want to see. So in ultrasound, again, kind of delving deeper and see the necrosis might be difficult. So in future, we might see with kind of change in frequency of the probe, because it depends upon what frequency of probe you are using. So in future, so these modalities might come into play, but as of now, consolidation, pneumothorax. So any kind of thing where you can quickly take the decision for the treatment. So for that, you need to use the focus.
Thank you. So please proceed to the memento segment, and there is a place designated for giving the memento. Someone will lead you to that place, and thank you so much for such an enlightening session. The next session is session on pulmonary investigation, and the chairpersons are Dr. Sabyasachi Roy and Dr. Pranab Datta.
For the next session, we would welcome Dr. Sabyasachi Roy and Dr. Pranab Datta to please come onto the stage and moderate this session, please.
Thank you, Dr. Sabyasachi Roy, for inviting me to chair the session. Now, at the outset, I just want to say that we are holding and taking part in this program with a heavy heart. We know whatever happened, and we are all thriving, and everybody is trying to get looking for a justice. But academics must go on. So that's why the session is being held. But we must not lose focus from striving to achieve justice for our dear sister or daughter, whatever. So to start the session, I call upon Dr. Sanjukta De. He has a special interest in pulmonology and rare disorders in children. She has many publications. She is attached to PLS Hospital, one of the premier private hospitals in this part of the country. Dr. Sanjukta De, please. She will talk on investigations in allergic pulmonary disorders. Dr. Sanjukta De, please start.
Good morning, respected chairpersons, my colleagues, teachers, dear friends. I'm honored to be here. And today we will, for the next 15 minutes, I'd like to take you through investigations in allergy and the recent advances. Before we go on for recent advances, we need to revisit what has happened in the past, or what is still there in the past, and what is time tested before we go forward. So the main question I find from most of my colleagues is there any role of allergy testing in everyday practice? Are allergy tests needed at all? Or do they create more problems than they solve? Because most of the reports they find is uninterpretable. So we know that allergic diseases are mediated by type 1 hypersensitivity, and we have quite a few of these common diseases present in our population. So if we are doing pediatric practice, I think about 60 to 70% of the population we see will have some form of allergic disease or the other. And amongst them, allergic rhinitis and asthma are one of the commonest, including atopic dermatitis. So my journey is from a non-believer to a supporter, because when I was training, and we do not have much exposure in allergic diseases or allergy testing, so I would feel that is it necessary at all? So what do we gain from it? So to change my way of thought came the mystery of the Saturday visa. And what was the mystery? The mystery, I think I have mentioned this case in several other occasions, but I take the opportunity to mention it again. So when I was training in the UK, this patient used to be admitted every time on weekends. Every time the exacerbations would be on Saturday. And there was multiple episodes of hospital admissions with severe Vs before we decided what to do, because we were thinking of things like somatization, etc. But if it is somatization, why on a Saturday? Why on a weekend? Why not on a Monday, in the beginning of the school week, if he wanted to avoid school? So he never had attacks when he was away from home. When he was sent away from home, he was fine. The moment he came back, every Saturday he would have symptoms. So what we did a skin allergy test. At that time, that was what was available. And he was highly positive to horse dander. This child had a sibling, a sister, who went horse riding. And every Saturday, she would come back and hang up her clothes, her riding clothes. And after that, the child developed symptoms. So the main thing, the high positivity to horse dander, confirmed the fact that he was actually getting exposed to that only on Saturday. The moment that exposure was stopped, his acute exacerbations stopped as well. And from then on, I realized that allergy tests do have some reason as well. So if a mother comes to us with 2 children, these are 2 cases that I'm putting up from my own practice. It's very frequent in everyone's practice, I'm sure. And she says that she was fine in another city while she was in Bengal. She was fine. Now she has come to Kolkata. Both her children are allergy prone. So she comes with 2 of her kids, one of whom is 5-year-old with frequent coughs and colds, wanting to be a professional singer. And whenever he goes to his Guruji's house to practice, he comes back worse. He's having itchy rashes all over his body. And he also can't appreciate smells very well. And his breathlessness is on and off. And the other child, 9 years old, and she's very worried about the child because the child had an episode of what she suspects is anaphylaxis. And we have these mothers who read up on the internet, do the Google search, and then come to us. So then she knows about anaphylaxis. She knows it can be dangerous. She knows that it can kill her child. So this child went to a birthday party, was exposed to what she avoids eggs, but he was exposed, and he had swelling of his lips. So she is worried, and she comes to you, and we are at in a state where we don't know whether or not we should proceed and with what allergy test to proceed. So I will just try to demystify allergy tests for one and all just now. So allergy tests obviously test the IgE-mediated reactions, and they document the presence of an allergic test and try to find an offending allergen. So what we are trying to do is to find the offending allergen. And a positive allergy test will always not say that there is clinical allergy. It might say that allergy is likely to occur or the child is sensitized. So it is always not 1 + 1 = 2. So we have the in vitro test and the in vivo test. And amongst the in vivo tests, we have the skin prick test, which is time tested, which has been around for years, even more than the time I have practiced. And intradermal test, which we use less frequently, but it is used very effectively for drug allergies. And there are other tests that is less practiced, but is there, the bronchial provocation test, etc. And the main problem which arises is when we have the serum-specific IgE tests that are brought to us in our practice. The patient comes to you with a report, and you find that the child is allergic to mostly everything that is there in the list. And total IgE. Many a time we have been asked, total IgE, how important that is? I will come to that later. So why do we do an allergy test? We do an allergy test, as I have said from the history, because we want to establish or confirm the diagnosis. We want to find a cure, we find a solution. That is what the parents are coming to us for. They want us to give them a solution what to do with the children. So this is to find a solution, whether it could be medical or non-medical. Allergen avoidance also works. So if you actually pinpoint the actual allergen, then avoidance will work. So you have to pinpoint, you cannot really have a list which says that you have 20 allergies. It doesn't work. So the main key thing is a detailed physical examination and history. Without history and without a physical examination, we should not proceed for an allergy test. So this is just a skin prick test being done. I frequently do skin prick tests, and I can assure you it is not painful. It is epicutaneous, and the youngest I have done in my clinic is 4-year-old. Even they comply if they are told what it is all about. I have always found a way of telling them that now you were taken off chocolates, ice cream, etc. So if you let me do the test, maybe you can eat all of that. So usually they comply. You can do it at the back, but I usually do it on the forearms. And you should not do multiple allergens. You should be only doing those that are clinically you think to be significant from the history. Again, positive and negative is compared on the basis of a normal saline and histamine. And you have to record the exact reaction size in relation to the normal saline and histamine, and then do an interpretation. So some drugs interfere with the skin prick test. So many of my colleagues, when they send patients across, I request them to stop the antihistaminics for at least 5 days. Most of the children are on short-acting antihistaminics, but the long-acting ones should be stopped for longer periods. If a child has had omalizumab, then you can't do a skin allergy test for at least 6 months. If a child has had anaphylaxis, you're well advised not to do it, not for at least few months, unless you know what you're dealing with. And leukotriene modifiers do not have significant effect. Again, the limitation of doing the skin allergy test is that you have preferably do it in a hospital setting. In case you precipitate anaphylaxis, you should be able to deal with it. So there can be adverse reaction to skin tests. Thankfully, for about 16 years I've been practicing in Kolkata, I have not had a single case of anaphylaxis, though the tray is always ready. And usually it happens within half an hour of testing. So interpretation is also very important. It's not very difficult to do or learn, but the interpretation and in relation to what it is done, is very important. So there are false positive tests as well, and we have to advise the parents that skin prick tests sometimes pick up the sensitization. So the false positives also have to be recorded and advised accordingly and taken in correlation to history. But a negative is a negative, and that is very important. For a child, if you have skin prick test negative for a lot of food allergies, then you can actually tell the parent, go ahead, give the food to the child, there will be no problem. Because a negative test means it is negative. Positive will have two interpretations, true positive and false positive. So again, false positive results can happen due to too much volume being introduced. If there is dermographism, if your child has dermographism and predisposition to urticaria, you're well advised not to do a skin prick test because you might get false positive results. And false negative is if you have expired samples or you have low potency, the extracts. Extremes of age also don't give you good results. And if there is any other correlating condition that decreases the immune response. So basically, a skin prick test is very specific. If you are testing for aeroallergens, we did a study in our unit for aeroallergens in skin prick test. Positive means positive, and negatives are usually very good. It's when you test for food allergies that things become a bit confusing unless you relate it to history and unless you correlate the true positives versus the false positives. So coming back to our case, from whatever discussion we have had so far, it seems that we can do skin prick test for both the patients. But we have to also counsel the mother about false positives and sensitization. But what if the child does not cooperate? What if there is a loss of cross-reactivity? I'm coming to that. And can we distinguish how bad the allergy is? Can we distinguish between food intolerance versus true food allergy? No, sometimes no. And what are the cross-reactive carbohydrate determinants? So the fallacies of the skin prick test might hinder you from doing it in certain situations. Then comes the serum-specific test. So that's why the skin prick test, difficult to do, not everyone knows how to do it, everyone knows how to interpret it. So many of the pediatricians who are faced with the situations who may not have the opportunity to refer to somebody who can do the skin prick test, or the parents may not want to go somewhere else, resort to a serum-specific IG. And that's where the problem comes, because you have a lot of false positive results. So when you opt for serum-specific IG, they test for a huge panel. Not only you end up having lots of false positives, you might end up having a situation where you tell no to a lot of foods. So we want more information still. We need to have and come to a decision about what allergen to avoid. So instead of going through a top-down approach, we go to a bottom-up approach where we think in certain situations that we have to pinpoint the allergen no matter what, and it should not bring in the cross-reactivities or the false positives. So here we have an allergen source. Suppose we take an apple. That's the allergen source. Parts of the apple, that's also an allergen source. The pulp, the skin. Then we have the crude extract from which we are doing the skin prick test. And it contains a mixture of proteins and carbohydrates and glycoproteins and numerous other biomolecules. So what are we testing? We are testing for multiple things with the crude extract. When we come to the purified total extract, we have the minor allergens and the major allergens and the cross-reactive determinants all broken up. So we are using the purified extract to come to the final characterized protein where it's broken down into amino acid sequences. So we are using recombinant DNA technology, and we have broken down the apple from the apple allergen to its actual molecules, which are the major allergens and the sequence of those allergens. So here we are, moving from a crude homogenized whole extract to a purified protein extract to characterize protein components to the recombinant components. So we are moving from a crude situation to a highly specific situation. So the principle of component resolved diagnostic is from source to the molecule, and we break it down to the proteins. I will just draw your attention to the tropomycins here. And here is where the cross-reactivity comes in. So somebody who is reactive to dust mite can also react to shrimp. But is that important? Is that a cross-reactivity or a true allergy? So this is a genuine versus cross-reactive sensitization. So we have a cockroach, dust mite allergen, and shrimp.
Dr. Dey, your time is over. Please try to
2 minutes.
hurry.
So ultimately, we have some cross-reactivities here that might blur the picture. So it will tell you genuine versus cross-reactive sensitizations. So severity analysis, the rule of thumb is that if a protein is heat labile, it is not dangerous. If a protein is heat stable, it can lead to high probability of reactions. So if you have a peanut where you have broken it down to 3 components, one of which is highly heat stable, that will give you severe reactions. But if you have the CCD, which is the cross-reactive determinants, you will not get clinical reactions. So when you have a peanut allergy tested by component resolved diagnostics, you can tell the mother whether she can give peanut never, whether she can roast the peanut and give it to the child, or whether she should ignore the test. The child can have peanut in any form. So the false positive is completely eliminated. The same for egg. So if GALD1 is positive, it tells you it is heat stable and digestion stable, and this child can never have egg in any form. But if it's GALD5 positive, it indicates sensitization to the raw or semi-cooked egg portions, and the child can have cooked egg. So what was positive in a skin prick test, when you demystify it in component resolved diagnostic, you can actually tell the mother whether or not that food can be given in cooked form or never at all. So this is how So I'll end my talk here. So this is the new age diagnostic tool for allergy. So you can move from false positives to true positives and then to allergen avoidance. Thank you very much.
Thanks for Dr. Sanjukta Dey giving update on pediatric allergy and pulmonary diseases. And the audience may put forth that question in the tea break. We are waiting. We are waiting for another session, which is very interesting, with the galaxy of learned speakers, particularly Dr. Kabra and the others, and our moderator is Roshi Ranjan Das. This session is on recent updates on pulmonary investigations in the clinicians.
I request all the speakers and moderators to stick to the time very strictly, because we have some demonstration in this locality. So if we are late, the outstation faculties may miss their flight. So please stick to your time very strictly.
Dr. Roshi Ranjan Das, please come to the dais and start your session. And you please call upon the speakers.
Okay. Thank you so much, sir. So we'll have a panel discussion on recent updates in pulmonary investigation for the clinicians. And for this, I have with me my teacher, Professor S.K. Kabra from AIMS Delhi, Dr. Indranil Haldar, Sanjukta De ma'am, and Dr. Nandini. Please take your seats. So what we have planned, so we'll discuss 4 cases and different scenarios, focusing on the updates in pulmonary investigation. So this is a case-based discussion. At the end, if time permit, we can take the case. So shall we start? So coming to case 1. So this is Ramesh. He is not the brother of Suresh. He is a 9-year-old boy who presented with cough and hemoptysis for 14 days. The cough was acute onset with scanty sputum, foul smelling in late night. There is no relation to any food or position, no chest pain, breathing difficulty, fever or cyanosis, wheezing. And hemoptysis was small amount 2 times, no other site of bleeding, and he didn't receive any transfusion. There was no other significant history, and past history, there was no history of nebulization or any kind of recurrent respiratory symptoms. And when the child presented to us, he was afebrile and there was no tachypnea, heart rate was 82, but he was maintaining 96% saturation room air, though there was no distress, blood pressure was normal, and the rest of the examinations were normal. And in respiratory system, trachea was central, but there was dullness and percussion on right, 4th and 5th intercostal space. We decreased air entry and vocal parameters in that area. And this was the X-ray which the child was carrying. And as you can see, it is showing diffuse airspace opacity in the middle zone and that is silhouetting the cardiac border, so maybe a middle lobe consolidation. And he also had some blood investigation that was normal. Somebody did the TB workup because the child had cough and hemoptysis, that was normal. So with this, what are the clinical possibilities we have to think of? So my question to Dr. Nandini, so what will think in this scenario?
Thank you so much. First, I'd like to thank the organizations for giving me this opportunity. Now, on the right side, we have seen there is a consolidation, so this can be pneumonia. Since the history is 11 days with hemoptysis and low-grade fever, we can think of tuberculosis, and there can be some local pathology, like there can be a cyst, an abscess, or a fungal ball, and any other local infection can be thought of. Now, there can be some non-infectious causes even, because the fever is not on the higher grade and the infective markers are also within the normal range, only there is a little bit of neutrophilia. So, there can be an old foreign body, though in the history we have ruled out history of foreign body or any foul smelling sputum. So, there can also be a lung malformation, okay, that might have been missed previously because no investigation has been done previously. There can also be vascular malformation that has bled because there is hemoptysis, and though there is no history of chest injury, but there can be local airway trauma that has led to this hemoptysis.
Okay. So excellent. So regarding that foreign body, so sometimes what happens, big kids, so they will aspirate something, they will forget. So the foreign body will localize there and cause some infection. But here, only thing was that there was no history of recurrent infection, so that is a bit odd, but still you have to think because there is a localized kind of consolidation. Okay, thank you. So what next? So we have a kind of diffuse airspace opacity in the X-ray. We have not got anything, and clinical finding only showing some decreased air entry. So what is the next best investigation? So my question to Dr. Sanjuta ma'am.
We might consider a HRCT thorax over here. So that could give us an idea about whether or not that would give us an idea whether or not it is a pneumonia, whether it is any congenital malformation, or whether it is a cavitating lesion. Because in our country, the first thing that we think of in hemoptysis and low-grade fever, however be the presentation, we have to think of tuberculosis. We can also rule out whether or not, like we can see over here, that this looks like a cavitating lesion, and thick-walled, and it could be a necrotizing pneumonia with a cavitation or a cavitating lesion or a lung abscess. Doesn't particularly look like from here, from any malformation, just from the structural wall and the cavitation inside. There's also some lymph nodes. Some lymph nodes. And I would think that in this situation, I shouldn't go for the diagnosis right now, should I? No.
Yeah, so you are very correct, ma'am, because in addition also, as you correctly told, the child is also having some borderline saturation. So, like if you want to plan bronchoscopy also, you are not sure, the child may develop hypoxia. And we are also considering chest mass, so we want to see the extension. And tuberculosis also, we are keeping the possibility. So if you do the CECT chest, so that will show you the necrotizing lymph nodes. So at least beforehand, you can have some idea regarding the diagnosis. And here, I will tell the audience, so there is a hypoechoic mass here, and if you see, this is the right bronchus, and probably there is a communication. So the mass is communicating, so probably that's why the child is having hemoptysis. But we don't know what this mass is. So we'll not go into detail of the case because this is regarding the investigation. So now we'll focus on this CECT with virtual bronchoscopy. So normally what we do, so in any case, any kind of like when we are not sure, we do the CECT chest. But we should know, with CT chest, you can also see the lumen of the airway actually. So CT will show you the 3D image of your chest in the lungs, and also inside the airways like bronchoscopy you can see, and this method is known as CT virtual bronchoscopy. So what are the indications? So CT is an investigation. The problem is that there is chance of radiation exposure. And the small kids, they are highly sensitive to radiation. So ideally we should avoid CT unless there is a compelling situation. So the CT virtual bronchoscopy should be done in conditions where your flexible bronchoscope is contraindicated, or the parents are not giving consent, or the facility doesn't have the scope for this flexible bronchoscopy. In those cases, you should go for CT if the situation demands, and also for the evaluation of tracheal stenosis. And there are two types of images that is constructed by this CT virtual bronchoscopy. One is external rendering, the second one is the internal rendering. So as the name indicates, so external rendering will show you the outside of the airways. Okay, so it is a 3D image that I will show you. Internal rendering means that will show you the inside of the airway. So this internal rendering is known as the virtual bronchoscopy. So if you see this image, so this is showing you the 3D picture. So you can easily see the volume of the lungs, the structural kind of any deformity or any anatomical abnormality. You can see the airways or any kind of abnormal pathology there inside the parenchyma, so that you can see. But if you want to see the inside the airways, so then this picture you have to take. That is CT virtual bronchoscopy. So that is in the above panel, and the below panel are the findings from your flexible bronchoscopy. So this is the trachea in the flexible bronchoscopy. Here it is in the virtual bronchoscopy. Then this is carina, and here it is the carina. This is right bronchus left, here right and left. So almost it is, you can tell, matching, and any pathology you can easily detect in the virtual bronchoscopy. The only problem that you cannot take the sample or do the bronchoalveolar lavage. So let us discuss few of the cases regarding this CT virtual bronchoscopy. Case 1, this is 2-year-old child developed sudden onset of cough while playing. No fever or other complaint. On examination, child is tachypneic with normal saturation, but there is grossly decreased air entry on the left side of the chest. And these images were done. So now my question to Dr. Indranil. So can you please comment on the X-ray and the CT?
Okay. It is a sudden onset. Okay, sudden onset, always we should suspect a foreign body. But again, if you see the chest X-ray here, there is hyperinflation on the left hemithorax. And also the mediastinal shifting somewhat towards the right. So this tells us that with decreased air entry and hyperinflation in the chest X-ray, there may be some abnormality in the left side of the hemithorax. On the CT scan, you have seen an arrow there. You see the airways. There is a narrowing or something there in the airways on the CT scan. With the hyperinflation, it has herniated to the right side also. The left lungs has herniated to the right side also. And the lumen, you see, there is some opacity there. The arrow marking is there, and you can just see that there is some abnormality. So he has done a virtual bronchoscopy there, and you can see an obstruction in the lumen there, which shows that and confirms that there is something abnormality in the lumen, and we suspect a foreign body there. So the history typical, the X-ray also typical, the CT scan showing, and the virtual bronchoscopy here comes to the help to tell us there is something abnormality. For that we can do a bronchoscopy,
yes,
and then extract. See, the bronchoscopy shows the foreign body there, which is either vegetable foreign body or something like that, and in expert hand it can be extracted. For people who do a virtual this fiber optic scope, they are comfortable with the fiber optic scope, or people who are not comfortable may do a rigid scope to extract the foreign body.
Excellent, sir. So as you can see, so that is showing foreign body, and as sir rightly told, so if you are expert, you can extract the foreign body with the flexible scope also. So for that you have to use the forceps or dormia. Excellent, sir. So coming to case 2, so this is...
What you people do? Do you extract with the fiber optic scope, or you refer the
Sir,
case for a rigid
nowadays we are using in our setting actually. Unless there
we
is
medical people are more comfortable with the fiber optic scope and a dormia basket or some other device we can put in to extract it.
So I will request Cabra sir to share the sir's experience.
No, it depends on where you are working, what facility is available. If there is a definite history with this X-ray, you will straight away go for a
Yes,
bronchoscopy if the facility exists,
Yes,
and no need for going for a virtual CT.
Yes,
because there is a pre-test probability of a foreign body is very high. And if patient is stable, transport the patient to a place where it can be extracted either by a rigid or
Yes,
this thing. It depends on because it is a expert. So expertise of the person who is able to take it out. So if there is an expert person like Dr. Varinder Singh, you will send the patient directly to him and then he'll extract it.
Yes, sir.
If you are working in a district hospital, and there is no fiber optic bronchoscopist, then possibly it is safer to get it done by the pediatric surgeon or ENT person, whoever is doing. And if there is doubt, then only you will go for a CT scan.
Yes, sir. Thank you, sir. So, as sir told, so if you have the facility, you try. So, what we do, we try and we keep the pediatric surgeons in the backup because they have the rigid scope. So, in case you fail, so they will take over. So, you have to take all the precaution because if the foreign body is broken down or it dislodged to a distal portion, the child may land up in complications. So, you have to be very, very careful. Thank you, sir. So now, this case, a 1-year-old child who is having persistent stridor noted since day 2 of life. The stridor is biphasic with more during expiration and doesn't change with position. And on examination, child is having chest injuring, both suprasternal and subcostal retractions with mild decrease in air entry on the left, and there is normal saturation. So my question to Professor Kabra, sir. So what diagnosis we are thinking, and so how we should proceed in this case?
This 1-year-old early onset noisy breathing with biphasic, it suggests that it is intrathoracic compression or narrowing of the airway. And it may be tracheomalacia, tracheobronchomalacia or bronchomalacia.
Yes, sir.
So you will do, if facility exists, you will straightway go for a fiber optic bronchoscopy to see. Otherwise, you can go for a bronchoscopy, this CT scan. And you may say that CT scan may be done if there are 2-3 ways by which you can do it. One is that there is a dynamic CT scan, which is now upcoming, but associated with higher radiation risk if you are using a modified this thing. So you can go for a virtual bronchoscopy here or careful interpretation of the CT scan, whatever is available to you.
Yes, sir. Thank you so much, sir. So, as sir told, so there is some external compression, as you can easily see. So, this is the external rendering image. And in the virtual bronchoscopy, you can see the lumen is compromised also. So, that means, so if you corroborate, so there is some external compression that is compromising the lumen. But as sir told, so if the facility is available, you should go for bronchoscopy rather than going for the CT scan.
So, here you can see in the CT that there is a narrowing and the airway is compressed between the 2 major vessels, anteriorly and posteriorly.
Yes, sir. Yes, sir. Yeah, this one. Thank you, sir. So now coming to case 3, so we have a 10-year-old child with wheezing and history of respiratory papillomatosis. Wheezing decreased but still persisting after this treatment. He has a serious hypoxic episode in the last bronchoscopy, so CT virtual bronchoscopy was planned by the treating team. And these are the images. So now my question to Dr. Nandini. So what these images show?
So as per the discussion, you can follow these images. On the first image, you can see the arrow indicating a mass in between the 2 bronchi. Yes. Can you see?
This is the correct.
And following to the second image, there is a white arrow that is showing a mass sitting at the carina, where both the bronchi has divided. And the third picture, an arrow showing a mass that is a papilloma that is sitting on the carina, where on the right and left side you can see the right-left main bronchi.
Yes, sir. Excellent. So already this is a diagnosed case of papillomatosis. Now there is a growth. So of course that is persisting. So the child was subjected to further treatment. Thank you so much. So now coming to case 4, a 6-month-old child with recurrent wheezing with partial response to nebulization. No family or personal history of allergy. On examination, child is comfortable, no distress. There is monophonic wheeze. Small size bronchoscopy facility was not available at the center, so virtual bronchoscopy was planned. And these are the images that is available. So now my question to Sanjukta ma'am. So what are the pathology in these images?
What attracts my attention is that there is a aberrant right bronchus. It's a supracarinal bronchus rather than the normal one. So there is a segmentation of the right main bronchus into a lobe there. So that is possibly the cause which is leading to isolation of the upper part of the lung and leading to recurrent infections and wheezing.
Yes. So any child with wheezing that is not responding to nebulization, okay? So you have to think of any kind of airway malformation or malacia, whatever it may be. So in this case, that was detected. Thank you so much. Now coming to case 5, so we have an 11-year-old child who had acute encephalopathy syndrome and he was mechanically ventilated for a week and got discharged after 2 weeks of hospital stay. After 1 year, he presented with complaints of intermittent noisy breathing that was increasing with some febrile episodes. On examination, stridor was present and parents didn't give consent for bronchoscopy. So they thought that probably it will cause some problem because they were counseled. And so the treating team planned for CT virtual bronchoscopy to see where is the pathology. So now my question to Dr. Indranil. So what are the abnormality in these images?
So again, 11 years child, intubated, more than a week, and you can see that there is stenosis of the bronchus there, the arrow that has been showing. And this causes narrowing. You can see the 3 pictures of this CT scan that has been shown. One, the narrowing in the first picture. The second picture, also the indentation and the reconstruction that has been done, this basic narrowing and the wave-like structure, which requires treatment. Otherwise, the child will become more hypoxic. In fact, we have to do a bronchoscopy even if they don't give a consent, with proper taking care of the oxygenation. And ultimately, in pediatrics, what they do, I don't know, balloon dilatation is one that we normally advise for this. Balloon dilatation is, after the dilatation, normally they become normal with this. So this virtual bronchoscope help us to identify the place, the pathology, but we have to again do a bronchoscopy for a therapeutic intervention.
Yeah, fantastic. So what we did, so this is our case. So we tried bronchoscopy, but it was not allowing the smaller size scope. So we take ENT consultation. So they did the resection anastomosis. So the child is now perfectly fine.
Normally, do you do a balloon dilatation in those?
No, it was not possible because it was not allowing. You can do, sir, but depends upon the facility. So we send the child to ENT.
So this virtual bronchoscopy or CT scan tells you about what is the extent.
Yes, sir.
If it is only a thin membranous, then possibly some balloon dilatation can be done. If there is it is a very significant extent or there is a significant fibrosis, then as you did, either there may be a need for a end-to-end anastomosis, or there is a possibility of using some other interventions, including.
So it was a bit long, so that's why that was rejected and anastomized. Thank you, sir. So this is a 7-year-old child with history of Guillain-Barré syndrome, required prolonged mechanical ventilation and finally underwent tracheostomy. He was planned for decannulation. Before that, the airway was need to be checked for patency. So again, CT virtual bronchoscopy done. So my question to Professor Cabra. So sir, your comments on these images.
As I said, CT scan tells us that what is the extent, and depending on this thing, if it is a localized, very small, then possibly intervention bronchoscopies can do some interventions. But if there is so much of a fibrosis and significant extent, then possibly our ENT colleagues or cardiothoracic surgeons may be required to do some intervention.
Yes, sir. Thank you, sir. So there is a membrane formation. So naturally, you cannot decannulate this child and take the help of your ENT or CTVS people, whatever it may be. Yes. Yeah. So what we learned from this, so CT virtual bronchoscopy allows visualization. It gives you a 3D picture of the external as well as internal part of the airways, indication when the bronchoscopy is contraindicated, and mind it, there is a high radiation exposure, so it should not be routinely used, and in a difficult situation when the facility is not available, only you have to use this one. So coming to case 2, so this is Jasmine, 11-year-old girl, visited you following a recent hospital admission with a severe asthma exacerbation, had one previous severe asthma exacerbation 1 year back. Father is a smoker and they stay in a rented house near to the national highway. On asking the treatment history, she is taking ICS Delhi, Saba SOS and Montelukast Delhi. Spirometry shows FEV1 by ABC is 0.9. So this is just at the, you can tell, lower end of normal. On examination, child is thin build, coughs intermittently without any wheezing or chest pain. Compliance is good as per the parents. You have heard about an objective test of airway inflammation, that is FeNO, and wonder if this could be useful here. So my question to Professor Cabra. So why this FeNO and what is the physiological basis we use in children with asthma, sir?
Yeah, FeNO indicates that there is some airway inflammation and there is an increased production of NO. And if you can identify it, it only suggests that there is some inflammation. But there are multiple causes of inflammation, increase FeNO, and there are some causes which will decrease this thing, even if there is a this thing. So that's why it is not very specific and cannot be used for making a diagnosis. And even there are doubts about whether it can be used for monitoring this treatment. But it can definitely be used to see if a patient is you have documented that there is a asthma and you want to start him on inhaled steroids. Whether the child is taking it properly, then it should show some decrease in the FeNO if it is a IgE mediated or inflammation because of IgE or eosinophilic inflammation. If this is still high, then you have to check whether the child is really taking it or inhalation is appropriate.
Yes, sir. Thank
But
you, sir.
you cannot use it in isolation if it is raised that it is asthma, and neither you can say that asthma is ruled out if it is low.
Yes, sir. Thank you, sir. So basically in difficult cases, when you are not able to know, you should use it, and it only indicate eosinophilic inflammation. So if the child is having neutrophilic asthma, it cannot kind of diagnose. It may be low, falsely low. So you have to be carefully choose your patients. So what machines are available and how to test, sir? Question to you.
So there are two principles of doing a FeNO or NO from the airway. One is, as you are seeing it, and this is ELISA-based method, and another is a chemilucent-based method. That is considered to be the gold standard. But that requires more setup, while this is a handheld, and it may give a fairly good idea about the airway NO.
Yes, sir. Thank you, sir. So different instruments are available. You have to use a specific one. Almost they are equal. And there are incentive kind of images available. So child will see and he will blow. Basically, you have to exhale because you are measuring the exhale nitric oxide concentration. So child should not blow very fast or very slow. So they can see that like sun is kind of going. So they will follow that and blow accordingly so that the sun is moving from this end to that end like that. So what is the role of FeNO in asthma? Already sir has told. So my question to Dr. Indranil.
Okay. So FeNO is basically a non-invasive and a very easy test for inflammation of the airway in that way. And asthma, as we know, is an inflammatory disease. So when we want to measure the inflammation of the airway, what is the invasive tool? That is induced sputum, or you can do a bronchoscopy and do the lavage and see. But a non-invasive test is an FeNO. So what FeNO gives us, it suggests that whether there is eosinophilic inflammation going on in the airway, and it is eosinophil that produces the NO. So one, it tells us about the phenotype of the asthma, whether it is eosinophilic asthma or not, because there are other asthmas which is non-eosinophilic. Second, in asthma patient, you have a patient who comes to you with respiratory symptom, for example, a cough, and you see a high FeNO in pediatric, it is more than 35. You see a high FeNO, you know that this patient may be steroid sensitive because there is eosinophilic inflammation going on. With 20 and 35 in between this FeNO, you have to take your clinical decision to start inhaled corticosteroid or not. So again, a patient that is of respiratory symptom, that is cough. Again, a patient who is diagnosed as asthma on inhaled corticosteroid, if you see a still high FeNO, that means the patient is not taking the inhaled medication in the proper way. You have to find it out, and you have to monitor whether the patient is taking the inhaled medication, and if the FeNO comes down, we know that probably the patient now is taking the inhaled corticosteroid. Another very important thing where we use FeNO is stepping up and stepping down. Patient of asthma, on FeNO, the FeNO has come down below 20. Now we can step down our inhaled corticosteroid or step down according to the GINA guidelines. And if you see a high FeNO and the patient compliance is very good, we know we have to step up the treatment.
Yes.
Coming to the diagnosis of asthma, you cannot stamp a patient as asthma even if you have a high FeNO, because this asthma may not be, this high FeNO may be because of some other reason, or even a low FeNO, you cannot negate that this patient is not asthma because it is not eosinophilic asthma, maybe that. So these are something which comes in our mind, but it's a very good, easy, non-invasive tool for monitoring of asthma.
Yes, thank you, sir. So can FINO be used to diagnose asthma? So already sir has elaborated. Is it more accurate than spirometry or peak flow? So if you compare this FINO with spirometry and that, so what is the sensitivity and specificity? So my question to Dr. Nandini, what is your take on this? Whether it is better or worse or equal, something like that?
So can we have the table? It has the sensitivity, specificity, negative predictive value and positive predictive value. But the quality of evidence is high. So it's see that FENO, the sensitivity is 57% higher than all above. Specificity is 87% higher than all above. Negative predictive value is 49%. That is not that good. And positive predictive value is again high. So what we can see that a raised FeNO level is supportive of asthma but not definitive. Again, FeNO has a high diagnostic accuracy compared to other tests. So that has been nicely explained by sir.
Yes.
So
if it is high, so you can think, but if it is low,
think
you cannot
it.
tell that
We
whether
can't
it is
say
asthma
that, we
or
can't
not.
rule it out.
Yeah, yeah. Yes, yes,
Just
ma'am.
a comment, like FeNO, as we have discussed, it's a measure of the eosinophilic infiltration of the lungs. So allergic asthma, it's a good way of monitoring allergic asthma and compliance to therapy, and sometimes even telling the parents that this child needs an allergy test, and also finding out whether they are adhering to allergen avoidance. Because milk allergy is one thing that can present with eosinophilic inflammation of the airways as well as with GI symptoms. And we have found that FeNO is useful in that. And I think peak flow is very, very underrepresented
So that is
in
not
home
recommended
monitoring.
nowadays. So this is a kind of, yes ma'am. So what ma'am is telling, so if your FeNO is high, so you have to try to find out the allergen by doing some skin purity test or something like that. Okay. So can FeNO be used to monitor response to treatment and tailor asthma? Already discussed. So my question to Professor Kabras. So any study, any evidence kind of thing?
As we have already discussed that it can be used to document whether there is an airway inflammation, but whether it can be one of the monitoring tool in isolation is doubtful. Because you have to take in consideration the clinical features along with your pulmonary function, and FeNO may be one of the tool, but it may not affect the your interventions and other things very in a great extent.
Yes, sir. Thank you. So what sir is telling, always asthma is a clinical diagnosis. So in very, very rare cases, you employ the investigation. You should not, like child has come, directly start doing FeNO and tell that asthma or no asthma. So still it is a clinical diagnosis. Yeah. Thank you, sir. So this is another study. So that is also the same thing. So again, doubtful role of FeNO. So revisiting our case, Jasmine, her FeNO was 55. This result enabled an honest conversation about ICS use because they were telling that they are using, but here FeNO is high. So she admitted that she has lost her MDI. So we restarted, and father was advised to quit smoking and change house because they were staying in a rented house. And on follow-up, she was perfectly fine and her FeNO was 14 and her symptoms were controlled. So lessons learned. Current evidence do not support routine use of FeNO in asthma diagnosis and management, and we need further data. So with this, let us move to case 3. This is Ramesh, a 9-year-old boy, cough since 6 months, fever since 6 months. Sorry, I think 6 months, it is not 9 years. This is the course. The child is having recurrent fever and cough. He was managed like case of recurrent pneumonia, but he was not gaining weight. So there was, the weight was low, and before coming to us, he was tested and hemoglobin was low, for which he received 2 times transfusion. And he also had hepatosplenomegaly, for which he was initially referred to pediatric hematology unit because the child required this transfusion and organomegaly. There was no other significant history. Mother actually died because of some unknown illness. Examination, child was stable and pallor was present. He was malnourished. There was dull percussion note on right infraclavicular and mammary area, decreased air entry, no added sound, and there was organomegaly. So what are the differential diagnoses? My question to Dr. Nandini.
Yeah, so we can see that there is a long history, 6-month history, and there is poor weight gain, and there are, has been treated as recurrent episodes of pneumonia, received 2 units of blood transfusion, visited the oncology department. So first what comes to my mind is a neoplastic lung mass. Okay, so needs further evaluation in that line. The other things, it can be a case of disseminated tuberculosis that can lead to all these kind of presentation. And from the family history and also following this course, it can be a case of immunodeficiency that can be since presenting
Maybe
at 9,
retro,
18
something
to
like that,
primary,
we don't
or
know, yes.
yeah, it can be because of some infection leading to secondary immunodeficiency. There can also be some congenital lung malformation that has been leading to this recurrent infection.
Maybe recurrently infected, but the child is not gaining weight. Okay, thank you so much. And these were the investigation. Hemoglobin was low and albumin was low. Retro was negative in this case. These are the chest X-ray. So my question to Sanjukta ma'am. So what you are finding in this X-ray?
Finding is there is a consolidation in the right lung.
Yes.
And quite extensive consolidation involving the right upper and middle lobe. There seems to be areas of breakdown as well within the consolidation. So there is, whether there is cavitation or necrosis, we need a CT
So
scan.
consolidation with some breakdown. Thank you ma'am. And these are the CT scans. So Dr. Indranil, can you please comment?
So it appears just a non-homogeneous structure with some, it may be a consolidation with some breakdown, or you may tell even a mass-like structure that is there.
Yes, yes.
So,
maybe a necrotizing pneumonia, something like
necrotizing
that.
pneumonia, or it has become solidification type of thing. So a mass, a necrotizing pneumonia with variegated appearance is some of the differentials that we have to think of.
And if you see the carina in that, so is it looking normal or slightly something like that in that second axial, this one?
What do you tell?
That carina you are seeing, so right and left, right bronchus, any compression, something, or it is normal?
It is, yes. There is
Slight
some compression.
maybe it is
there
pushing
is some
something
compression.
like
In
that.
fact, there are some different differentials that should be coming. In fact, the consolidation with breakdown, mass also, malignancies and everything can be the differentials of this one.
Very correct, very correct. So, initially the child was in pediatric hematology unit. They did biopsy of the mass, ultrasound guided. AB was negative, CB NAT GFR negative, but it showed necrotizing granulomatous inflammation. So what next? My question to Professor Kabra sir. AB is negative, necrotizing.
So as you are seeing, X-ray showing some initially upper lobe, then involving the middle lobe, and CT scan is showing a fluid bronchogram. So if there was a fluid bronchogram, it suggests that it is a pulmonary involvement. And in such a situation, the commonest would be whether it is a TB or aspergillus. So we should be obtaining some, if biopsy is not suggestive, then we can do a bronchoscopy to obtain a ball. And as it has already been pointed out, that middle lobe is showing some issues. So middle lobe is probably having a obstruction.
Yes, sir.
You can take a ball as well as a brush or some transbronchial biopsy to document whether it is a really TB or some other infection.
Yes, sir. Thank you, sir. So there is a growth inside, so in the bronchoscopy, and we took the ball actually. So ball was positive, TB was detected, it was rifampicin sensitive. So the diagnosis was disseminated tuberculosis. The child was started on ATT, and we started prednisolone because the endobronchial growth was there to prevent future complications. And X-ray at completion was entirely normal, as you can see. And repeat bronchoscopy we did, you can see the growth is no more there. So lesson learned, try to elicit TB microbiologically by all possible means. So if you are not getting, better to bronchoscopy, take the samples rather than starting the empirical ATT. And if there is endobronchial tuberculosis, so give steroid and do a follow-up bronchoscopy to see whether there is a stenosis or obstruction. If that is there, you have to intervene early. So now coming to the last
in
case.
resource-limited settings where we don't have a bronchoscope, induced sputum also probably could have faced some of this.
6 months childs are small, but big kid you can do.
6 months.
Even stool, CVNAT you can do, sir can tell. So there are studies, but that is in the preliminary stage. Yeah. So coming to last case, case 4. This is Sachin, 5-year-old boy, persistent dry cough since 6 months. Cough is intermittent dry with some increase at night, no activity limitation or wheezing or breathlessness, no seasonal change, no family history of allergy. He has taken almost all treatment including nebulization but no relief. Spirometry normal. Somebody has sent the child to psychologist. Again, that is normal also. So what next? Is there any objective test to rule out asthma in this 5-year-old kid? My question to Professor Cabre.
Yeah, one is that for making a diagnosis of asthma, apart from, you will suspect it based on the clinical features, family history, and other contributory factors with reversibility. And in such a situation, 5-year-old spirometry may be possible, sometimes may be difficult. Alternative pulmonary function tests like impulse oscillometry and other tests can be performed.
Yes, sir.
And as you can see, even you can perform it about 2 or 2.5 years of age if the child is cooperative, and it can be performed on the tidal breathing.
Yes,
that
sir.
is the advantage of impulse oscillometry.
Yes, sir. So in spirometry, you have to forcefully exhale, but in impulse oximetry, it's normal tidal breathing. Okay. And these are the principles. So there are, I will request sir to elaborate. Okay. So basically, so there are sounds. So during tidal breathing, so sound wave, you can see there is a speaker that will kind of superimpose the sound on the tidal breathing, and that will be detected, and it will be measured by, there is a transducer you can see here. So it will detect the pressure change and the flow. So that will be used to determine the lung mechanics. And these are the different waves.
So you might have heard of FOT as well as impulse oscillometry. Both have the same principle and same results. Just those who have not seen, it is something like a physiological basis of identifying the resistance.
Yes,
resistance of the airway, and what is the reactance, that whatever, if you are passing some wave through a pipe, wind pipe or say airways, then there will be a resistance as well as reactance of the wall.
Okay, thank you, sir. So these are the different types of waves that is produced, and so depending upon whether you are using I wave, so square wave pattern, if it is FOT, then sinusoidal wave, something like that. So there are different terminologies. Sir was telling like resistance, reactance. So let us try to understand those catchy terms, because that is very, very important in relation to the lung mechanics. So my question to Dr. Indranil, so please explain us what is this impedance, reactance, and
okay, we have only 2 minutes left and another 3 questions practically. I will be very short. So the basic principle is we are using frequencies, sound wave frequency. And the basic principle is that the lower the frequency, the more distance it will be traveled. So in tidal breathing, we are giving some sort of sound waves which are different frequency from 5 Hertz to 25 Hertz. So what is important is that 5 Hertz, just think of the All India radio, it is 1 megahertz, and the FM radio 106 megahertz. 106 megahertz is only limited to a city, and 1 megahertz all over the country. Smaller the frequency, lower the frequency, it travels through longer distance. So 5 Hertz travels to whole of the distance, 20 Hertz travels to less distance. So next comes the terminology. We want to measure the total impedance. It is all the collective opposing forces. What is impedance? It is the sum of the resistance and the reactance. Resistance, we know the opposing forces, the friction, and what amount of energy is required to traverse the sound wave, to traverse the full pathway. And what is the reactance? It is the sum of the inertance and the compliance. Inertance means the air that is there. If the air is dense, more inertance, and the compliance is basically the elasticity. So it measures the resistance directly. And in asthma, what we require, we have to document variable airflow limitation. So this is an objective tool. We see the resistance, which is important, and we give bronchodilator, and we see if the resistance has decreased or not. It is more sensitive because it measures the resistance directly. So now coming, the 5 Hertz versus the 20 Hertz. 5 Hertz travels both through the larger and the smaller airways. So the definition of smaller airways means less than 2 millimeter in, and it starts from the 7th division of the bronchial divisions. So more than 7 division, less than 2 millimeter are the smaller airways. So 5 Hertz measured both the large and the smaller airways. 20 Hertz measured only the larger airways. So the concept of small airway, when it comes to asthma, the concept of small airway, if we do R20 minus R5, that means R5 minus R20, we get the resistance of the smaller airways. So the full airway resistance, the large airway resistance, and the difference between the R5 minus 120 gives us the small airway resistance. Now this curve, it's a resistance and the reactance curve, X5, which is more negative, because we know you see this curve which is moving up from X5 towards and crosses at 0, which is called the F-res. The F-res means the more negative smaller airways, that is the capacitive dominance to inertive dominance goes in, and it is the point as 0. Once the wave, the frequency wave moves towards the right, means that the X5 becomes more negative and the AX becomes more. So it is present, more the obstruction, more the resistance, the AX increases. And it is a very sensitive tool to determine whether we are having bronchodilator reversibility, or if we are dealing with a patient of asthma and treating it, the patient is recovering better.
So very well elaborated. I'll just summarize. So this graph is very important to understand. So these are the frequency with which the sound waves are produced. So this is the area of reactance. So reactance is normally negative. So it comes down, that means there is obstruction. Resistance is positive. If it goes up, then there is more obstruction. So you have to see the graph to know the pathology basically. So quickly we'll skip this. So these are the reference range. So for R5 it should be less than 150%, R20 less than 150%, and the X5 it should be higher than X5 predicted. So this is the normal kind of, you can tell this impulse oscillometry. So I'll request Kabra sir to explain this pathology. So you can detect both obstructive and restrictive lung disease. So in peripheral and central obstruction, both the R5 will increase, but in peripheral R20 will be normal. Okay. So R5 minus R20 will tell you the peripheral, so that will be increased in case of your peripheral obstruction. But in central it will be normal. And in restrictive R5, R20 is normal, but the area of reactance and resonance frequency will increase. So they will become more negative actually. So limitation, still some cooperation is needed. Reference values are not generated, so we cannot generalize it. So it is in the, you can tell in the infant stage in the pulmonary function testing. And already this we have discussed. So what happened in our case? If you see, the R5 is 145%, and after bronchodilator, there was a minus 42% decrease. So resistance decrease means there was an obstruction which is getting better. And if you see area of reactance, it is becoming more negative. Okay? So that means that is also getting better. So bronchodilator reversibility is defined as R5 changed by minus 40, here it is minus 42. Area of reactance by minus 80, it is minus 62. So in this child, there was a significant bronchodilator response. So that tells that probably this child was suffering from asthma, then he was started on treatment and he remained perfectly fine. So what lessons learned from this case? Oscillometry, a simple effort independent PFT, can be done in small children and more sensitivity than spirometry, asthma diagnosis and determining treatment response, but it has limited utility in other diseases. But mind it, it is in the infancy stage because we don't have the reference range as per the population. So you have to send the child to expert for interpretation. So with this we finish, we could finish all the cases. So I am very much thankful to my esteemed panelists and the excellent audience for their cooperation, and it was a very fruitful discussion. So if there is in doubt, we can take at the end. Thank you so much.
Thank you, Dr. Dash, and all the panelists for the beautiful discussion, especially focusing on relatively newer modalities. We have to get some time to get used to all these new things. Yes. And just one thing, though the time is less, we have learned about MDCT and virtual bronchoscopy, but as Dr. Dash has already said, it needs a lot of radiation. So we are hoping that a day will come when MRI will also help us to do a virtual bronchoscopy. So thank you once again to all the panelists and Dr. Dash. Thank you.
Thank you so. Thank you, Dr. Dash, and all the panelists, Professor Kabra, for an excellent discussion. Next, we move on for a very important session, that is inauguration ceremony. And I request Dr. Arun Mangalik to start the proceedings.
wait for 30 seconds while the photography is being done. Thank you so much. We are going straight to the inauguration part now. May I request the dignitaries to be on the dais, please? May I request NRC incoming chairman, Dr. Rawat, to please come up. Our chief guest, Dr. Kabra, please. You had to take the trouble to go back and come again. May I request Dr. Shubhashish Roy to please be here. Dr. Pallab Chatterjee. Dr. Shantanu Dev, the Vice President East Zone, CIAP, please come on the dais. Dr. Shopon Rai, incoming President, West Bengal Academy of Pediatrics, please come on the dais. And may I request Dr. Varinder Singh to please, senior faculty from Delhi, Lady Hardinge Medical College. And Dr. Shantanu Bhakto, please come here, sir. We'll have a very short inauguration, please. Tibosh. Chair like this. Is Dr. Mihi Sharkar here? Yeah, please. Secretary, West Bengal Academy of Pediatrics. So we'll have a very short inauguration. And before we start, may I request everybody to have a 1 minute silence in memory of the departed soul we all know about, Oberoi, in memory of Oberoi. 1 minute silence, please. Thank you. Please take your seats. So, as part of this inauguration, I'd like to welcome all of you. Despite the upheavals we are facing in this city, we are able to continue with academics because that is one thing we must not forget. We cannot allow that to take a back seat despite all the problems we are facing. So, we are having this annual meet, and I'm really grateful that we could have so many faculties, and we have had almost a full audience since morning. So we welcome you all to this gathering, and I'd now request our chief guest, Dr. Kabra, to please say a few words. We'll have something very short.
Respected people on the dais, it gives me a great pleasure to come to visit to a city of joy, because I feel I belong to Kolkata. My relation with Kolkata is for 6 decades, when my parents and my family stayed here, and they moved in 1987. I congratulate the team. I am seeing it for last 2 decades at least. Every year I come here, and they are organizing such a beautiful CMEs, improving our knowledge and providing me an opportunity to learn more and more about pediatric respiratory diseases. I am very thankful to all, and I wish all of you will enjoy this CME in Pulmocon.
Thank you, sir, very much for your short but crisp message. And we must remember that it's very difficult to complete a CME without you. So that's the reason why you are here every year. So may I request Dr. Rawat to please give us a message.
Thank you very much, and I bring greeting from IIP National Respiratory Chapter, respected dignitaries on the dais and all the delegates who are present here. IIP NRC is very passionate about academics, and I am very happy to see that West Bengal Chapter of Pediatric Pulmonology is trying to maintain this tradition that since past 20 years they are organizing this pediatric pulmonology CME every year. And again, it speaks volumes regarding their commitments for such turbulent times in their city. And they decided to organize and maintain this tradition. kudos to all, particularly Dr. Subhashish and Dr. Pallab, for their dedication toward academics. My best wishes, and I again promise from the chapter that whatever help they need to carry on this tradition, IP National Chapter is ready to give them help for coming times. Thank you very much, and again, best wishes.
Thank you so much, sir. Meanwhile, we have with us Dr. Kaushik Chaki, who represents West Bengal Doctors Forum, who's been doing a yeoman's job fighting on behalf of Oberoi or Tiloktama, whatever name we call. And may I request Dr. Chaki to come over, because West Bengal Pediatric Pulmonology Chapter has decided to donate a small amount to his efforts. Well, this unfortunately is only a replica. So now we can have the lamp lighting. May I request all the dignitaries to take a bit more trouble and come down. May I request people of the dais to please join? Aurubda, Bhupida, Atul, Gautam sir. Thank you so much. So we have now come to the end of the short inauguration ceremony. May I request Dr. Subhashish Rai to give the vote of thanks.
So, good afternoon, and thanks to all of you who have gathered in this program despite of having a heavy heart. I am really thankful to NRC, Dr. Rawat, Professor Varinder Singh, Professor Kabra, Dr. Bharat Reddy, Shantanu Dev, and all outstation faculties who have come, taken your time to make the program successful. I am really thankful to all the delegates who have attended. At exactly 9:30, I have seen not less than 100 delegates who are sitting inside the hall, without whom the program cannot be successful. I am really thankful to Pallab and Orunda and Gautamda for their very valuable suggestions for making the program successful. Thankful to Grand Hotel for giving us the venue and making all the background services time to time and meticulously. Thankful to all the sponsors, CIPLA, Lupin, and all other people who are there giving us some amount of financial help, which is making the program successful. And I am over and above, I am thankful to all the senior people who have gathered here and making the program successful. Thank you all, and thanks, and enjoy the program in the remaining part of the program. Thank you so much.
I think for the benefit of time, we would continue with the sessions, and tea is being served outside, so if anybody really wants to miss Dr. Varinder's talk and go for a tea break, then they are welcome. So I would invite Dr. Sutapa Ganguly and Dr. Madhusmita Sengupta to please come onto the dais and welcome the session. The first talk will be on drug-resistant tuberculosis by Dr. Varinder Singh. He's gone for a short break, so he's coming.
Hello. Should I start? So good afternoon all, and thanks to the organizers for the invite. Now, emergence of drug-resistant tuberculosis is a very important and high-risk global health issues, and alarming reports are generating every day from every corner of the world. And there is a threat of disruption of the National Tuberculosis Elimination Program because of this. So the best person to speak on the diagnostic approach and the management of drug-resistant tuberculosis is none other than Dr. Varinder Singh, who is the Professor Director of Lady Hardinge Medical College, Delhi, and he is also the lead of the Pediatric Tuberculosis Unit of under the control of National Tuberculosis Elimination Program. Now, I'll request Dr. Singh to take the podium.
Good morning. I'm sorry if I'm holding you from your tea. I don't know how much drug resistance TB is going to interest you, but if you choose that tea over the DRTB, I would understand. At the outset, I'm very thankful to the organizers for having called me to attend this meeting. Quickly getting onto the business is recent updates. So recent updates is something which is a very vague term to me, because it depends, it's very relative. It depends on where you are starting from. So if you have not updated yourself for 10 years, or something which is dated for someone else, maybe a recent update for you. So that's very hard when you get a topic like this. So I decided to bring bits and pieces from all over. So what I'll be talking about in 15 minutes is the diagnostic philosophy, the current regimen, and the future neo-regimens. So the first question always is, when we say DRTB, can we identify DRTB? What are the footprints? When do you think it is DRTB? So this beautiful study, which is little old, showed us very clearly that there is nothing which tells you that it is a drug sensitive or a drug resistant TB. That's simply because body does not differentiate between an MTB which is drug resistant or drug sensitive. For it, it is a Mycobacterium tuberculosis. So the clinical spectrum is no different. The children and adolescent can present with hilar, mediastinal lymphadenopathy segment, just like what you see in drug-sensitive TB. There may not be any different, neither would it be difference between an extrapulmonary involvement versus a pulmonary involvement. It's not necessarily an adult type of cavitary disease, which we often have an impression that drug-resistant TB means extensive cavitary disease. It may happen, but it is not essential. Even in adults, where it has been said that cavitary lesions are reflective, that's because there is delayed therapy and they go into an extension. If you look at outbreaks within the adults, where the disease has just started, there is no difference. They would also have lymphadenopathy, they would have a non-cavitary consolidation. So there is no clinical picture or an involvement or a radiological picture which can tell you this is drug sensitive or drug resistant. We have had a 1 month-old child with a lymphadenopathy or a miliary which turned out to be drug resistant TB, never ever exposed to therapy, because children often have transmitted drug resistance. So suffices to say, you can't make a clinical diagnosis of drug resistance. It has to be a drug resistance is something, sorry about that. Never mind. So it is something which has led to a change in our, my apologies for this mix-up here, but I'll explain that the philosophy has changed to what we call as a universal DST. You suspect that every child, every person who has TB may have drug resistance, and you want to know it upfront. The advantage of this approach over the earlier approach, which was targeted to depending on clinical failures, is that the drug resistance TB, if it is given first line therapy, it further leads to amplification of resistance. So if you can upfront recognize, not only you decrease the morbidity for an individual, you also decrease the public health impact of that, because you are not, and it's a communicable disease, even children can spread it. So therefore you want to check everyone. So what is this universal DST? When we say universal DST, it means upfront testing at least for RIF resistance as a first step. So universal means access of a rapid DST to all presumptive TB. So universal intent, no one should be left. It does not mean to all drugs. So we often mean universal would mean for every anti-TB drug the sensitivity. No, we are not saying that. By universal we are saying nobody. It's not a selective, as we were doing in the past, that drug failure relapses were being tested for drug resistance. Universally, every individual who is a likely case of TB, you investigate for drug resistance right up front. And currently, what is available to us is a RIF resistance, because we have molecular diagnosis available for it, which is rapid. So that's the biggest important thing which has changed. The other thing is that if you have RIF resistance, the current therapy would also depend on whether you have additional resistance to fluoroquinolone, and if you are RIF sensitive, but you may have INH resistance if you are a failure. So the other two things you look at is fluoroquinolone and INH in RRTB or non-RRTB. Taking away RIF resistance upfront would lead to decrease in the amplification of resistance. So what are the tests which are available? Two tests which you are familiar with are TrueNat and Expert. So Expert RIF is something which is a cartridge-based test which is made in USA, and TrueNat is made in India, and this is a chip-based test. Both are rapid tests. You can get answer in about 90 minutes to 2 hours. And remember, Gene Expert and TrueNat are just DNA extraction and amplification and detection platforms. So TrueNat was also used for COVID. They can be, it depends on what probe you are using. You can use any of these platforms. So the complete test would be TrueNat MTB RIF or Expert MTB RIF. Just saying Expert as we say or TrueNat means nothing. That's a testing platform. So that's one distinction which becomes relevant, because there are more than one test available with Expert. There may be more than one test in future available with TrueNat, and therefore just writing TrueNat, your lab will do whatever they wish to. The third test which is available is a Heinz test, which is from Germany. It is also called line probe assay. These are two types. This can be on first line drugs, which is HNR. It could be for second line drugs. The difference between a line probe assay or Heinz test versus the other two tests which I talked to you earlier is that the first two tests are rapid, they're single tests, and their limit of detection is about 100 bacilli, 120 as they say, as a round figure. But for line probe assay, you need 10,000 bacilli per ml. That means only on smear positive specimen, this can be tested. While TrueNat and GeneXpert has been exploited to use gastric aspirate and other specimen, LPA has not been used for that. So that means in pediatrics, the relative role of LPA would be less because we do not have as many smear positive, but we do have smear positive in a peri-adolescent age group. It's not that we don't see it, but a lot of primary TB may not be smear positive as we know, and that is where LPA would not work. But there also it comes handy. You send culture, so culture will take 4 to 6 weeks. If you want sensitivity phenotypically, that means you are delayed by another 6 weeks. But once you have culture, there is no limitation of number of bacilli which are available to you. Then you can put an LP on that culture and get a, so these molecular methods can help even in pediatric possibacillary disease if you have an MGI culture positivity. So that's how it is important for us to know. So these are the tests which have been approved by the national program. There are some more tests. One of them is GeneXpert Ultra, which is approved by WHO, but not approved by the national program for several reasons. The sensitivity of this is much better, 38. Then why are we not recommending? Because interpretation of this test becomes difficult. The additional value comes from, these are all semi-quantitative tests. So when you say MTB trace, then the specificity and sensitivity of it becomes questionable. So RIF resistance in those situations when you have trace, often the machine will say indeterminate, or if it gives a resistance, then also you cannot rely upon. There are concerns even about that MTB positivity when a trace result may not truly be reflective of an active disease. It may be a healed person, a natural infection getting healed which may be picked up because it's too sensitive a test. For these reasons, this has not been adapted by NTEP, but in your practice, when you're sending to the lab, your lab may be doing any one of these. So kindly be mindful of what test is being done and also look at how to interpret them, because if you do not get a semi-quantitative report that it is low, very low trace, you may be wrongly using it, and I'll talk about it a little bit later. The other test which is relevant for by expert on the expert platform is an XDR test, which tells you about isoniazide, fluoroquinolone, second line injectable, and ethanomide. This is now being approved by NTP. Slowly it will be available under NTP also. It is all available in the private sector. This gives you in 90 minutes information about all the resistance and not only RIF. But this test is only done if you have a patient who is a RIF resistance or a failure where you're thinking of an ionist resistance. Otherwise, this test is not your primary test. Your primary test is expert or expert ultra, and I've told you the limitations of those. This is another test which is made in India, this is going to come. Now ICMR has evaluated it. It's called PathoDetect. The advantage of this test over TrueNat is that this has two probes, R and H. So simultaneously, it will tell you about rifampicin and INH. This has just been, as we speak, we had meeting less than 2 weeks back where it was finally agreed upon, and very soon this may be available. Very soon means in few months time, because there is a procurement time, and there's a much bigger machine. So this is not like TrueNat, which can go to a peripheral health center. It will be a district hospital or larger hospitals where it will be used, but this is something which is there in the pipeline. A quick word about molecular tests. When we do not know what we are writing, this is what we get. You write CB-NAT, you write NAT. So from all the big labs, you will get in-house NATs. You will get non-specific NATs. You will also get, where TB expert has been recognized, EXPRT, or GeneXpert as GenExpert. These are not same platforms. These are Korean, Chinese, which are available. What the test you have got may be right, may be wrong. Their sensitivity and specificity has not been validated. So please be mindful of what you're writing. That name is important. So it's like buying a Nike which is new K, and then later on realizing that ye sasta to mila lekin bekar tha. A word about CB-NAT, results. When it comes to very low and RIF resistant, indeterminate or detected, you have to look at risk factors. If the risk factors are not present, you have to repeat it. And there is a need to understand how that is to be also evaluated in a repeat test. In the shortage, because of the shortage time, I'm not going to take you to the algorithm. I'm just showing these algorithms are available on the website of NTEP. where you can go through them because you don't have to remember them, but these are relevant, there is an interpretation. Largely it says that if it is second time confirmed, you treat as drug resistance. If it is not confirmed, you treat as drug sensitive, unless until there are clinical risk factors. What are clinical risk factors? A failure, a relapse, a contact of an MDR, or a contact of someone who has died of TB. So these are the broad areas where you may consider, even in a very low or a fresh case, RIF resistance as RIF resistance. Otherwise, there's a huge algorithm of reflex testing for fluoroquinolone, INH, and this has an impact on your choosing the correct test. Again, in the interest of time, 15 minutes is too less a time to even talk about RIF resistance, so let me try to deal with it, and I want to finish in time. So quickly going to DR-TB treatment. If RIF resistance is not detected, we give drug-sensitive TB treatment, and if there is non-response, then only we will. So that's going to be your commonest stream. However, suppose this is a child who was a failure, where you are thinking of drug resistance, and this is still showing no RIF resistance, then you have to go this pathway because this failure may be because of INH resistance, right? So that's something which is very important. And if you are using a treatment for INH, you're going to replace INH with fluoroquinolone. Our background resistance to fluoroquinolone is very high. In our country, the deficiency of fluoroquinolone and third generation cephalosporin leads to fever. So that's one trouble. And so morning we heard that every pneumonia can be staph, so linezolid. I'm very worried about that situation. Please be very careful of using these drugs because they're very important second line drugs. So no aspiration on the previous speakers, it's just that we can't extend the argument. कोई भी pneumonia staph हो सकता है और कोई भी staph PVL producing हो सकता है और वो staph vancomycin resistant भी हो. With that extension of argument, we cannot. There were very clear markers which were given by that panel when and to use or not to use. Kindly do not use these drugs loosely. If you have drug resistance, again, depending on the severity of disease, you have long and short regimens, and this is the regimens which we are using today. As we speak, again, there is a lot of consultation going on how these should be modified, because we are talking of injectable below 5 years, we're talking of an 11-month regimen with many drugs, where also there should not be an INH and ethanamide resistance, there should not be a fluoroquinolone resistance, and often in children, these answers are not immediately available because you have to depend on a culture before they will come your way. So we are, the whole profession is looking for future where this can be reduced and done better. So what is going to happen is that you have fluoroquinolone sensitive, possibly you heard in the newspaper 6 BPAL M is coming to the country. It is not coming to us because proteanamide cannot be used below 14 years for possibility of a testicular toxicity. As of now, it is not recommended. So this is out for us. Possibly where we may be headed at something like a 6-month regimen where you have bedaquiline, I'll just 30 seconds, delamanide or levoflox with linezolid and clofazimine as 6 months, or a 9th month. The final decision on this has not been taken. The advantage is going to be that then you do not need an 11-month therapy and you do not need a lot of reflex testing because that will be taken care of what we have. So finally, to end, we know it is difficult to diagnose and obviously difficult to teach in 15 minutes. Microbiological and molecular diagnosis are something which is very important. Suitable therapy is possible, but we lack child-friendly formulations, and pill burden and injectables are another problem. Thank you very much. So TPT, preventive therapy in the context of MDR, has only been approved if your source case is fluoroquinolone sensitive, then you can give 6 months of levofloxacin.
To rifampicin resistant to isoniazid, there is an article in
If it is INH resistant, then you can use 4R or 6R.
And for rifampicin resistance?
Sorry?
Rifampicin resistance?
Rifampicin resistance, fluoroquinolone, if only it is fluoroquinolone sensitive. If it is fluoroquinolone resistance, currently there is no TPT recommended.
One more question may be allowed.
So, CBNAT was a terminology which is used only in India. That because we have our own another test, TrueNat is from India and WHO validation came later on. So one is a chip-based, that is also CBNet, that's TrueNat. Other is a cartridge-based, which is GeneXpert. But when we write CBNat, the lab can do any NAT for you. So please write, we usually say avoid the brand names. This is one place where I say, know the brand names, ask for the specific test. Because all of them are not same and only some of them are approved.
So the CBNet and GeneXpert, they are the same thing. Both are cartridge based.
In the context of NTP, CBNat could be either a TrueNat or a GeneXpert.
Thank you, Dr. Varinder. Next, we have the panel discussion by Dr. Shantanu Dev on updates in childhood pulmonary TB. The panelists are Dr. Atul Gupta, S.S. Rawat, Chandri Bhattacharya, Varinder Singh, and Arun Bangali. Thank you, organizers, for allowing me to address this August gathering.
So I hope Dr. Shantanu Dev needs no introduction. He is the CIAP East Zone President and also Vice President. And he is an expert of all zoners of pediatrics, and he is a very active member and contributed in different publications from CIAP, which are very useful in our day-to-day office practice. Sir, please introduce the panelists.
They have shown the slides, ma'am. Thank you so much, madam, for the kind words. We have a very illustrious panel of panelists, and most of you know them. So the questions will go to certain panelists. The names are given there, but any of you can interject. But my only plea is that please keep your answers short and to the point. Otherwise, I'll miss my flight. So childhood TB in India, as you all know, is a very staggering problem. Approximately 3.42 lakh children, that is 0 to 14-year-old, they get TB every year. There are only 6% of notifications to NTEP, which is childhood TB, but it is estimated that the numbers would be much more. And it is also estimated that there is a detection gap of nearly 56% in notification or detection. So the exact contribution of TB to under 5 mortality in India is still unknown, and as a singular organism, Mycobacterium tuberculosis contributes to most deaths of under 5 children amongst the world's middle and lower income countries. So with this background, this first question goes to Atul Gupta sir. Sir, what are the challenges associated with the diagnosis and management of childhood TB, which allows very less reporting or a detection gap of 56%?
All clinicians here, I think everybody faces the challenges which are associated with the diagnosis and management of childhood tuberculosis. And childhood tuberculosis, as it has got a varied presentation. And it is also such that if you compare it with adults, there are more pulmonary tuberculosis than extrapulmonary. And in pediatrics, the ratio is a little on the side of extrapulmonary. That is a different one, and that is a challenge because all the methods which are for collection of samples for extrapulmonary, even pulmonary, are a little difficult. And also the yield which comes out is inadequate. And as you all know, that childhood tuberculosis is paucibacillary. So the yield is very low. Even if you get it, then when you start treatment, there is a problem. The problem is that is now a bit solved now, that earlier we used to be 4 tablets to be given to the children. Now a better formulations are available with 3 drugs in a dispersible form, and that is flavored so they can take it well. And when you start treatment, the problem is of treatment failures. So you have cases where they stop treatment in between, or there is HIV or protein energy malnutrition. These all factors lead to treatment failure. And also another problem is that the evidences that we have to start tuberculosis are less direct in nature, and we have to depend upon indirect factors to treat.
Yes, sir. It looks like a huge mountain that we have to climb now. A lot of challenges are there. So the first step in diagnosis of TB is symptom characterization and labeling a child as presumptive TB. Because TB suspect is a terminology that we no longer use because of stigmatization. So Arun Manglik sir, how do we do symptom characterization in TB? Because the symptoms of TB are also common to so many other conditions. So which children with the similar symptoms would you think of having TB?
I wholly agree with you, sir, because there's a huge overlap over there. And if you have a persistent fever for 15 days, maybe 2 weeks, or a persistent unremitting cough, I mean, here this is something very important. You had a cough for 2 days, and then the child was not coughing for 2 weeks, or maybe 10 days, and then again starts coughing. Maybe you're dealing with something else. Maybe you're dealing with some sort of allergies of asthma. That's a different story. But if you have an unremitting cough for 2 weeks, well, tuberculosis should be at the back of our mind, and we must have a high index of suspicion. At the same time, if there is no weight gain or weight loss around 5% or so in the last 3 months, child not improving, a severe acute malnutrition child which is not improving despite all of nutrition management being done, and very important, if there is a contact with pulmonary tuberculosis in the family in the last 2 years, all this raises our hairs to the thought process that we may be dealing with a childhood tuberculosis.
So in addition, there may be other signs of extrapulmonary TB also, like peripheral painless swelling, meningitis of insidious onset, or spine gibbous, which should tell us that probably this child needs to be worked up for TB. So, Dr. Rawat, in the algorithm, it is mentioned that it is pulmonary TB. Exposure to pulmonary TB is contact. But what exactly do we mean by contact? How do we define contact?
Yes, thank you very much. So history of contact is extremely important history which you should try to elicit. So contact is an exposure to a child or an adult who is having an infectious form of disease, mainly in the larynx, airway, or in the parenchyma. But mind you, if the child is symptomatic, in that case, even contact with any case of TB in the past 2 years, because he could have an undetected pulmonary lesion. Like, for example, he's in his contact with an skeletal TB or a joint TB, and if that person could have additional lung involvement. So a child who has eye contact with an infectious disease like larynx, airway, or parenchyma, that is a contact, or a symptomatic child with any contact with TB in past 2 years, because he could have an undetected pulmonary lesion, that is contact. Then again, contact would be different type, like household contact, or they could be close contact. But these are all definitions. More important is that take a proper history, whether in past 2 years, whether it is an active disease or a child who is.
Thank you, sir. So 2 years and any form of TB, finally it boils down to that. So after doing symptom characterization, we will do the chest X-ray, because this is the initial screening test. So, madam, when we do the initial screening test, this is the algorithm. The top part is the algorithm. It is mentioned that X-ray suggestive of TB. So, what are the TB highly suggestive X-ray patterns?
Well, the first evaluation, as sir has suggested, for any presumptive TB is a chest X-ray. Yeah. So, what do we see in a chest X-ray? X-ray, we will advise to a patient, but how do we interpret it? Yes. That is the basic question that should be at the back of our mind. There can be two sort of findings. One, there are findings which are highly suggestive of TB. And this is in a patient who may or may not have a contact with the clinical features that makes us suspect a presumptive TB.
Yes.
There are mainly 3 patterns that makes us think of that this might be a case of pulmonary tuberculosis. It can be either a hilar, paratracheal, or mediastinal lymphadenopathy. It is highly TB suggestive, or it can be a fibrocavitary disease usually found in older children, or it can be, the third type can be the miliary pattern, which is a snowstorm kind of an appearance, and it is suggestive of a diffuse disease.
So we give more weightage to these three patterns. So if we get these three patterns, what next?
Shantanu sir, I think it's very important to point out that this is the first major change in the algorithm. Initially, we used to depend upon the smear examination for entering into this algorithm, but now it is extra chest. So past we used to depend upon and smear. Now smear is out and we depend on extra chest. So this is the major difference.
We have a lot of reliance on, because we have to have a lot of reliance on chest X-ray. So madam, what to do next?
As sir has suggested, it is now sits at the top of the algorithm.
Yes.
Absolutely. So if these lesions are seen, we have to find a sample. It can be either a sputum or an induced sputum. How that is done will be explained by my senior panelists later. Or it can be a gastric aspirate, as it is feasibility, and according to the age, the type of sample depends. If it is nucleic acid amplification test, that is NAT positive, then it is a microbiologically confirmed TB. Now, with the microbiological confirmation itself comes the rifampicin resistance. It can be diagnosed by the same test. So, if it is the rifampicin resistant one, then the DRTB pathway will be entered, as sir was just explaining. Our main concern is with the rifampicin sensitive one, since it is most common in children. Now, what kind of NAT can we use? It has to be NTP approved. Yes. Either it is gene expert with RIF resistance detection, as sir said. In other cases, don't write brand names. Here, brand name matters.
Sir, by habit, I'll be mentioning CBNet many times, but from the next panel discussion, I'll change it to gene expert.
It is expert RIF.
Yes,
yeah.
expert RIF.
And TrueNat is a approved Indian test, and line probe assay is mostly for detection of resistance, but it is also a useful test.
So these would be the tests that we would do for a molecular diagnosis if we have a chest X-ray which is suggestive of TB. So this is another big challenge which Gupta sir had told in the beginning, collection of sample. Why is it a challenge, sir? It's on, sir.
It's a challenge to collect the sample because, as I said earlier, that in pediatrics, in small children, it's very difficult. Even if you, firstly, the resistance comes when you counsel the parents that this is going to be done. Secondly, the children cannot expectorate. So, and even when they expectorate, the force of expectoration is not much, so the things cannot come out. So that is, and even they tend to swallow whatever comes in the throat. So unlike the adults, the specimen needs retrieval.
Perhaps it is only a teenager or an adolescent who can give us a good quality self-expectorated sputum, below which we should not expect sputum to be given to us. So we need to retrieve that sputum. So Arun Manglik sir, what are the solutions to this?
Well, the solutions, as he rightly pointed out, most of the children, they would not bring it up. Half the time they would swallow it up. So we get it from the stomach. That's one solution. Okay, and that we have been doing all these years. I would have been very grateful if our moderator could have allowed us to show the video which Dr. Varinder Singh has produced. It's available freely on the net and also on the YouTube.
In the CTB website, it can be downloaded from the CTB website. Varinder Singh sir has posted very good videos on collection of samples.
Excellent videos. The gastric, I saw it myself. Gastric lavage one is about 6 minutes duration. The induced sputum one is around 13-14 minutes. Of course, now what we are basically doing in the gastric aspirate, what we are doing is allowing the child to have a fasting for about 5 to 6 hours. So it has to be an overnight fasting. We can do it as a domiciliary setting, but if the patient is admitted, then all the more better because the results are better off. You can try another trick is that you put in the nasogastric or the orogastric tube right in the beginning and the night itself, and allow the child to go to sleep with that only. What happens that the next morning when the nurse comes, the child is still sleeping and she doesn't disturb the child at all, and you can aspirate, and we can expect there won't be any food components inside that would be disturbing the collection of the sample. And At the same time, if the sample is not adequate enough, then in that situation, obviously, you have to give a lavage with maybe 10 ml of normal saline. That would be good enough. So we have to rotate the child, now for that obviously the child will get up. The child will not be sleeping anymore. But if the first instance you can get enough of maybe 5 to 6 ml of sample, that may be enough, and we have not disturbed the cell, because as you disturb, and maybe there will be some gastric motility and lot of gastric contents may go down. So that's one part, and that becomes very easy to collect. But yes, the in-house done means an admitted child, where in the domiciliary setting, the child comes in the morning without having taken anything, and then you can do the whole procedure. Obviously, there will be some less of yield, but still it is good enough.
Maybe 3-4 hours of fasting, sir?
Overnight. He comes in the morning, so he comes without taking anything.
But
so the child had anything, and obviously the staff has to be ready by 7 o'clock in the morning. Otherwise, if we expect the child to wait till 10 o'clock in the morning, obviously the child will be hungry and wouldn't come absolutely fasting.
Minimum duration?
5 hours.
5 hours, sir. 3-4 hours, sir.
The challenge comes in very small children.
Yes.
Because they can't
That is a
stay
problem.
fasting that long. So if you are on liquid diets, so the usual formula is 2-4-6. Clear water 2 hours emptying, milk 4 hours, and thick things 6. So most of these children are milk feed. So 4 hours is minimum you need for them.
And the next part would be induced sputum. Here what we are trying to do, we are trying to get the sputum out from wherever the secretions are there deep inside the chest, and for that we have to use normal saline nebulizations, 3% normal saline. Now since the normal saline nebulization can induce bronchospasm, we have to prime with salbutamol nebulization prior to the normal saline nebulization. Instead of salbutamol nebulization, you can use MDIs also, maybe 2 puffs might be good enough, and follow it up with normal saline nebulization. Again, this is very excellently depicted in the video produced by Sir. And while the child is being nebulized with normal saline, you can give the container, particularly if the child is big enough, maybe 7-8 years old, you can give the container to the child, because when the child is being nebulized with normal saline, what happens, there may be a bout of cough, and the child may bring it out. So if the container is with the child right there itself, then the child can just put that expectorant down into that container, and then the nebulization part is just disturbed for that moment when the child is expectorating out. Now if the child is too small, and despite all efforts, what is happening, the child is swallowing it up. And that is also very well depicted in the video. You can have those infant mucus suckers which we use for newborns. You can use that and put it under a low control suction device, and then you put the other end of that, right, measure it from the tip of the nose to the tragus. So that is where then once you insert it through the nose down up to the pharynx, it will reach the posterior wall of the pharynx, and then once it reaches there, at the same time advantage would be that it would tend to trigger a cough once it touches over there, and once it reaches there, what happens that whatever secretions the child may expectorate out doesn't have the opportunity to go into the esophagus, and because the suction is being continuous at a low suction powers and pressures, it will be expectorated out into that container which we have with the suction device. And at the same time, we can also do a bit of a chest percussion. And for chest percussions, we normally use, say, a cupped hand sort of a thing, and we can pat on the back and do it on a regular basis. That will help to loosen out the secretions from the depth, and that may come up further again. And these chest percussions are done around both on the back and the front. And again, at the same time, all the secretions, if it is collected, now collection tube may be a conical one or maybe a simple bottle. Now, if it's a bottle, because the conical ones can be put directly into the sample testing procedure, because those are the ones which we are using.
Yes, sir. Rawat, sir.
Add to one thing, that the sample should be from deep airway, so it should be a mucoid sample. It should not be just a watery spit, and it should be at least 2 to 5 ml. So volume and the content of the sample should be important.
Yes, yes. And in induced sputum, while collecting induced sputum, the collector should take proper precautions. Yes, post-COVID we are more aware of it, but these guidelines had come even before COVID.
So self-protection is required.
Yes. So, Dr. Rawat, there may be so many children who are not having TB highly specific X-ray patterns. So how to go about with those children? For example, consolidation, non-homogeneous opacity, ground glassing, thin wall cavity, how to go about?
Yes, so in this particular condition, straight away you treat these children with antibiotics. It could be amoxicillin or amoxiclav. You should not use linezolid or fluoroquinolone because these are the drugs to be used for TB.
Even
so
macrolides.
As we have discussed in the pneumonia session, don't use levofloxacin and linezolid. Reserve to amoxicillin and amoxiclav. Give for 7 to 10 days. Child responded well, matter ends. The child not responding now at the end of 7 to 10 days, now these children you have to collect a respiratory specimen, either self-expectorated sputum or an induced sputum or an GL and subject them to NAT. And in case if the NAT is negative, again you can repeat the sample, get a better sample like BAL, or you can see for extrapulmonary focus like a node sitting, you can go for an FNAC and see whether you can pick up some bacteria there. You can do BAL. You can refer for some higher center to get some more ideas. And still, if you cannot identify the bacteria and still you are very sure that this child has TB, then that comes into the category of clinically suspected TB, and probably you are well within reach to start anti-TB treatment. But should follow this case very closely because they could be DRTB because you have not isolated the bacteria. So in spite of you are starting your treatment of TB, DSTB, so empirically follow them up very closely for response of the therapy so that you are not missing DRTB.
Thank you, sir. In fact, you have gone ahead by a few slides. So this, yes, sir.
So just to quickly summarize this algorithm, why X-ray has come up, and many of us, that was the end point. Who did sputum, who did gastric aspirate? If X-ray shows there is miliary, X-ray shows there is lymph node, you treat for TB. So why have we brought it up and then said, no, do another test? So UDST. Earlier we used to write gastric aspirate for smear and also write X-ray. X-ray was done, gastric aspirate was done, not done, done in whatever way it was, and it was smear which did not cost much. And the positivity was less than 10%, nobody bothered, and you started treatment on that basis. Now, if we do the same thing with CB0, it is more expensive. This test takes 90 minutes, but if it has a modular machine. So machine at best can do 4, or a 16 modular machine can put 16 cartridges together. That means in a given day, you would have about 30 samples which can be done. If I'm sending samples which are not required, despite there being a rapid test, I will not get a report till 10 days or 15 days because I flooded the lab with unnecessary samples. So that is why value for money. If there is X-ray is showing lesion and that lesion is TB-like, I must know whether it is drug sensitive or resistant, so I go ahead, do an ad. If it is a picture which could be because of an alternative diagnosis also, and one of them is bacterial pneumonia, I give appropriate therapy if the child has not received therapy. If the child has already received for 7 days, there is no need to wait. Then you can straight away go do NAT.
Yes.
You're not able to get it, then look for alternative specimens. It can be BAL, it can be EBUS, it could be a repeat sample in a better way because the quality of sample has been talked about, which is very important. So what is a higher center is not which is on 15th floor. A higher center means which has a capacity beyond yours. So it will vary from where you are working and it will not be the same for everyone. So wherever you have come to your wit's end, seek help for someone who can do more.
Yes.
And that is the essential.
Yes. So next question also is for you, sir. This is a burning question. TST is not there in the algorithm. So what is the current status of Manto test? There are so many pseudo Manto tests available in the market. So whether they are reliable, will it come back in the future? Is it actually required? Should we look for a Manto test or a skin test again in the future? And what about the new CYTB test? How to diagnose TBI? And can IGRA be used for instead to diagnose TBI? That is tuberculosis.
This is not one question.
Sir?
This is not one question. Yes. Anyway, so there are two parts to it. I'll just quickly take the first part. Why the Manto test is not there in algorithm. Whether it is tuberculin skin test or what it is now going to be called a TB skin test, because it's not tuberculin, it's a component test which is also called CTB Copenhagen and now CyTB because Copenhagen has sold the test to Serum Institute and that's their brand name from Cyrus Poonawalla. Whatever it is. it is a component test, so it is not falsely positive with BCG. That is an advantage. Why is it not in our algorithm? Because now we have better tests. So when you had Montu's test, it was more like police wala. No, the mentality of तुम उधर से निकले थे, हाँ निकला था, तो वहाँ चोरी हुई, तुमने नहीं करी. But in a country where 50% of us in this room would be Montu positive, so if I cough and I have a shadow and I'm Montu positive, so I have TB. When I have better surveillance tools available. Therefore, this indirect pointer has now been kind of decreased in its importance, because it's only a marker of presence of TB infection. It is not a marker of presence of TB disease. So it only says, since you have TB-like symptoms and you also have evidence of TB infection, most likely you were suffering from TB. That was what the conventional teaching was. But now we do not have standardized tuberculin available. 500 grams was made, it is finished. Whatever is available in the market is not a standardized one.
Yes.
So you have Psi-TB, you can use it, but then again the difficulty is that in a high burden country you can be Psi-TB positive because you are infected, not necessarily because you are diseased. And symptoms of TB are overlapping with many other diseases. So therefore it has a very limited role. Its primary role is to identify TBI or TB infection in current time. Now we are talking of a universal TB preventive therapy to identify them. You can use either a Psi-TB or you can use IGRA. IGRA is more expensive. Then IGRA also has several names, gold, platinum, God knows whatever. Remember, whether it is gold or platinum, it only tells you infection, it doesn't tell you disease. So do not be misled by those, the things which companies do. Be aware that it only tells you TB infection, it does not tell you anything beyond that. It can be used, there is no, but it is more expensive. Some tests, just like we heard about CB0, there are a lot of other IGRAs other than quantiferon and ELISpot, which are the only two which were WHO approved, which are available in the market. They are done without a positive and negative control. You get a test, it's not a validated test. Okay. So remember, these tests also, which technology we are using becomes very relevant for us to interpret. So there are only two IGRAs which have been approved by WHO. That's called quantiferon gold, and the other one is called TB spot or ELISpot.
Okay. So this CYTB test, is it available for children?
So it has been now approved till 12 years.
Till 12 years.
And so far not available in the market. They're giving to they were to produce it, then COVID came, they started producing COVID vaccination. It's low priority for them. Currently they are only giving for the TPT studies to the government, but they soon would be marketing.
Till 12 years means 12 years and above.
Sorry?
12 years and above.
12 years and above.
Oh, not below 12 years.
Yeah.
Yes, sir.
As of now.
Yes, sir. Thank you so much.
That's because they have not done safety studies, which DCGI needs to approve. Otherwise, there is no concern about this being any different in younger than.
Dr. Rawat, you have already explained that if after overcoming the hurdle of sample collection, we may face another hurdle, which is NAT negative. So how to proceed in this, you have already given. So briefly.
So sensitivity of CB-NAT is almost same as culture. So it is about 40 to 60% less than culture. So a negative culture, as it doesn't mean that no TB, similarly CB-NAT negative doesn't mean that the TB is not there. You can have TB in spite of a negative CB-NAT. But then that's clear. The only advantage of CB-NAT is that it has got a quantum jump over sputum smear examination, because if you compare culture positive test on sputum, the difference is between 90 to 30. 90% is in CB-NAT and 30% with smear. Whereas for GL, gastric lavage, it is 68.8 versus 25. So advantage of CB-NAT is a quantum jump over smear examination, sputum smear, where it is a point of care test. But a negative CB-NAT definitely doesn't exclude TB, and you must again look very closely for TB. Again, the role of the repeat samples, because if you clinically suspect that child could have TB, then if your one sample is negative, again you go for a better sample. The sampling may not be proper. Again, go for a better sample, or you can go for an alternative sample. Then definitely, but once it doesn't end, if you're clinically very suspicious, you must do it. Role of culture, if you see the algorithm initially, there is no role in initial. But if you have an important specimen like ball specimen, definitely you must send NAT along with culture because that is a very important specimen. If NAT is negative, probably you have at least something to bank upon. Or if you have detected rifampicin resistance, then in that case, a sample for culture is extremely important because it is going to tell you the all downline, what are the sensitivity to other drugs. So there are only two indications. If sample is very important, like BAL specimen, go for culture also. And once you have detected rifampicin resistance, then of course you have to send for culture. Clinical diagnosis TB, you have done everything you have done, and you are not able to document MTB. Bacteriologically, you are clinically sure, exhausted all options, then that is a very small group of clinically diagnosed TB where you are justified in starting TB. But as I told you previously, it has to be DS TB treatment unless there are high risk for DR TB, and follow these children closely.
It is risky because, yes sir.
I totally agree with what Dr. Rawat had said, except that we send cultures for most extrapulmonary specimen because they are difficult to get again. So remember that. And often the extrapulmonary samples are collected by surgeons. And they are in a habit of putting everything into formalin. So please remind them it has to be in a saline sample that you have your cultures positive. So that's an important thing. So whether it's a psoas sepsis or a tissue, and these NATs are possible to done on tissues as well as cell saps or secretions. So needle aspiration of peripheral node is something which will often give you a diagnosis when your BAL is not giving you an answer. So that is also a possibility. We also have on the website on needle aspiration how that can be sent and that can be accessed to. So whenever you have a precious specimen, send for culture. Whenever you are suspecting TB resistance, send for a culture. If it is ref resistance, obviously you have to do it. But even when you are suspecting a step backwards, please send a culture because you may not have a repeat sample available later on. And it takes time. It takes 6 weeks before you will get your answers.
So, Gupta sir, when to refer? There would be times when you are not able to proceed ahead.
This referral already has been almost discussed.
Yes, sir.
So I don't want to waste time.
Okay.
Then blocks have been created. The first one with symptom complex, chest X-ray and having chest X-ray negative. Then if this is probably for extrapulmonary TB, and for these are the cases which should be referred. And the second one, if you have got a chest X-ray which is not the 3 ones which earlier described, then you have to treat with an antibiotic for 2 weeks, and then do another CBNAT if it is persistent, and if it is negative,
Still
then
negative.
again the referral has to be.
Yes, sir. Thank you, sir. So currently every case of TB must have confirmation of diagnosis as well as completeness of diagnosis. So ma'am, what do we understand by confirmation and completeness of diagnosis?
We have discussed most of the diagnostic algorithm by now. So confirmation and completeness according to NTEP is basically having either a NAT or smear positive and completeness or culture positive, and completeness means doing UDST. As sir has said, now it is very much incorporated in the algorithm. We must test for rifampicin resistant at diagnosis itself. So 2 C's, confirmation and completeness.
So we must confirm TB also, and we must also look for drug resistance upfront.
UDST.
Yes, sir. So this is the national strategy now. Already sir has also described and madam has described. UDST is the national strategy. All children must upfront be tested for drug sensitivity, at least for rifampicin resistance. So this is an example of a report. MTB detected very low and rifampicin resistant not detected, so confirmation and completeness. So Gene Expert has been the game changer, as we all know. So what is Expert Ultra? Arun Maglik sir, and what are the advantages of Expert Ultra?
I think we have a one-line answer to this. It's more sensitive, and just now Dr. Varinder had highlighted at length on it. You can see, you can detect up to 16 bacilli, whereas for the Gene Expert, the one which we are using right now, 131, so it's 8 times more sensitive. And you compare that with the smear where you needed 10,000 organisms per ml. So that way we are definitely improving, and that is the reason why we are now insisting on microbiologically detected and confirmed tests. Otherwise, earlier on, we used to half the time smear negative and we used to start anti-TB treatment. So that is the very reason, but the disadvantages are also there, which Dr. Varinder highlighted in his talk, with the view of the fact that there may be just positives, despite the fact the patient may not have tuberculosis also. Please do remember this, all these tests don't detect living organisms. They are all dead organisms which may be detected even if the patient has been cured or patient may not have it, may be just harboring it. So these are things which come up with these caveats also.
So it has been recommended by WHO in 2022, but not yet recommended by the program, not yet by NTEP. So one additional thing that has come with Expert Ultra is that it can also be tested on stool specimens. So Dr. Rawat, Expert Ultra in stools, this is new, and how useful can it be?
So as Vandha sir has told you that Gene Expert Ultra, this is a very sensitive test. It has got a very, it can detect 17 bacilli. So it has been found that WHO has recommended that it can use to detect MTB in stool, and the sensitivity is anywhere about 70 to 80%, and specificity about 96 to 98%. So a very good sensitive, very good specific test. So stool sample you can collect very easily even at the periphery. You don't require any expertise. So this here is a place where this sensitive test can go to the periphery, where you can easily collect the stool and you can do the testing for MTB. But remember, it is only for Expert Ultra. It is not for Expert RIF. So till now we have not approved the use of Expert Ultra in India by NTEP. So whenever it is approved, definitely it is a step, a quantum jump, where you can use stool test to diagnose TB. A very easily collected specimen and done at the most peripheral level.
So Varinder Singh sir, Expert Ultra trace results, how to interpret, and why is it still not yet in the program? What are the reasons?
So I'll quickly go a little back on the previous comment, which was on stool. One, this 53% is tested against gastric aspirate or sputum. So it is not same as if your 53% of the sputum test or gastric aspirate was to pick up by NAT of the total TB. This is further half of that, because it is standardized against respiratory specimens. So remember, this 53 is not same as the other 53, because this is here the comparison is with the respiratory specimen. So it goes down. Alternative specimens are something which we are looking at, because it's not easy. But remember, here the positive predictive value is good, the negative is poorer, worse than what you started with. So if you can get where nothing is a child, you can't get a gastric aspirate and stool comes positive, fine. But then cost, it's the kind of an oxymoron, like a happy marriage. So you can't do a test because you are poor and you are at a periphery. But you do an ultra and then do a repeat test, it comes negative. So I do not know where we are headed, but that's what it is. So ultra, now we are even trying in, NPA was tried, nasopharyngeal aspirate. So you just aspirate, because when you cough, normally that's where the secretions are collected. And now people have gone ahead and they're even doing an oral swab. The oral swab positivity of the ultra is similar to stool. So this all is something which is there in the research mode. The good thing about this test is, other than the trace, if it comes positive, it's easy to go. Positive means positive. And you don't have to ask questions. Your questions comes around RIF resistance. It doesn't come around rest of the things. The moment it is traced, RIF resistance is not reliable. Even with the non-ultra, very low, RIF resistance is not reliable. RIF resistance indeterminate is not same as saying, like we compare it with the pyogenic bacterial culture, where it says partially sensitive. No, it does not mean that. It just says test can't tell you, it does not have enough DNA copies to tell you whether it is sensitive or resistant.
Yes,
it doesn't tell you either way. So do not think an indeterminate means ki so ho sakta hai RIF resistant. It simply means you do not know. You are as good as you were before you got the test done. So this problem with trace is that trace can come from infected. It is not that ultra or expert picks only dead bacilli. It can pick both dead and live, but it picks as much dead bacilli. So studies have shown it is useless to know for quiescence of disease if you do it at the end of therapy. But we still do it at the end of therapy if the symptoms are persisting, because now if it is resistance, that's a rapid way of knowing there is an acquisition of resistance. But positivity of MTB at end of treatment doesn't tell you anything. And trace would be same way something where there is a big question mark. The additional yield largely is because of trace results. And that's why it's not the pediatric NTEG group which is opposing it. The lab group, which is supporting National Technical Expert Group, which is supporting the program, has come to this conclusion that in our country, which is high burden country, the WHO recommendation comes from low burden countries.
Yes.
In a high burden country, this has not been as well evaluated, and therefore we are holding on.
So the pediatric TB management guidelines, which came out in 2022, have written one sentence that Expert Ultra is increasingly being used in the private sector. Machine printouts of the result from Expert Ultra may be considered for guiding treatment. However, uncertainty in trace call. So if you're getting a trace result, don't rely on the resistance pattern so much. Warrants clinical correlation and additional tests to be ordered by the treating physician.
It simply means because you have Ultra available in the private sector, if it is trace, above trace result, it's okay. You don't have to repeat with the alternative gene expert. But if it is trace, then there is a problem. That's all. It doesn't mean the test is bad, you can't use it. You can use it, but you have to be cautious. Because once it's written on the paper MTB positive, it's very hard for you to explain that it is positive that I'm not treating. So either the lab should not report them, they should say it is traced to be clinically interpreted. So that's something which there is no agreement.
Any shortened regimes in the offing, sir?
Not yet. A small answer and sweet answer.
Yes, not yet. So even though WHO is saying a lot of things about 2+2 and all, we have to wait.
You see, the science says you can do it. To identify those select patients where it will work is very difficult. We are struggling even for pneumonia, whether it is POCUS or X-ray. We talked of a gap in diagnosis. I think we are a country, we always have double dilemmas. Our dilemmas are never one. One is under and other is over treatment. A lot of us who do VC children know an expiratory film, everything becomes a bulky hilum and hilar lymph node. Most of our asthma patients used to come with an ATT treatment already received.
Yes.
So we have a trouble both ways, and therefore shortened treatment in our regime
may not be good.
Sir, the only thing I'd like to add one thing, that the short regimen recommended between 3 months to 16 years, it has got a strong recommendation by WHO. So it might come sometime, like we must know it. There is strong recommendation.
You see, the strong and mild recommendation by a guidance making group is only related to the evidence they have studied. We give a lot of weightage to these words. Kindly take them in their context. So taking them out of context, often the WHO recommendations are strong recommendation, very weak evidence. What do you do with that? So they are relevant, they have to be contextualized. That's an important thing. And they have to be contextualized as to we are transforming an information from an alien setting to our setting. Whether it works as well in our setting is an equally important question. So these decisions, whether they were accepted or not accepted, are taken by a team of experts who actually delve deep, look at the evidence which WHO has also seen in our context. WHO very clearly says, for every guidelines, GINA, WHO, they say, adapt it to your country setting. So we should not be a silent recipient of it.
So if anybody is interested, you can go and have a look at the SHINE trial to know that something exists in the world. WHO is recommended for certain select situations, but it is not recommended by NTEP, and it is very unlikely to be implemented in our country also.
Sir, just
quickly,
need a few seconds.
Yes.
To sir and you as well, as Expert Ultra, you said that the trace is a problematic report. The original Gene Expert also gives report like trace. That is, yeah.
It gives only very low. It does not give trace. And very low, only thing which is questioned in very low is not MTB. What is questioned is a RIF resistance. Yes, so that's it.
Sir, it is a very difficult topic and the discussion can be unending, but the time is up.
Yes.
So I request.
So you want me to conclude?
Wind up the. Yes, you wind up, sir.
Yes. So Arun Manglik sir, father of a 7-year-old female child has pulmonary TB. Should she receive TPT?
One line answer should be yes, because now we are being more proactive to give to prevent spread of disease?
So there are different regimes now available for drug-sensitive contact TPT and for drug-resistant contact TPT also. Available resources are available, you can have a look. These are my concluding slides only, so just the steps. Identify presumptive TB. Radiology is the starting point. Try to collect good quality pulmonary or extrapulmonary specimen. If necessary, repeat collection of the specimen if you are not satisfied. Microbiological confirmation should be done by molecular methods or culture. UDST is the national strategy. Notification is mandatory. If you are diagnosing any case or started treatment on any case, please notify in the Nikshay app. Initiate proper regimen. Pyridoxine must be added to therapy, and there are 3 drugs in continuation phase now. Doses of the drugs have been revised upwardly. FDCs are available, so use proper weight band packs. Refer to NTP to give them the proper packs of FDCs that are available. For the duration of therapy should be for proper. 12 months therapy is recommended for drug-sensitive CNS TB and osteoarticular TB. Ensure completion, follow-up. Drug-resistant TB is better treated by experts. And if you are working in the private sector, please link your patients to the government TB sector for benefits. Ensure notification, dots, completion, and follow-up. Accept limitations and seek help. Follow recommendations and algorithms. And all patients must have HIV ruled out in them. So attempt confirmation and completeness of diagnosis for all, because if we cannot find TB, we cannot treat TB. And if we cannot treat TB, we cannot end TB. So what is out? Probably smear examination as an initial test for most, ESR, ELISA, Manto test, ADA for diagnosis in any fluid. And alternate day therapy is out. Non-DOTS therapy is also out. And maybe for the future skin tests, Expert Ultra, be careful about the trace results, and shorter regimen, not possible in India, maybe for the other parts of the world. So thank you all for a patient hearing. Thank you to my expert panelists, because they made my job very easy. And looks like I'm not going to miss my flight also. Thank you so much.
Thank you. Thank you, Shantanu. Excellent session, very enriching session. Please collect your memento. So the next session will be on sleep, and the chairpersons are Dr. B.K. Manocha and Dr. Abhijit Datta. Sleepless before the lunch, yeah. Dr. Manocha, please. May I request Dr. Bharat Reddy to be on the dais?
Good afternoon. This is a very important subject, which, nowadays we get parents coming to our chamber, and this mother and father both are, in a job. And when the child at night does not sleep, or, gets up repeatedly, and the mothers also can't sleep at night, they have a problem attending office. So they request pediatricians, how to deal with this. And today we are having Dr. Bharat Reddy to discuss very interesting chapter. I've heard he's an expert in this sleep therapy and sleep problems. So I request he can start his lecture. Thank you so much.
Thank you, sir. Thank you for the wonderful introduction. I'm going to speak a little fast because obviously you all are all hungry. So we're going to try and cover a lot as we can today. How many of you all are feeling sleepy right now? Sleepy? Anyone? Only one or two of you. Okay. So today the first topic which is allotted to me is about infant sleep issues, right? And I think a lot of us are going to talk about it in a more general pediatric point of view, because as pediatricians, you're going to face this on a daily basis. A lot of children are going to come to you saying, my child is not sleeping, my baby is not sleeping. Most of the time, you as a pediatrician have told them, deal with it. You're a parent, deal with it, right? But today the concepts are changing, and we're going to talk about how are you going to address infant sleep issues. So let's start with this 18-month-old baby. Arjun's mother comes with the following complaints. Arjun wakes up multiple times at night, around 5 to 6 times at night, but he sleeps between 10 p.m. to 6 a.m. He falls asleep after the mother breastfeeds him. He cries excessively if the mother does not feed him, and does not sleep if mother doesn't feed him. And he currently sleeps on the same bed as the mom. And what does she do? She feeds him. Every time he wakes up, she feeds and she goes back to sleep. Is this a common scenario that you face on a daily basis? Yes? Okay, I need you all to shout yes or no? Yes, okay. I'm trying to keep you all awake today. Okay, so in this case history, again, Arjun has a working mother. She is not getting enough sleep now. She had to start working 6 months after her pregnancy as well, but she continues to follow the above practice, and she feels like this is, as a mom, this is how her nights have to be. Now, going to a daytime nap, he sleeps twice for 1 hour during the day after she rocks him. Otherwise, Arjun is a healthy boy, growing well, developmentally normal, chest is clear, everything is fine. Except the sleep problem, everything is fine for this mother. Mother comes and asks you, is this okay, doctor? How long is this going to go on? Asks Arjun's mother to the pediatrician. Many of us are going to face this. Is this okay or not okay? Not okay. But why have we not dealt with this if it is not okay? Okay, she's a working mother, it's not okay for her. Why have we, how many of you feel this is okay? Dr. Rawat says it's fine, it's completely okay. How many of you say it's okay? All right, how many of you say not okay? Equal number. Is this normal or not is the question that we need to answer, of course, right? And as a general pediatrician, let us answer, is there a sleep problem at all? Now, I would say yes, this is a sleep problem. Why is this a sleep problem? Is because it's interrupting the sleep of the mother, right? It is causing the mother, a working mother, to not function at her job the next day. And this is something very important for us to consider. And let us understand if this total sleep duration of the child was normal or not. So do you think this total sleep duration of this child was normal? If you go back, the child slept at 10 p.m. to 7 a.m. and in between he's been waking up multiple times. He had naps, around 2 or 3 naps during the daytime. Do you think for an 18-month-old child, the sleep duration was normal or not normal? It was not probably normal. We'll go through that again. Is multiple awakenings at night acceptable for 18 months? Now, as a pediatrician, they're going to tell you this all the time. You should confidently be able to answer this. Doctor, my child wakes up around 5 to 6 times in the night. Till today, I'm sure all of you all have told that this is normal. But today you all need to go back and say that this is not normal and this is not acceptable for a child. Is breastfeeding and rocking contributing to this problem? Do you think the breastfeeding was a problem? Okay. And finally, is there any medical issue? Do you think it was a medical problem? Do you think there was a medical disorder which was causing this child? Or do you think it's just normal practice which was happening? Most likely a common practice. Let us answer these questions so that today you can help this mother. Should the mother accept her fate as this is normal? Few of you are saying yes, but I'm asking you very directly. Should the mother accept this as fate? No. A lot of the patients who come to me eventually, a lot of pediatricians have told the mother or told the parents saying that, listen, you are a parent. Bacha tumne paida kiya. So deal with it, right? And this concept is going to change in the new age mothers, and we as pediatricians need to change our concept and counseling as well. Is this sleep problem at all? Yes. When a parent comes to you saying my child is not sleeping properly, high likely that it is a sleep problem. So do not rubbish a mother's problem saying this is how it has to be. It is not how it has to be. Sleep deprivation in mothers has also resulted to show in severe depression. Postpartum depression is on the rise, and a lot of mothers are getting affected by that because of not sleeping adequately. And mothers who undergo sleep coaching, we do something called as sleep coaching for a lot of these mothers, and they are shown to be happier. You need a happier mother to raise a happier child, and that is what is more important with sleep coaching. So there's a new concept which has come. It's called sleeping through the night, right? We all have heard the word sleeping like a baby, right? Have you not heard sleeping like a baby? But does sleeping like a baby mean waking up multiple times at night? No, it means sleeping through the night. And sleeping through the night is possible for a lot of babies. So what is the normal sleep duration? Now if you look at this child, he was around 18 months. His night sleep was around 8 hours. Daytime sleep was around 2 hours. So the total sleep duration that came was around 10 hours. So is 10 hours a good enough sleep time for a child who is 18 months? No. So what is the normal sleep duration? So this is called as the American Academy of Sleep Medicine guidelines as to what is the normal sleep duration for different age groups. So we will discuss this in more detail, but for this age group, a baby is between infancy to toddlers requires around 12 to 16 hours of sleep and toddlers around 11 to 14 hours of sleep. This baby, 18 months, probably requires a minimum, a bare minimum of 12 hours of sleep. So we are deficient by almost 2 to 3 hours of sleep in this baby. Remember, at the end of it, I may talk about sleep duration, but what was another problem in this baby? Okay, the baby was sleeping 10 hours, but was that good quality sleep? No again, right? So even for you as an adult, you may end up sleeping 10 hours, you may end up sleeping 12 hours, it doesn't really matter. It is your quality of sleep that is very important. And when I kept telling that this baby is waking up multiple times at night, what is happening in this baby is the poor quality of sleep. We're not looking only at the quantity. So when a mother is telling you he's waking up multiple times at night, imagine you as an adult had to wake up 5 times at night. Do you think it's good for you? It's not. Then why are we telling that it's good, okay for a child to be doing this? It is not okay. So the quality of sleep is also extremely important. So is multiple awakenings okay at the night? It's not. So what you need to understand before you counsel your mother, or you as a pediatrician, what you need to learn is there are 3 concepts that I will tell you. Firstly, about the stages of sleep. Secondly, what is self-soothing skills? And thirdly, what is sleeping through the night? Now, when we all sleep through the night, we have different stages of sleep. We have something called as non-REM sleep and something called as REM sleep, right? Now, we all go through non-REM sleep and REM sleep. This keeps happening through the night. This is what we call as an ultradian rhythm, right? So when I do sleep studies, this is what I keep reading. How much non-REM sleep, how much REM sleep. We have different stages of non-REM sleep, 1, 2, 3, and REM sleep. We keep going through this through the night, which means you as an adult also are waking up multiple times. When do you wake up or when do you have this mild arousal? We use the word arousal, is when you transition between non-REM sleep and REM sleep. So when you go from non-REM sleep to REM sleep, you have a mild awakening, but we go back to sleep. Again, when you transition between these different stages of sleep, you wake up a little and then go back to sleep. So the mother asks, so doctor, does this child waking up, is that normal? Yes, to a certain extent it is normal. All of us have arousals in the night, right? Every time we transition between non-REM to REM sleep, those arousals will happen. But what should the child do during the arousals is that the child should go back to sleep on their own when they wake up for these minor arousals. So you as an adult also, when you transition between non-REM to REM sleep, you wake up at night, but you go back to sleep. So this is a developmental milestone which we have not learnt during our pediatric residency at all, which is called self-soothing skill. A lot of babies acquire self-soothing skills at a certain age, and we need to ask them if they've acquired the self-soothing skill. This is a developmental milestone. It needs to be assisted, it may need to be nurtured. I always ask the mother a simple question. Do you have dogs? Have you seen dogs and puppies, right? Does the puppy require the mother to help the puppy to go to sleep? No. Does any other species in the planet require the babies to have the mother to come and assist the baby to go to sleep? No. Then why is it happening in human babies? It is happening because we are not allowing the baby also to go to sleep on their own. And that is a milestone which they normally attain. And a lot of babies attain it. It's only 10% of babies that you will find this problem with, which is called self-soothing skills. So what does the self-soothing skill mean? A baby should be able to go back to sleep on his own after this arousals happen during that REM sleep. So when the transition happens, the baby wakes up, but the baby should go back to sleep on their own. And that keeps happening through the night. And this is normal and natural. So it is shown that this self-soothing skill is acquired by the age of 6 months to 9 months, which means after the age of 9 months, a baby should be able to self-soothe on their own. So that brings us to a problem of sleeping through the night. So at what age can a child sleep 8 hours through the night? This is going to shock you, but this is a physiological studies which have shown that a baby between the age of 4 months to 6 months can sleep long stretches of 6 hours to 8 hours through the night. Most common question, but doctor, he's hungry. Will a baby not get hungry after 6 hours to 8 hours? So physiological studies have shown very clearly that after the age of 6 months, a 6 hour to 8 hour stretch of sleep is required for the child. And your feeding rather disrupts the physiology and they are not going to be hungry for 6 hours to 8 hours. So sleeping for 8 hours through the night can be acquired after 6 months of age. And some developmental milestones can interrupt sleep. A baby who starts learning to walk, starts learning new milestones can get disrupted, but by 12 months. So when a mother comes to you, you have to be very confident in saying, by the age of 1 year, a baby can stay for 8 hours through the night without requiring a feed, and this baby should be technically sleeping at least for 8 hours at a stretch, and that is called as sleeping through the night. And this is very important for the baby to sleep through the night to acquire growth hormone. Right? Growth hormone is secreted only with consolidated sleep. We all have learned that one of the main triggers of growth hormone is sleep, right? And that occurs only with consolidated sleep or continuous sleep. It will not occur with disrupted sleep. So there are various advantages which this continuous sleep causes for growth and development. Was this feeding a problem? Was feeding and rocking a problem? Yes. Now, why was this a problem? This is a term which I'm going to introduce to you called as a sleep association or a sleep prop. What is a sleep association? It is any object or activity on which a baby becomes dependent on to fall asleep. So what are you dependent on to fall asleep? Go back and think about it. You will also have something every night that you do which makes you go to sleep. Most of the time it's your phone, most of the time it's watching TV or doing something very, very particular to make you go to sleep, right? That is called as a sleep association or a sleep prop. So what have we done is we have trained babies also that listen, you cannot go to sleep on your own. You cannot attain self-soothing skills. You can sleep only by doing certain things like rocking or feeding. And over a period of time, a baby's brain gets wired to become habituated to a sleep prop or a sleep association, right? So it is not, a baby is not born with this problem. It is us having created a lot of these problems. So if a baby comes to you at a newborn period, and we start now doing counseling for sleep coaching as early as newborns, and you won't be surprised, since I work in Bangalore, a lot of mothers approach us at the newborn period saying, doctor, start sleep coaching now. And I say, listen, we can't do it so early, but I'll give you all the basic guidelines that you need to follow so that later you don't face sleep problems. Most important, don't introduce sleep associations right from the beginning. We work on eliminating all these sleep associations and make sure your baby develops self-soothing skills. That is a very important and independent milestone. So what exactly happens here? Do you think there's a medical issue happening? I think a lot of you said no, but history taking is very important in these children. History should be taken in detail, and before I start any sleep coaching, as a doctor, I ensure that medically there is no gastroesophageal reflux, there's no associated colic, there's no associated allergies or any form of milk intolerance or food allergies which is causing all these problems. Once those are completely ruled out, we call this condition in our sleep circles, it is a diagnosis called as behavioral insomnia of childhood. It is insomnia. A baby who's not sleeping through the night is called insomnia. And this is called behavioral insomnia because it is caused by only a behavioral problem and not by anything else. So this is a simple questionnaire that you can take in your regular practice, which is very simple, called the Bears questionnaire. You just need to ask, what is the bedtime? Is the baby having excessive daytime sleeping? Is the child awakening during the night? How regular it is, and if they're snoring. If you ask these 5 questions, you rule out most of the medical problems before we label this child as behavioral insomnia of childhood. So these are the conditions that I told you that you need to rule out for any sleep issues: GR, obstructive sleep apnea, AR, infantile colic, and food sensitization. So what should you do, and why do you think you should help this baby? First of all, as a pediatrician, you're the first source of contact to these parents. If you do not help, nobody is going to help them, right? And sleeping through the night is absolutely essential for us to have happy parents and happy mothers as well. Benefits of sleep is on growth and development, on memory, attention, prevention of obesity, and prevention of infections as well. So the importance of sleep in a child is so essential, and that is important for us to focus on. I'm rushing a bit so that we get to the main problem of sleep coaching. So what do we do with sleep coaching in these children? So when you have to assist these babies to self-soothe, we encourage a lot of safe sleep practices. We ensure this child gets consolidated sleep. So the term has to come to you as consolidated sleep, which means that awakening should not be there. It is a continuous sleep. So even you as an adult need to understand that continuous sleep has a very important role. So when we talk about secretions of growth hormone, when I spoke about attention, spoke about memory, all that requires continuous sleep or consolidated sleep and not poor quality sleep. And this will achieve the milestone of sleeping through the night. So there's a lot of studies which are done on this concept of sleep coaching, and it has shown that yes, it does have a high benefit not only for the baby, but also has high benefit for the mother as well. So what do we do in this sleep coaching? The first thing we do is set a fixed bedtime. You have to be very sure that your baby goes to sleep at a fixed time every night. See, take the baby to bed. The baby may not sleep as well, but tell the mother, listen, every day at 8 p.m. you have to go to bed, and let the baby wind down by 7:30 and go to bed at 8. Establish a sleep routine. What is a sleep routine? You have to do a set of fixed activities, 4 to 5 fixed activities of winding down before sleep, which does not include play activities. You might just change the pajamas, give a bath, read a book, listen to some soft music, and wind down this child. You are literally training the child again, but you're training the child in an other manner, where every day you do 5 activities and get the baby prepared to sleep. Try to reduce co-sleeping as much as possible and follow safe sleep practices. So due to want of time, I'm just going to show you this slide where you try to fix an ideal bedtime. Usually half an hour before the bedtime, you start your sleep routine half an hour before, and by 8 o'clock. Now you ask me at Indian time, what time should a baby normally go to sleep? An infant, an 18-month, usually by 8 p.m. all the winding down should have happened, and baby should be taken to bed by 8 o'clock for sure. Going on to basic concept of sleep routine, it can include any form of activities which does not make the child stimulated, like have a bath, brush teeth, read a book, put pajamas, etc. And should be the same. Every single day the sleep routine should be the same, so the child gets programmed. You won't believe, after a certain period of time of the sleep coaching, the moment the mother's changing the pajamas, giving a bath, babies go to sleep within 5 minutes, right? There's no insomnia. So follow a sleep routine, and that works like clockwork in a lot of children as well. And ensure that goes step by step. How to overcome sleep associations. I think this is the most difficult topic which all of you are going to, how is the mother going to wean off breastfeeding? How are you going to stop rocking? And that is where this whole concept of sleep coaching works, where we try to help the mothers come off the breastfeeding, come off the dependence on any form of association, and it is possible. There are 3 techniques that we follow. One is called the standardized extinction, or the Farber technique, which is followed a lot in the Western scenarios where they allow the baby to cry it out. In India, a lot of mothers don't accept it, so we go to another technique called the graduated extinction, where we give around 15 minutes of crying and then allow the baby to do anything else to go to sleep. Just one simple tip I will leave you with especially breastfeeding, because I have done a lot of surveys in India and we found out that the most common association still remains feeding. So, and that is very important for us to counsel. How does the mother wean the baby off feeding and not make feeding an association? Most important tip is, don't allow the baby to sleep on the breast right from the beginning. Right when you're feeding the child, breastfeed the child, identify when your baby is falling asleep, get the baby, when the baby is falling asleep, put the baby on the bed or crib or whatever and start patting. So the baby understands breastfeeding is feeding and sleeping is sleeping, right? And if you do that right from the beginning, it becomes very easy for the mother to wean off from breastfeeding as well. So I will not cover this. Co-sleeping is still a matter of choice. I think a lot of parents can continue to co-sleep, and safe sleep practices, I think all of you all know about that. So winding down, in summary, as I said, the quantity and quality of sleep is extremely important in infants. Infants should sleep through the night by the age of 1 year for sure. Eliminate sleep props and sleep associations like I showed you. Rule out medical problems before we label this as behavioral insomnia of childhood. Introduce sleep coaching as early as possible. And right now in India, a lot of parents have become aware. They look online for sleep coaches rather than them looking for uneducated and non-doctors as sleep coaches. You as pediatricians should become sleep coaches and ensure that children sleep through the night. Thank you.
Thank you, Dr. Reddy, for a very interesting and very important subject. I would like to know that in abroad, babies sleep in separate rooms from a very young age. Is it good for the sleep pattern, or is what we do in India, we sleep with the...
Sure. So the concept, there are 2 concepts. I skipped that slide. So there is a concept of co-bedding and co-sleeping. Yeah. Co-bedding means you sleep on the same bed. Yes. Co-sleeping means you sleep in the same room but not in the same bed. And children in the separate room. Yeah. So all 3 are completely fine. There's studies which show all 3 do not have a problem on the psychological impact of the child. So just because you put a baby in a different room, it doesn't impact the child psychologically for sure. But what happens is, for you to sleep coach a child, it becomes very difficult. See, you're having a baby next to the mother and the mother is telling, listen, I'm not going to feed you. That is not going to be easy for the mother more than for the baby. So what we recommend is co-sleeping but not co-bedding. Keep the baby in your same room, but keep another bed or keep another crib just next to the mother's bed, so that you feed the baby but put the baby back to the bed. So that is the recommended method.
Thank you. Has this been included in the curriculum of postgraduate students now?
It is not. We're trying to work very hard to introduce. So we have also done surveys of how many doctors, pediatricians know about sleep, and we found that most pediatricians, when we ask questions of pediatrics, sleep score less than 30%. So we need to include it in the curriculum, and I mean, obviously we're thankful to the conference to include this as an important topic.
Thank you, Dr. Reddy, for an excellent talk. May I request Dr. Shapan Chakraborty to co-chair the session in the following panel discussion. And the moderator is none other than Bharat Reddy. And the session is on sleep disorders in children, a case-based approach.
So I would like to request all the panelists, Dr. Gautam Ghosh, Dr. Sumantra Sarkar, Dr. Arup Haldar, and Dr. Varinder Singh to please come up on stage, please. So in the first talk, I introduced a lot of the concepts of sleep, and I think a lot of you got excited about what the whole concepts are. So we're going to go through a few cases with our esteemed panelists, and I think these cases will answer a lot more questions you had from the previous talk as well. So even after this, if you have questions, please feel free to ask us. So why have we introduced this session on sleep itself? There's an entire pre-lunch session on sleep which is troubling you, right? Because sleep problems are very common in children. The overall prevalence is found to be 21 to 47%. And in the US, they've done a study which shows that in your clinic, if you did a survey, nearly 4% of children will have sleep problems. That means 1 out of every 4 children that you see will come back with some sleep problem or not. The most common ones are snoring, obstructive sleep apnea, behavioral insomnia of childhood, which I showed you was 30%, and parasomnias. So starting off with the first case, patient A, aged around 5 years, and the mother complains 5-year-old child has stopped napping in the afternoons. And she's worried if this child's sleep is adequate or inadequate, and asks you, is it okay, doctor, that my child has stopped skipping naps at around 5 years? Is this fine or not fine? So firstly, Dr. Gautam Ghosh, why is adequate sleep so important? I know I covered it very briefly, but give us more scientific reasons. Why is sleep so important for children?
Yes, thank you. Am I audible? Adequate sleep must be good in regularity, continuity, quantity, and quality. And the usefulness, the result is a good somatic growth, a good cognitive growth leading to no learning disorder, and long-term obesity and infections, and at the age of 5 years, parasomnia too. And I finally want to have a comment that stopping the daytime nap is maybe normal at the age of 5 years.
We will cover that for sure. But as you mentioned, sleep is most, let me tell you the 5 points sleep, as Sir mentioned, was important is growth. Most important with the growth hormone with respect to development. Always say attention and memory, because you all remember if you don't sleep before your exam, you're not going to perform in your exam, right? So those are the main important thing. Prevention of obesity. Remember, obesity causes sleep problems can cause obesity, and finally prevention of infections. So thank you, Dr. Gautam Ghosh, for covering that. But how do we calculate the total sleep duration, Dr. Shumantra Sarkar? So in this child which I showed you, how do we calculate that?
We'll calculate on the 24 hours total. So the nighttime sleep as well as the daytime napping, both will be included, total hours. But one point I must include that bedtime, going to bedtime not equal to the sleep time, because as the parents report to us, when the child goes to the bed, that doesn't mean the child, after going to the bed, child is sleeping. There must be some latency to bedtime to sleep time. So the point is, when the lights are off and the child is sleeping, and that calculation, the starting hours and the awake hours, that means at the time of when the child is awake. So that time in the night, and including the daytime nap, that should be included. So total will be included.
Included in this child. Sure. So we took the history like you said, and the bedtime is in this child at 11 p.m. Wake time is around 7 a.m. Nap time is around 2 to 4 p.m. This used to happen before the child turned 5 years. Currently he's skipping the nap. So the total sleep duration comes to probably around 8 to 9 hours, right? So is this okay, Dr. Varinder Singh? Is this okay for this age or not?
So, this child is 5 years. So you expect them to sleep about 10 to 12 hours, so it is little less. And that's something which we often do not recognize. The sleep times are, the recommendation for Indian children are not there, but whatever the American Academy recommends is about 12 to 16 hours when you start in the newborns, and it gradually decreases. And you are doing about 10 to 12 hours when you are 5 years, and about 10 to 12 hours at that time, and 9 to 11 hours when you are above 5 years. So often the Indian children tend to go to sleep late, and there's a variety of reasons. You know, the father comes late from work, and the mother is busy looking after the family, and nobody. So somehow the family time actually starts after dinner. The whole time, often it is that, okay, after dinner is over, then people are watching TV, and how would the child sleep when all the excitement of the day is happening? So for several cultural reasons, it starts late in our country, and therefore the timing which we see here is less.
Sure. So as we already put up, the total sleep time is as per the American Academy of Sleep Guidelines, and this is very important for you to remember. So in this child, if we say his child is around, let's say 3 to 6 years, should be sleeping at least 10 to 13 hours over 24 hours, and definitely a baby sleeping for 9 hours is not at all adequate sleep for this particular age. As Dr. Varinder pointed out, there are various reasons that can happen for this. So we are very clear in this child, the sleep duration is abnormal, right? And all of you took the picture of what the sleep duration is, so the mother says, okay, it is definitely low. So how do you acquire good sleep duration, Dr. Gautam Ghosh? Yeah.
Yes. Considering he doesn't have any other medical problem, we accept the diagnosis as behavioral insomnia. The steps that we have to take, so he is almost a sleep depth of 2 to 3 hours on calculation. First is a sleep environment. And at this age, out of the long list, I will think the most important point in sleep environment training to the mother is bed is only for sleeping. This child probably using the bed for a lot of other activities. Then, graduated extinction. I will advise not a standard extinction. Graduated extinction is the first step that we can to early the sleeping time. Of course, parents coming back, acting, family schedule is very important. And the most important at 5 years, he is probably his preschool nursery. And the bus comes at 5 a.m. or 6 a.m., takes 1 hour to school, and 7 a.m. So that is an important early arousal technique. During graduated extension, I would rather console the mother, train the mother, so the child goes to sleep drowsy but awake. And finally, the follow-up. It doesn't, I cannot make this sleep coaching in a day. It may take some time. And involvement of the family members, the in-laws, the grandparents is most important.
Sure. Thank you, sir. So I think a lot of the issues that you raised are important. I'll go to the guidelines for that as well. And what about the nap, Dr. Sumanta Sarkar? I think one of them raised the question of the nap. So as 5 years, is it normal for a baby to skip naps at 5 years?
Sir, the nap that is the child is having now is the 50% napping. The skipping is because there are so many reasons to keep skipping the naps. But
so what age does the child start skipping naps?
Yeah, from the 5 to 6 years, the age that the child starts skipping the nap. So at the age of 5 years, it's okay, the skipping the naps, but there must be some reasons. And I must add to the sir's comment that the people are now using more and more mobile phones and the TV screens, which are now causing the problems of skipping the naps and the reducing the nighttime sleep
duration.
Yeah. So this is not quite normal in this child, but by 6 years, okay, nap skipping is normal.
Sure. So by 5 to 6 years, skipping the nap is definitely normal. So keep 5 years as the cutoff. Anytime before 5 years, if babies are skipping naps, it could be due to various reasons. But after 5 years, we usually label this as normal and say that by 5 years, it is okay. And sleep deprivation is found to be the most common problem, not only for adults, but also for children in our country. And there are studies which have compared Indian sleep versus children sleeping in Western countries, and there is almost a 2-hour difference or a deficit, which means our children are sleeping for 2 hours lesser than their Western counterparts. And that is quite significant. What's the impact going to be in the long term? We do not know. The bedtime in the Western countries is between 7 p.m. to 9 p.m., and the average bedtime in India, as per studies, is 10 p.m. to 11 p.m. Absolutely not acceptable, which means our children are definitely sleeping lesser and later. And one of the main reasons, like Dr. Varinder Singh pointed out, is that we're culturally accepting it. Let us not say it's the cultural difference. We're culturally accepting this late sleep time and accepting them sleeping lesser and later, which we need to change as a population to help our children sleep better. So we had an NRC guidelines where we have started reciting the recommendation for pediatricians, where it was recommended that we follow the ASSM guidelines. A lot of questions are saying, children sleeping 2 hours lesser, is it normal? Is it normal? Someone asked, Modi sleeps only for 6 hours, but he's functioning, right? So is it okay to sleep only 6 hours? That is an important question we need to raise. Let us stick to the guidelines saying, yes, this is the recommended duration of sleep, and we should try to achieve this much sleep in our children. We do take into consideration the age, the wake time, the family schedule, etc. But we should start counseling our parents saying that this is the amount of sleep your child requires. So the best method to reach that point, like Sir said, there may be school time may start early, etc., is to ensure the child goes to bed as early as possible. And that is very important for us. The total duration, as he mentioned, includes daytime naps. And by the age of 5 years, the naps are going to stop. And up to 7 years, the naps can stop. If a child is napping after the age of 7 years, coming back from school and taking 2 hours of nap time after 7 years, there's something abnormal, right? That means the child is sleep deprived through the night, and that is why they're coming and napping. All of you all who are going to sleep through this afternoon session today are going to be sleep deprived in the night. And that is why we're taking naps in the afternoon or through other sessions, right? We're not sleeping adequately through the night, and that is why we close our eyes. So that comes to the most important question of how do we ensure good sleep hygiene in our children? So what are the sleep hygiene guidelines, Dr. Varinder?
On a lighter note, he is being, kind of very helpful to us. He's not blaming us for your sleep. He's blaming you for your sleep. But getting back to the question which I have to answer is sleep hygiene recommendation. Gautam mentioned that right at the beginning. The first important thing is regularity. So there has to be a regular routine, a bedtime which is appropriate, early, and which is maintained. We often also say, "Arey, sara hafta to bahut kaam kiya, ab sone do, weekend." So Saturday, Sunday, you sleep, you get up at 12 o'clock, 2 o'clock, it doesn't matter. Parents accept it. They accept it because it gives them free time from not minding the child. But that's not right. So there has to be a fixed, regular routine. That is something which is very, very important. It's more about pattern building. So children learn from patterns. So there has to be a pattern on what is it bedtime, what is the duration of time, which has to be consistent, not much variation, maybe an hour or so allowance, because often children are getting up early for school, but that slight allowance is possible, but not a huge difference between them. Then, same way, have a bedtime routine, which you alluded to in your lecture also, that, okay, you prepare as a ritual, that now your bedtime, just as we prepare them for food, ab thali lag gayi hai, food is cooked, get onto the dining table. There has to be a routine for them to recognize, okay, this follows with the sleep. And that routine cannot be telling a story is fine. Playing a game before sleeping which wakes up the child is not fine. Hyperactivity is not fine. Showing a story with the help of an audio book and a visual book is not, less of screen time. Screen time is something which actually, there's so much to do and be actively involved. It arouses them rather than makes them sleepy. So less of screen time, an appropriate fixed routine. It's not a question of to make it boring. Even though it becomes boring, it is more about pattern recognition. So that is these are some consistent things which are required for sleep hygiene. So quiet room if possible. Beds are for sleeping fine. But suppose there is a family who just have one bed, one room, and where is the bed? Bed is everything there. That's a dining table. Still there can be a bed that you put a different sheet and say, okay, this is the time. So child does not understand bed only as bed. A bedding can also be a bed. So we have to improvise and think how those routines are brought in to identify for the child that this is your bedtime, you have to go to sleep.
Sure. Thank you, sir. So again, with school-going children, as sir mentioned, maintain a routine, consistent bedtime on all days. Whether it is weekday, weekend, it has to be the same. And like sir pointed out, there's a concept where some of them oversleep during the weekend, right? That is called as a term called sleep debt. Sleep debt is because your body is asking you for more sleep because you've taken away the sleep from the body, and any form of debt is not good for your body. Ensure weekdays and weekends is fine. Avoid electronics. Avoid high energy activities, and today we have to also talk about high energy drinks as well as any form of caffeine, chocolate, etc. should be avoided before that and keep the environment fine. Just a point on the digital things, sir. Up to how long before bedtime should screen time be avoided? 1 hour. So 1 hour prior to bedtime, we avoid screen time. How many of you all hold your phone and go to sleep? I think a lot of us, right? So the blue light which is emitted from your phone disrupts a lot of sleep waves. The reason we talk about so much about digital is the laptops, the screen, all the screens that you see emit blue light, and the blue light significantly disrupts your sleep cycles, which is the reason why we should not allow any form of screen time. Going on to the second case, here is a similar child, a 7-year-old male, brought with history of snoring for 2 years, wakes up around 2 to 3 times in the night. Parents do notice some degree of heavy breathing at night occasionally, and symptoms particularly increase during infections. This is very common, I think, most common scenario which all of you all find for sleep issues. It's a snoring child. So Dr. Arup Haldar, the previous child was just about a regular sleep issue. Here is a child who's snoring. When do I say snoring is normal or not normal?
So before answering, one disclaimer, I'm an adult pulmonologist, but I do have a training on pediatrics for 2 years, and I regularly perform pediatric polysomnography, which is being referred by Dr. Gautam Ghosh, Pallab Dar, all other pediatricians. So don't ask any question on treatment, because I do not treat them, okay? So this patient, 7-year-old boy, presented with a snoring and heavy breathing. And snoring, not all snoring is obstructive sleep apnea, but definitely primary snoring or habitual snoring has some comorbidities, like they may have hypertension, or in adult we have seen they may have stroke incidences. I do not have idea about what happens in children. But if the snoring is associated with some other symptoms, like daytime sleepiness, a restless sleep, or a behavioral problem, that becomes very important. And even in primary snoring, without any other issues in the bedtime, if the patient is habitual snorer or more than 3 times per week, that is important to consider. And then we have to take a history and we have to evaluate whether other symptoms or subtle symptoms of obstructive sleep apnea whether present or not.
Sure. I think summarizing what Dr. Arup said for you as basic tips, a child's come with snoring. First, you have to differentiate a term called habitual snoring. What do you mean by habitual snoring? First question you ask, is it more than 3 nights in a week? If it is more than 3 nights in a week, he gets labeled as a habitual snorer. Then, like he mentioned, you ask for additional questions. Is this associated with him waking up multiple times? Is this associated with nocturnal enuresis, any form of daytime symptoms, nighttime symptoms? Then we say that this snoring is abnormal, and you go into taking a detailed history as well. So the important term we introduce here is called sleep disordered breathing. Right? We always keep using OSA very loosely. We need to use the term called sleep disorder breathing, which is the current terminology for a child who comes to you with snoring and you want to do further evaluation. So another term he said was primary snoring. So what is all these terms? So first we label it as habitual snoring. He's snoring more than 3 times. Then we ask more questions. And if it is only snoring and there's nothing else that is happening, it becomes primary snoring. If there is anything else which is happening, is it going to become obstructive sleep apnea or not? And all of these conditions come under a single spectrum, what we call as sleep disordered breathing. Why are we discussing sleep in a pulmonology conference? Is because a lot of the sleep issues are related to breathing issues, and which is why we label it as sleep disordered breathing. And almost 70% of children who have this sleep disordered breathing will have snoring. So how do you diagnose the sleep disordered breathing clinically, Dr. Haldar? I know you mentioned a few points, but can you give the practical tips? What questions should we ask to say it is abnormal or not?
Categorically, patients may have some nighttime symptoms, daytime symptoms, and there are some problems may be picked up in the physical examinations. In nighttime symptoms, the most important symptom is definitely snoring, choking or apneic episodes during the snoring, a restless sleep, sleep in a particular posture, like in a hyperextended neck or in the sitting position, drooling of saliva, enuresis. So these are the nighttime symptoms. The parents, they could observe that. Daytime symptoms, daytime somnolence, or hyperactivity in children. Attention deficit hyperactivity disorder is associated with OSA in children. Or poor school performance, behavioral issues, mood issues. So these are some daytime symptoms the patient can, the parents can observe. Physical findings like enlarged tonsils, enlarged adenoid, or retrognathia, some skeletal abnormalities like mid-face hypoplasia, hypotonia like in spatial child, like Down syndrome or Prader-Willi. So these are few of the findings we have in suspected obstructive sleep apnea.
Sure, I agree. So a lot of daytime symptoms, nighttime symptoms, and associated physical examination. Yeah, sure, sir, please.
Only to add, when we get a case of, in clinical practice, we remember 4C. Controller, is there a problem in the CNS?
Yeah.
Container, is there a dysmorphism? Content, if he has a large tongue or adenotonsillar, and comorbidity including obesity. Thank you.
Thank you, sir. So first we ask a lot of nocturnal symptoms, daytime symptoms, and physical examination. Important for us to take these basic histories to say that this sleep disorder breathing is abnormal or not. So we learned two terminologies, sleep disorder breathing and obstructive sleep apnea. You learned that these are completely different right now, right? It doesn't mean the same. So Dr. Gautam, coming to you, is it different? And
Yes.
if so, what is the difference? Yeah.
The gold standard is polysomnogram. There are other issues of audio, video. I will rather advise the gold standard in children is polysomnogram. There are 4 levels of polysomnogram.
No, so is this OSA or sleep, which is clinical, which is lab-based?
OSA is lab-based. Sleep disordered breathing is always a clinical diagnosis. To confirm, we need a polysomnogram. There are 4 parts. The first, level 1, that we usually always recommended on pediatrics, have 28 channels, if I'm correctly, and 15 are in phases. That not only monitors the airflow, heart, lungs, and everything, but the CNS. But the second is only home-based, and third, fourth don't have a CNS name. So, clinical prescription is sleep disordered breathing. Confirmation is, of course.
Yeah, sure, please.
It's a broad spectrum actually, and in this broad spectrum, OSA is one of the disease, obstructive sleep apnea. So we may have a central sleep apnea, we may have a sleep-related hypoventilation, we may have a primary snoring or habitual snoring, we may have a sleep-related catatonia. So these are the various diseases which is under the umbrella of sleep disordered breathing.
Sure. So I think the take-home point over here for all of you is to understand that sleep disorder breathing is a clinical diagnosis. So child come to you with snoring, you're trying to analyze this child more. Your diagnosis should say sleep disordered breathing, suspected OSA. And you will refer for a sleep study or refer for a polysomnography. And it is on a polysomnography that you can diagnose that it is obstructive sleep apnea based on various criteria. Like Dr. Gautam mentioned, there are different levels of polysomnography. And I think a lot of them are already doing it in Calcutta. And it's very important to understand that level 1 is considered the standardized method of doing PSG in a child. Level 3, level 4 is more commonly done in adults, not so much in the pediatric age group. So Dr. Sumantra, there's a question always asked us, as a pediatrician, no, I'm suspecting snoring, fine. I'm already saying sleep disorder breathing. When do I need to say a PSG needs to be done or not done?
Well, PSG should be done for some respiratory indications and for some non-respiratory indications. Since we are dealing with a patient with a snoring, so we are suspecting OSA. Probably for the respiratory indication, we are using this. So we can do a polysomnography before the adenotonsillectomy, so, and also after the adenotonsillectomy when we find there are some risk factors, and if we find it, there are some problems like some patient may not respond to the treatment. So for them, we have to give some additional therapy in the form of positive airway pressure. So we need to titrate them. So before that, we have to do a baseline polysomnography. And after that, when we titrate the patient with the CPAP, then we have to go for another polysomnography. And for those patients who are having neuromuscular diseases, some craniofacial abnormalities which adenotonsillectomy may not respond, in those patients we have to go for the polysomnography. And in some patients with Down syndrome also, we should go polysomnography initially. And along with those child is having the smaller children, little children who is having a apparent life-threatening event, any history of apparent life-threatening event, then we also go for the polysomnography to find out any problem is there or not. There are certain other non-respiratory causes, rather that periodically movement disorders, like some parasomnias are there, where we want to discriminate between whether it's a parasomnia or it's a frontal lobe epilepsy. Then these are the reasons we go for usually the polysomnographies.
Okay, sure. So just summarizing for you as a pediatrician, take-home points again. When do you refer for a polysomnography? Firstly, you're suspecting adenotonsillar hypertrophy. You want to go for surgery or not go for surgery. Most common problem which comes to my sleep clinic ends up being one person has said do surgery, one person has said don't do surgery, one more ENT has said do, one more person has said don't do, right? All the parents come back and say, doctor, what do I do? It's a sleep clinic, right? So there a polysomnography gives you a very clear objective answer. And I tell parents, listen, also, as doctors, we need to understand we're going to go into a medical legal era in the future. You need to be very clear about what you advise, right? So you need to get a sleep study done prior to the surgery, and there are certain ways we can tell you, yes, you can go for surgery or not go for surgery. And that is very objective and easy for you tomorrow to say this is the reason. So pre-adenotonsillectomy. There are a lot of them who come back after adenotonsillectomy with sleep issues again, and we may need to do it for them. But most importantly for before adenotonsillectomy and all children with genetic syndromes and neuromuscular disorders with sleep problems. So in your normal practice, these are the two main conditions where you will end up doing your sending for sleep studies as well. Dr.
All Down syndrome patients should have a polysomnography before the four years of age.
So in Down syndrome, the criteria is very clearly defined that by 4 years, sleep study is mandatory. But I would say all children with genetic syndromes, like you're a pediatrician, have identified a child with a genetic syndrome, inevitably anybody with any craniofacial abnormalities, any genetic issue will have sleep issues. So at least try to ensure they get a sleep study done. Yeah. Mike, please, yeah.
Three strikes rule.
Yeah. We will come to that. We'll talk about it. Okay. So, Dr. Varinder, is there any role for sleep questionnaires? Why do I need to do a PSG? I can just do a sleep questionnaire. In adults, they have this Epworth sleepiness score and they end up treating. Video recordings are good enough. Why are we doing sleep studies if it's not available in certain cities?
So, the thing is that if you want an objective measure, you cannot get through any questionnaire or any. They can supplement your history in certain ways. Now, that means they're largely a screening tool. So if you look at the thumb rule of what is a screening tool is which has high sensitivity and acceptable specificity. So it may not be as specific, but it should have very high, it should not miss anything, which you confirm by PSG. Unfortunately, these are other way around. Their sensitivity is relatively low. Because their sensitivity is low, therefore you may miss some. You may pick up, but if it is negative on a questionnaire, you can't be certain that this child does not have. So, therefore, their role is limited. If we sometimes, any alternative we use, then we are, withholding the child from a standardized test. That's a difficulty. Where it's just not possible, it is assisting you, you can pick up fine, but if the symptoms are there and your sleep questionnaire is not providing, which is less likely but may happen, then possibly you would have to go for alternative things. Role of video recordings. Now, with the smartphone being with everyone, this current era has made everybody smart, except for people like me who do not know how to handle it. So, these smartphones are helpful for episodic things which often were reported by the patient but not understood by us, because they would describe in layman term, and even a hiccup could be a seizure to them. So, therefore, a recording is able to give us more specific information on what we ask, and are therefore possibly will make our sleep questionnaires or questioning little more effective. In future, they may give you some answer, but they are quite useful for parasomnias or other things where you have to make a distinction between a sleep-associated epilepsy versus parasomnia. It may be handy.
Sure. And I think the question about sleep questionnaires, I know in adults, I think Dr. Arup will agree, where a lot of the sleep questionnaires are standardized and shown to correspond to the sleep problem. In pediatric data, it has been clearly shown that none of the sleep questionnaires can pick up the problem. Even in some of the studies we have done in India itself, where we have taken sleep history from children with genetic syndromes, and we have shown that the parental perception of what the sleep problem is and what we find on the PSG completely do not match at all. So which means that yes, sleep question and sleep history taking is very important, but that is just additional and does not preclude PSG.
Yeah, what is the preclinical likelihood of having obstructive sleep apnea so that we can judge whether we'll do a level 1 or level 3 study. So however, in pediatrics, we are doing a level 1 study. So that's why I think the questionnaire becomes not that much relevant like the adults. And regarding the video, we must have the video if you are diagnosing parasomnia, because we have to stage the sleep, whether it's an NREM parasomnia or REM parasomnia, so that is required. And the video is being actually synchronized with the EEG waves so that we can actually pick up which stage of sleep the patient is having the parasomnia.
Sure.
Sir, I want to add one thing, sir. Studies are saying that the PSQ are 85 to 86% sensitive and specific as well.
Right.
As the studies have said in the
sensitive
literature.
for you to pick up whether the sleep problem is
Yeah,
there or not, but it is
PSQ are
not diagnostic.
important also.
So it's important that PSG remains confirmation for the diagnosis of OSAs. Detailed sleep history needs to be taken. And of course, we go ahead with doing level 1 polysomnography. Home sleep testing. A lot of the, these pharma reps may come and tell you, sir, we do home sleep testing. Many of these companies will come and say, we'll do it at home. In pediatric, do not recommend it because they do not pick up a lot of the problems. It should be referred to a sleep clinic for managing. And this child, we went ahead and took a little more history, snored more than 4 nights in a week, had nocturnal aerinosis once in a week, had early morning headaches and difficult to awaken. So this child underwent a PSG, and it was reported this child had an AHI of 11.3 per hour. So this child may come back to you with such a report, went to a sleep lab, and they came back with a report saying AHI is 11.3. So before any surgery, do you recommend the PSG
Yes,
always?
Definitely.
So why do you recommend that before surgery?
Already, sir, the AHI we are seeing here 11.3. It is severe. That means even after the operation, it may not respond. So we can.
So there may be a residual OSA as well. So Dr. Gautam, can you explain what this AHI means? Like as a general pediatrician, after the study, you're going to get this report, and it says AHI so much. What does it mean?
We calculate the apnea and the hypopneas. Apneas and the hypopneas together in total duration and divide in hours. In pediatrics, it is quite different from the adult standard. In pediatrics, up to 1 is always normal, 1 to 5 is mild, more than 5 to 10 is moderate, and in this particular case, so apnea-hypopnea index is more sensitive in pediatrics and lower levels are more severe vis-a-vis comparison to the adults. And you also in these cases see the oxygen saturation index and the hypercapnia because this is very common in pediatrics.
Okay. So to summarize, a lot of you will get a sleep report. We classify a sleep report as apneas and hypopneas based on how the airflow is stopping. They calculate how many apneas, how many hypopneas occurred throughout the night. That total divided by the total sleep time gives us what we call as an apnea-hypopnea index. You just need to look at that index, and if it's less than 1 is normal, 1 to 5 is mild, more than 10 is considered severe. And why is this important for us is that a lot of your treatment can depend on what this AHI is. So the question of whether to do surgery or not to do surgery is going to be determined on this AHI. So the studies have shown if AHI is less than 5, pharmacological therapy can still work to some extent. If AHI is more than 5, the chances of pharmacological therapy working is less. Above the AHI of 10, it is a definite indication that you have to go for adenotonsillectomy or surgery, and that is the importance of using AHI as a method of management over here. Is there any role for radiology, Dr. Arup? Any endoscopies can be done or anything? Yeah.
So if you suspect there is adenoid hypertrophy, you can do a lateral X-ray of the neck. But this is not that much sensitive. You can go for the endoscopy if you're planning any surgery. This is called drug-induced sleep endoscopy, DISE. Many ENT physicians are doing it in Kolkata now. And that this is much more informative than the radiology itself. So definitely you can do if you suspect.
Sure. So take-home point is the role of radiology is very limited. There is no role currently about doing a X-rays anymore. Doing X-ray adenoid has no role because whether it is enlarged, not enlarged, it doesn't tell you whether you have to do surgery or not. So that sensitivity has gone. I would not agree with drug-induced sleep endoscopy. You can just do a regular nasal endoscopy, which a lot of ENT surgeons do. The child can be just in the outpatient and they can just use a nasal endoscopy and see the size of the adenoids, which you're visualizing with the camera. And how much obstruction that is causing is what can be directly visualized, and that is sufficient to tell you, take a decision of combining both, saying AHI is more than this and the adenoids are this enlarged, therefore surgery is recommended or not, but still going back saying gold standard would still be your PSG. So I answered this question, I think, when do pharmacological versus surgical treatment? I think pharmacological, yeah.
So obstructive sleep apnea, there is obstruction. So the obstruction is the prerequisite for developing obstructive sleep apnea, but actually it is the response to obstruction which determines the clinical syndrome. So obstruction, relief of obstruction is definitely important, but there is some role of pharmacology, especially if the child is having allergic rhinitis or asthma, that has to be treated. We have seen the montelukast or intranasal corticosteroids often help in those patients who are having these symptoms, along with that patients having adenotonsillar hypertrophy, because they have a lot of leukotriene receptor there. So that is the first way of treatment. And apart from that, we also teach the patient about the myofunctional therapy, which is very important, about the exercises of the nose, of the tongue, of the cheek, which actually helps which actually restores the tone of the muscles of the upper airway. So these intranasal corticosteroids, along with that, myofunctional therapy. And if the patient is using CPAP, and in spite of using CPAP, he is having a daytime somnolence, sometimes other drugs like modafinil, solriamfetol, pitolisant, I do not know what is the pediatric recommendation of this new drug. So these are often used as a pharmacological treatment. But the mainstay of treatment remains the CPAP and NIV in some children who have residual hypoventilation even after CPAP or require very high CPAP pressure. Surgical treatment is mainstay in pediatric age group, definitely. So in adult is CPAP, in pediatric is the mainstay is definitely surgical. Adenotonsillar hypertrophy is the main cause of pediatric obstructive sleep apnea. But if the adenotonsils are not that much enlarged, we have to think about these physiological causes of obstruction apart from the subtle obstruction which is present during the sleep. So in those cases, we have to go for this pharmacological treatment and CPAP.
Sure. So summarizing, I think less than AHI, less than 5, we can still get away with doing intranasal corticosteroids as well as montelukast. If it is more than 10, you have to recommend for adenotonsillectomy. If there is a recurrence after adenotonsillectomy, then we'll probably go ahead with treatment. So this is the basic slide. More than 5, irrespective of comorbidities, require treatment. AHI 1 to 5 associated with any comorbidities. And in the absence of polysomnography, if the clinical suspicion is extremely strong, you have to go ahead with treatment.
So you have to go for 6 weeks treatment. That's the duration you have.
So if you're going to use pharmacological treatment, I agree. 6 weeks to 12 weeks before you say is responding or not responding. Now, let us say this child was not a regular child. The child had Down syndrome or Prader-Willi syndrome, and the same PSG was done. AHI was around 11.3. Now, this child, we agree, AHI was 11.3, you're going to recommend adenotonsillectomy. So, Dr. Varinder Singh, if this child had Down syndrome and everything else was the same as it was, is there anything different in your management here?
So, you see, because of hypotonia, whether it is Downs or Prader-Willi because of obesity and hypotonia, they are at a risk of collapse of the increased upper airway resistance. And often Downs are found to have pulmonary hypertension because rest of the things do not get reported. And that happens because of this obstruction, respiratory obstruction which is occurring. So in these situations, unfortunately, the nature never gives you this insurance that since you have Downs, you will not have hypertrophied adenoids. That's a function of age. So everybody gets large adenoids, or children often get large adenoids in tonsils. So if they are enlarged and you have done an evaluation and you find they are contributing, you would go ahead do a surgery. But when you will prognosticate this family, you will be very clear in your prognostication that this is going to perhaps decrease part of the problem and not whole of the problem. And you would require subsequently intervention if this does not go away, the likelihood of which is very high. So when it is Prader-Willi or any other syndromic, surgery may benefit if there is an additional contribution by adenotonsillectomy. Otherwise, you would often require alternative.
So what alternative therapy would you recommend?
So
in this
that's
child?
where you would need BiPAP
Or
CPAP.
NIV therapy. So we do use CPAP or NIV therapy in these children. So who do we recommend CPAP therapy or NIV therapy? Though in adults it is widely used, in children it is for children with residual OSA after adenotonsillectomy. And just to highlight a point, 30% is the recurrence. That means you recommended the child to go for adenotonsillectomy, but studies have shown that 30% of these children will come back with obstructive sleep apnea. That's a huge number, right? We're not diagnosing that because we're not doing sleep studies. So in them, NIV can work. OSA with obesity, high chance is going to come back with craniofacial malformations, genetic syndromes, and neuromuscular disorders. I would counsel that, yes, I would do surgery, but they're going to come back with residual OSA, and CPAP therapy is going to be the risk factor. So what are the other risk factors for residual OSA for them to come back?
Hello, yeah. So definitely if the OSA is severe, then there is chance of residual OSA even after adenotonsillectomy. In obese patient, in patients who have hypotonia because of the various spatial conditions, and these are the main indications of doing a sleep study repeat. Actually, adenotonsillectomy there is only 27% patients actually get complete remission of OSA after adenotonsillectomy. So rest 70% will going to have some residual OSA, and you have to judge whether this residual OSA is causing any symptoms to the patients. Then if it is symptomatic, then you have to treat with the CPAP.
Sure. So this is the indication. First, take-home point, residual OSA is common. Up to 30% are going to come back. And if they're going to come back to you, these are the patients you will counsel before you send for surgery as well. Listen, you can go for surgery, but your AHI is more than 10. There is a high chance you may come back. So I would do a sleep study after 6 weeks, and if there's associated therapy. So in consensus, conclusion, pharmacotherapy is recommended only for children with mild OSA. Beyond mild OSA, don't go on giving treatment if after 6 weeks to 12 weeks it's not going to respond. Surgical and NIV treatment is the modality of treatment to moderate to severe OSA. Preoperative PSG is strongly recommended in those children especially where you feel the recurrence is going to be high. Post-operatively, you need to also assess many children. This is the last question. I think this is a child with a 5-year-old child presenting with screaming at night, and the child is not completely awake but just screaming at night and shouting in her sleep. Each episode, the mother says, lasts for 5 minutes, and the child is not going to sleep on her own. Parents are really worried and want to solve this. First of all, Dr. Gautam, would you do a PSG for this child, yes or no?
This looks to be parasomnia, and
Right.
PSG is not needed at all until unless it appears recurrent. With the symptoms, it looks like if it is consolable, if we can remember the...
What parasomnia do you think this is?
Yes, that's it. If we can remember the signs, we can consider a REM group that's nightmares. But if we cannot remember, have autonomic activities, it's probably nightmares.
So this most likely, since the child is not waking up, not remembering it, most likely this might be night terrors. But the take-home point, like you mentioned, is this is a clinical diagnosis. Parasomnias in pediatrics are clinical diagnosis, and you don't need to refer for a PSG for these parasomnias itself. And most common parasomnias that you encounter, Dr.
Most
Sumanta?
common are usually the confusional arousing and also the sleep terror that occurs in the first third of the night. The others are REM, that is a REM, usually occurs in the early morning. So those are usually remembered by the
So we classify them as REM parasomnias and non-REM parasomnias. Non-REM occurs mostly in the early part of the night, and REM parasomnias occurs in the early part of the morning.
So
as
sleep
well.
talking, sleepwalking, all are early part. That is the
Our take-home point is parasomnias are extremely common. You're going to see a lot of them in your clinical practice. You don't need to do sleep studies for them. And the management of parasomnias are going to be the same, irrespective of what you're going to see. So which is why we're not going to say, is this confusional arousal? Is this nightmare? Is it night terror? Really doesn't matter at the end of it. So steps would be almost same. Dr. Varinder? Yeah.
So it's largely one of the similar to sleep deprivation. So it's about sleep hygiene. And secondly, counseling the patient. So that's age dependent, how young the child is. So you reinforce about, tell them a story which they can dream about. Tell them this ending, that demon has died, which you saw. This would be more relevant for REM. Night terrors, they don't remember anything. So there it's more about sleep hygiene And also telling the family that more they try to intervene, they are actually keeping that child alive, awake. So what is important is that they should just calm the child as much as they can and just hold their hand, let it be, and it will pass away. Tell them that this is not going to cause any damage. Protection of the child during that time is important. Sometimes they walk out, they can hurt themselves. So they are guarded during sleep because they are not fully oriented. So night walking can cause a lot of trouble to the child because they can hurt themselves. They will walk. They don't know where they're going. They're not awake. They're in a trance-like state. They're totally asleep. So safety during that part is something which is very important.
Just like to include one thing. Yeah, one of the precipitating factor of this parasomnia is sleep disordered breathing, obstructive sleep apnea, restless leg syndrome. Recently, we got a patient of somnambulism actually, who has got both of these precipitating factors, and treating these factors actually cured the somnambulism.
Sure. And I think that's very important why sleep history taking is again very important before you decide whether to do a PhD or not. If you're considering it as associated with any other associated problems, we should be able to pick up on PhD and refer for pick up on sleep history taking and refer. But going back to the same point, a lot of parasomnias, these are the points with respect to sleep hygiene management. So parental education support is extremely important to manage parasomnias. In pharmacotherapy, all that is not recommended for children with parasomnias. So concluding our sleep panel discussion, I think it was a very fruitful discussion. We all learned a lot. Ensure that children sleep well, parents sleep well, happy parent and family. As a doctor, you're going to go sleep well and go have a good lunch right now. Thank you one and all.
Thanks. Just to conclude the session, thanks Dr. Bharat Reddy, the beautiful way you keep everyone awake. One thing which I wanted to say for sleep hygiene, the parents should also follow sleep hygiene, otherwise kid will not.
Yeah, absolutely.
That's one. Yeah. And all of us, no one has undergone a polysomnography, although many of us are having sleep problem in this age. So it's not.
Sir,
Thank
I
you.
just wanted to
Thank you all the panelists.
Dr. Bharat. So I just wanted to add one thing, sir, like any child who is kind of, oh, sorry. Photo, please. Yeah, no. So I just want to add one thing regarding that parasomnia. So any child who is kind of shouting, frightening or crying in the night and that is happening repeatedly, so better to get an EEG done because we have seen a few cases of temporal lobe epilepsy and you start Tegretol, they are totally fine. Yeah. Yeah.
Screening and your screen is positive.
Yeah.
So we have screening for flip score as well for nocturnal epilepsy. So we can't do PhDs for all parasomnia.
Yes.
So we need to do a basic scoring and see that it fulfills a particular score. If it does, then yes, EG and PhD is extremely important.
Thank you, sir.
Thank you. Thank you. Chalo, I think. Thank you.
So we break for lunch straight away. Since I don't think we need a big break, we can reassemble by 2:30.
Good afternoon, everybody. I hope you had a sumptuous lunch. And we will all understand now after the post-lunch session whether you all feel sleepy. That means the lunch was good. Now the session is on asthma. The chairperson is my professor, Dr. Swati Chakravarti, and I request her to please come on the dais. And I request the first speaker, none other than Professor Kabra, to talk on recent advances in the management of asthma beyond the guidelines. So we will come to guidelines later, but she's going to talk on beyond the guidelines. Dr. Raja Lahiri, are you in the hall? I would request Dr. Arun Manglik to please join Dr. First session.
Hello. Hello. Uh, Good afternoon, everybody.
Dr.
And
Raja Lahiri, I would
this
request you to
session-
please join Dr.
This
Swati
session on
Chakravarti.
asthma, the lecture will be delivered by none other than Professor S.K. Kabra, which is a very known person or very known teacher. He is a teacher of teacher. He is a researcher, and everybody know that he has got special interest and work and research papers in pediatric pulmonology and tuberculosis. And there are so many things to say about Dr. Kabra, but I will not waste any time. So I would request Dr. Kabra to start his lecture. Dr. Kabra.
Respected chairpersons and friends, in next 14-15 minutes, I'll take you through what are the recent updates. A little bit of from Gina, that would be repetition in the next panel discussion. And the second thing is, I have chosen some of the updates from data generated and published from India. So let us see, the first and foremost is asthma, global asthma trends. This is, all of us are, it's not moving. Okay. Okay, so let us see the global trends in asthma. So this is data generated by a multi-site. All of you are aware about a movement started by Isaac 3 decades ago. And at that time, we had an idea that what is the global prevalence of asthma, including India and various sites in India. So 5 years ago, 5-6 years ago, a global network against asthma did a fourth such survey, but first for the GAN. And you can see here that there is some reduction in the prevalence of asthma, and in this city of Kolkata was also represented. This is just to highlight that there is some decrease in the trend in the asthma GAN phase 1, and which was published in Lancet in 2021, and it was carried out in 18-19. And this is India, that even this, in India also, it is showing some decline in the asthma in 6 to 7 years as well as 13 to 14 years. So there is a decline in the current wheezing, but important thing here is we should be aware that there is a problem that majority of those who are having asthma, they are not getting appropriate treatment. Less than 1% are getting inhaled steroids. So that is onus on the pediatrician that I'll be showing in the other details. In the morning, Dr. Sanjukta was talking about role of PFR, that it is probably underutilized. So this is that clinical phenotype and objective documentation of reversible airway obstruction by spirometry is the standard. But spirometry is not available to majority of the practicing pediatricians. And clinical features are cough, wheeze, and dyspnea, they are non-specific. So PFR is less reliable than spirometry, but better than diagnosis based only on the clinical symptoms. That's why how to use PFR. Spirometer, you may be getting it in 1,000 to 2,000 rupees, an increase of more than 15% after the bronchodilator. That may give objective evidence provided that there is a clinical phenotype. Pre-test probability of asthma is high and you are documenting an increase in PFR of more than 15% after giving 2 doses of salbutamol. And if diurnal variation, that is morning and evening PFR is higher than the morning, and if it is more than 13% different, then you may say that there is a airflow variability. And another thing which is upcoming is FEV1. Till now, it is being considered to be more than 12% after bronchodilator is considered to be a reversible airway obstruction. But there is a ERS and other agencies, they suggest that it should be decreased to 10%, not yet accepted by GINA, but it may come. So even in our practice, if there is an increase of more than 10%, possibly we may take it as a reversible airway obstruction. Then this is a study of how to diagnose exercise-induced asthma. In the morning, we had some discussion about the impulse oscillometry. So this study was carried out at AIMS, and it reported that there is a role of around 21% of the children had the exercise-induced bronchoconstriction. And if you are able to do impulse oscillometry, then a change in R5 was associated with within 30 minutes, and majority of them will show a change in the R5 by 30 minutes, 10 minutes. And the area under the curve was 0.74, that was reasonably good, and it can be used for documenting whether there is an exercise-induced bronchoconstriction. A cutoff value of 14.1% in the difference between the two R5 before and after exercise, then you can say that the child has a problem of exercise-induced bronchoconstriction. And percentage cutoff, you can take it as a 14%. If it is more than that, it suggests that there is a exercise-induced bronchoconstriction. Almost 41% of the children who were missed by this gold standard of FEV1 for this thing was picked up by this impulse oscillometry change in the R5. Then asthma assessment of the control, stepwise treatment, therapy-resistant asthma, and alternative treatment. So all of us are aware about this chart, that how you assess that, but this is clinical based, and all the clinical based parameters may have some limitation, including under or over assessment. So this study was carried out at AIMS, which suggested that can we do a highly sensitive CRP, because asthma is an inflammatory disorder, and if we expect that the anti-inflammatory markers should be increased. So there was a significant difference in the levels of highly sensitive CRP. In well-controlled asthma, it was 0.3, while in uncontrolled asthma, it was 2.74, and area under the curve, which suggests that what is the utility, it was 0.67. Cutoff of 1.1 HSCRP level had a sensitivity of 68 and 67% specificity, or 68 specificity, for suggesting that it is uncontrolled. So it has a modest sensitivity and specificity, but it may be one of the parameter, as we were discussing nasal FeNO in the morning, so it may be another alternative. Then what is the role of FeNO? It has already been discussed and debated in the morning. FeNO is raised in T2 high but not in T2 low asthma. So significant proportion may have a T2 low asthma in children also. FeNO, so that it may not be increased, and that's why it cannot be used as in isolation diagnosis of asthma. FeNO may be lower during the bronchoconstriction, early allergic response, and smokers, and it may be high in allergic rhinitis, atopy, eczema, eosinophilic bronchitis, and it is suppressed by the oral or inhaled steroids. Whether it can be used, where we can use it, monitoring T2 high asthma receiving ICS, mainly to see that the child is getting appropriate treatment, and whether he'll benefit by increasing the dosage of inhaled or oral steroids. So what is the problem in management? So as I was saying, this survey, which includes Kolkata, and Professor Ghoshal was part of this survey. And almost 82% of the current visa and 70% of the subjects with symptoms of severe asthma were not clinically diagnosed as having asthma. This is an important thing, that the onus is on pediatricians. The daily use of ICS was less than 2.5% in subjects with current wheezing, and those with the symptoms of severe asthma, but less than 1% use daily ICS. So we have to diagnose more, put the diagnosis, and start them on appropriate treatment. So starting the treatment, that would be discussed in the next next panel discussion. But what is the status of MART? in children between 4 to 11 years of age. It is option on a step 3 and step 4. Step 3 is 1 puff once a day and 1 puff as needed. So it would be that you are giving 1 puff twice a day and 1 puff SOS. Step 2 is again the same, and the maximum dosage you can use when formoterol is 6 microgram, 8 puffs a day. So several RCTs are underway to assess MART. So it is not the final word. It is desirable that you cannot follow it for all the patients. You have to wait for those results of RCTs, and then we can decide. And it should not be used if you are giving a budesonide and salbutamol SOS. So another problem is remission of asthma. Because this is a problem which we face in our day-to-day clinical practice, that literature suggests those Vs at 3 years go into remission 59% by 6 years and 15% by 26 years. Only 15% are having the problem at 26 years. There may be possibility of recurrence of symptoms, may consult that asthma may go into a quiet state for time being, but it may recur again. And there are multiple definitions. That is another problem, that clinical remission versus absolutely not requiring treatment is different. So for stopping, we can use a clinical remission. And for stopping treatment, clinical remission as assessed by GINA tool did not require oral corticosteroids. Another brief about allergen immunotherapy. AI may be, allergen immunotherapy may be add-on therapy that has a potential as disease-modifying agent and better control of asthma. Most evidence are for the allergic rhinitis patient with sensitization to the house dust mite. Few studies have completed, compared with the pharmacologic treatment, that whatever treatment we are giving, whether it will add anything more. So recommended by GINA is that it should be used in adults. Even Government of India has not cleared it's for use in children. Though multiple friends are using it, they are having experience. So I would suggest that if we really want to popularize it, publish your work so that we can ask the government to clear it. Okay, so I would like to share this piece of work which was carried out at AIMS, efficacy of yoga, that is a Brahmari pranayam and Om chanting on asthma control, quality of life and airway inflammation in asthmatic children. It was an open label randomized control trial, and a combination of Brahmari pranayam and Om chanting as a adjunct to standard pharmacological treatment on asthma control, quality of life, pulmonary function, airway inflammation in asthmatic children. And as per the protocol analysis, after 12 weeks of this treatment, controlled asthma intervention group was 68%, while in controlled only standard treatment, it was 38.5%. As compared to standard group, children in an intervention group, yoga as an intervention plus showed a significant lower asthma control quality of scores and higher quality of life. No significant changes were observed on the lung function parameter because the sample size was not adequate. So conclusion is that children practicing Brahmari pranayam and Om chanting for 12 weeks have a better asthma control symptoms, quality of life and reduced airway inflammation. So this is something, I am not suggesting that we'll be able to stop the medication as our other so-called yoga guru says that has caused the more damage to our yoga. So we say that it is part of an adjunct treatment. As we say, these are the precautions which should be observed, adjunct treatment so that we can control asthma properly. And it is important, and I'll request all our colleagues who are doing research that pick up some of our traditional medications, document them scientifically, that these are better scientifically, prove them, pathogenesis prove them, and then so that people who believe in these things, they are anyway using it. But those who are having a doubt, they may say that it is scientifically proven therapy and it can be used. So it is sustainability as well as you have to explain it very clearly. Then lastly, azithromycin, this was carried out at AIMS, a randomized control trial. And it was an open label randomized control trial including children between 5 to 15 years with poorly controlled asthma defined by asthma contra ACT and childhood asthma control test. And intervention was azithromycin 10 milligram per kilo per dose 3 times a day, 3 times a week for 3 months along with a standard treatment, and priority outcome was this course. And secondary outcomes were how these children behaved. So you can see here that the score showed a significant improvement in azithromycin group, well-controlled asthma more in the azithromycin group, and medium IQR number of exacerbations were improved, suggesting that it may be useful. However, there was no difference in the FeNO, spirometry parameters, throat swab positivity, and adverse effect. And so interpretation is you can use azithromycin in difficult to treat asthma or poorly controlled asthma 3 times a week for 12 weeks and see that they improve. So to summarize, asthma prevalence is decreasing over the last 3 decades. In community, asthma is missed and there is a significant scope to improve diagnosis and treatment. This is onus is on pediatricians. For objective demonstration of reversibility, you may use PFR, though it is not comparable to spirometry. Increase in PFR of more than 15% bronchodilators that suggests that there is a reversibility. HSCRP may be objective measure for control of asthma. Impulse oscillometry may be used for exercise-induced asthma. Stepwise treatment is suggested by Zina may be considered for all to begin with. Pranayam may be useful adjunct therapy, and immunotherapy may be considered in sensitized individuals. Thank you very much.
Thank you, Professor Kabra, for your excellent lecture. And any questions, or we will go to the second part of this session.
I have a question to Professor Kabra. Sir, you have said that with pranayam, there is no change in the lung function, but at the same time you have mentioned the inflammation has come down. That means by FeNO or something, the FeNO level has come down. Probably this, you have shown it to slides. How is it
Sir,
possible?
if you see the absolute change in the FeV1, that would be, say, 0.5, 0.6 liters per this thing. So that will require a huge sample size. And that's why we could not document. But for the quality of life and change in the other parameters, the sample size was adequate.
And regarding this inflammation marker, FeNO,
inflammation markers,
it gets improved.
It improved but did not reach to a significance because of the same problem of sample size.
Thank you, sir. Hello. Doctor.
For the second part, yes, Dr. Pallab Chatterjee, moderator of this session. I will request Dr. Pallab Chatterjee to... I will request Dr. Pallab Chatterjee to invite the panelists on the stage and introduce them.
Good afternoon, everybody, and I am here to learn from my experts. So we have our incoming IAP NRC chairperson, Dr. Rawat, and our current West Bengal chapter of Pediatric Pulmonology chairperson, Dr. Shantanu Bhakto, and my good friend, Dr. Kaustubh Chaudhary, a well-known intensivist from Calcutta. So these are our 3 experts. And we also have Dr. Kabra. And why do we have Dr. Kabra here? Because of these 2 rules. Rule number 1, the boss is always right. And rule number 2, when you are in doubt, see rule number 1. And I am here to learn, and I have special thanks to Dr. Shishir Modak for his special permission to use these slides. So Gina, they met in around 1998 in May, Barcelona, and they decided that we will start having these guidelines. and this year's guidelines were published in on 22nd of May, and they have this every year, the World Asthma Day, which is the first Tuesday of May every year. And this year it was 7th, next year it will be the 6th of May, and like that we'll have days. And they always have these, what they say, the theme. So this year the theme was Asthma Education Empowers. So basically you empower people with asthma with adequate education, you empower the healthcare personnel to increase their awareness. And we all know it's one of the most common communicable diseases, large number of people are affected, and a huge proportion of them are from the middle income and low income countries. So we are going to talk about GINA guidelines, because we know they are guidelines, they are not laws, so they are meant to be broken, though laws are also broken very often. And there is a lot of gap between guidelines and practice. So what is the solution to this? So this is an under 5 child, a 3-year-old, recurrent wheezing since the last 1 year, mostly febrile periods every 2 months. Recently they are lasting for more than 10 days. So every episode of wheeze is lasting for more than 10 days. And somebody had done a chest x-ray and a CBC. Nobody says that I have done it. Somebody had done it and had sent it to me. And this child was given salbutamol nebulization at home and sometimes in the doctor's office also. And so they found, the parents understood that this is the treatment. The hospital charges it for it, the doctor charges it for it. Let me buy a nebulizer at home. So they were giving the nebulizer at home. The child was responding well. The child was not responding nowadays, and later history had shown that the child also had a few atopic rashes, and the father also had a history of allergic rhinitis. So we'll start off from by Dr. Kaustubh. So what was going wrong? So what is happening? What is the problems that many practitioners are doing, and what is the correct treatment as per GINA?
Thank you, organizer, for giving me this opportunity. And when we are talking about this case, this is an OPD case or something like at-home case. But we get to see a lot of cases of PICU patients who are actually coming to emergency with status asthmaticus and then subsequently collapses when you just give nebulization without oxygen. Because, you know, in hypoxia is one of the factor for asthma patients. And if you are not correcting hypoxia and giving only nebulization with salbutamol, there will be definitely the VQ mismatch, and that can lead to cardiac arrest state also. So in these conditions, GINA is quite clear about that we need to continue not only nebulization with the short-acting beta-agonists like salbutamol, but also give some anti-inflammatory drugs like inhaled corticosteroid. So inhaled corticosteroid plus SABA or inhaled corticosteroid plus long-acting beta-agonist is the current statement from the GINA.
Yeah, so that is a very, very important point that Kaustubh has made. Being an intensivist, he sees these patients day in and day out, and there have been a lot of studies that have shown that children who are nebulized without oxygen tend to land up in the ICUs or in the hospital very, very sick. So giving an oxygen is very important if you want to nebulize or use MDIs. And Dr. Shantanu, you want to say something? Yes.
In the first place, the history was not taken properly.
Yes, yes.
We could see that later on, we found that there is a family history of allergic markers and also personal atopy. So history should be taken properly, and then the treatment should be started, not only with nebulization, but also with maintenance dose.
Yes, sir.
So in under 5 children, GINA 24 has given a very clear guidelines regarding probability based. So they have given 3 boxes where you can easily categorize the children under 5, where you want to categorize on whether they have got low probability, moderate or high. So good history taking in under 5 children is very important, where you can put them in these boxes and you can start the treatment whatever you want.
Dr. Rawat, why do they always talk about this 10-day thing? What happens in 10 days? Like they say more than 10 days, less than 10 days, coughing for more than 10 days, less than 10 days.
Yes, so studies have studies have shown that those children who have got prolonged attack lasting for more than 10 days or more than 3 per year, they are those children who require a long-term maintenance of ICS. So studies have shown clearly that this is the dividing line. If you have symptoms lasting for more than 10 days in each episode or more than 3 per year, that is the group where you need to start putting them on controllers. So 3 things: attack more than 3 per year, more than 10 days, and family history of atopy or asthma.
Yes, so
Personal
this
or
is
family. This is very important.
not a very hard, fast cutoff, no? It's not like somebody who says that give me 7 days, I'll catch all the rapists. So it's not possible like that. There's no fixed cutoff value. So it's 10 days means grossly, usually all the viral cough will go off, but doesn't mean so. You can have a viral cough that can persist for more than around 1 month also. So this girl, Bharati, she falls in the third box.
I just like to add one thing more, that even if the attacks are severe, a child might get only 1 or 2 attacks in a year, but if they are severe, again, these children, they qualify for long-term control and management. So severe attacks also qualify. He might have 1 attack in a year, but that requires for long-term controller.
Okay, so these under 5 wheezers, you need a very good history. That is very important. So you should not miss out on that. Have a very good history, clinical examination, rule out atypical wheezing, and then you have this uncontrolled symptoms, and you have the interval symptoms, more than 3 episodes, you have a high probability of asthma. You give a trial of inhaled corticosteroids. So you give a trial of inhaled corticosteroids, but you see these children again at 6 weeks. Professor Kabra, I wanted to know why this 6 weeks? Like, usually what we do is we always say you give a trial of 3 months. So it does not mean 3 months. You get them back at 6 weeks. And that is where you have to assess. Sir.
Yeah, you will like to know whether there is some improvement or he requires something more. So it may be 4 to 6 weeks as long as the patient is showing some improvement. If not improving, then they should come early.
Yes, so basically what happens is, remember, these are always the under 5s, no? They have a lot of other things that are attached. So it might not be asthma at this age. So if it does not respond by 6 weeks, you have to go back to the drawing board and see that you have done something wrong. You're barking up the wrong tree. It is not the usual run-of-the-mill under 5 Vs where you just write a prescription for 3 months and call them after 3 months. And if there is a good response, then you give them for 3 months and then you stop it. You do not wean. That is very important. You stop it. But again, sir, I wanted to know that many people often say that supposing if it recurs, the symptom recurs after 3 months, how many such trials you can give for 3 months? अच्छा, फिर से आ गया, फिर 3 महीना दो, ठीक है, बंद कर दो, फिर से आ गया, फिर 3 महीना दो. How can you do that, or you have to continue with the inhaler?
If there is a asthma, there is a wheezing which has responded to 12 weeks and then you have stopped and there is a recurrence, then you will treat it as a full-fledged asthma. It is not something like you will continue to give a trial.
Exactly. So, trial of inhaled corticosteroids is 3 months. There is no called, like you give a trial, again you give a trial, again, that's not there. Tarikh pe tarikh nahi hoga. You diagnose, you continue. So if the second time the child comes back, you know that you are dealing with something that is asthma, and you probably now have to think in terms of asthma, even if it is a under 5.
And at that stage, the diagnosis changes from some people may be writing recurrent wheezing, under 5 wheezing, like our residents write, and then it continues for years together under 5 wheezing. But once there is a recurrence of symptoms, you have decided to treat it with asthma, then it becomes asthma.
Asthma. So you have to have this thing to write the diagnosis of asthma, and there is nothing else. So there is nothing called a hyperreactive airway disease, there is nothing called a wheezy asthmatic, there's a wheezy bronchitis, and all these things are not there. It is only asthma, because once you label a patient as asthma, it is much easier for the parents to accept the diagnosis, and it is easier for you to say, and we should not shy away from writing the term asthma, even if the child is less than 5 years of age.
So,
Yes,
so the line is that if it is an under 5 user, you are giving a trial of ICS, and once you label as asthma, he goes on stepwise management, step 1, 2, 3, 4. So there is a difference in management. Under 5 user, they are giving a trial, and once you label as asthma, the child goes on the stepwise management. So there is vast difference in how do you manage that.
And it's also easier for you to explain to the parents that, see, you had given this trial, the child was so much better. Now you stop, the child is bad. So that means that you need to control his symptoms. Now, above 6 years, spirometry, that is what Gina says. That recommends spirometry for all children above 6 years because, as Professor Kabra was saying, we are a country where we have excess of both. We have more, we have less. So people, like everybody will go on to develop, they will be writing asthma for all patients, and we might be over treating also. So we need to find out. So Dr. Rawat, how many pediatricians actually advise spirometry before starting? Is there a percentage? Why is it so low, and why is it important to do it?
We don't have any percentage in India, like how many percentage of pediatricians they are doing spirometry, but now we are extremely clear. From IPNRC, what we are doing asthma training modules, we are doing advanced asthma course. We are very emphatic that spirometry is an easy test to do, easy test to learn. It is again not very expensive. The equipment, the cost has gone down, and I cannot give any statistics, percentage of people using it, but I can tell the house that we at IPNRC, we are trying to promote actively. And one bottom line, it is an easy test to do, to interpret, to follow, and it makes your asthma management much more evidence-based.
Sir, can you go on to this thing, like what is, this is the typical chart that we see. So for the benefit of our viewers, like, can you explain this chart, the spirometry, what do we usually see?
Okay, so you get two types of chart. One is a volume time graph, which you can see on the right side. It is like that, and the second it is a flow volume loop. So just for beginners, if you can see the flow volume loop, the top is an PFR. Whenever there is asthma, that top is going to go down. Then you can see the downward slope where normally it is straight. If you see a concavity, probably that is indicating airway obstruction. So just on inspection, you can tell if the peak is low, your PFR is low. If there is a concavity, it indicates that there is an lower airway obstruction. In the right curve, it will tell you about the FEV1. So if a curve which is showing a downward or a bit obtuse slope, it indicates your FEV1 is going down, and it's taking a longer time to reach. So just on inspection, if you don't see even the values, you can tell this child is having asthma. Then you have some values like FVC, FEV1, and the ratio of my FVC. So the ratio, the earliest indicator of asthma is that the ratio FEV1 FVC, it will go down below 90%. So just on seeing that value, you can tell that child is having an airway obstruction. It will have a normal FVC, low FEV1. You do bronchodilator, and then after that you see FEV1. Any improvement of FEV1 by more than 12% it indicates asthma. So values, they might look intimidating initially. You see that EKI is, what are these curves and all. But slight training, and it is very easy. On inspection, you can tell this is a curve of an asthmatic child. And again, you have to input only three values: FEV1, FVC, and ratio FEV1 or FVC. These three values, and you can interpret and you can diagnose asthma very easily.
So what is changing now, as Professor Kabra said, is probably we will be shifting away from the 12% to the 10%. Probably we will be going in the coming years to LLN rather than these percentages. But there will be differences, like when you get the results from different labs, no, you have to see, sometimes they will write FEV1 by FVC, sometimes they will write this FEV1 ratio, so both of them are same. And you should have a look at this volume time curve that the child has done the procedure. So you should see whether the start was good and whether the expiration was for an adequate period, because many times what happens is children, no, they will do it for 1 second. And then you get a ratio where you see 107%, 110%. So you feel that this child is obviously asthmatic, but you're not getting it because the child has blown out for not more than 3 seconds. So at least for 3 seconds they should they should blow out. Okay, so if spirometry is not available, as we all discussed, we can use PEF, and this was what was said just now by Professor Kabra. And you need the variability. So you need to see the child's personal best. So Dr. Shantanu Bhakta, can you elaborate on this, the PEFR?
Okay, where spirometry is not available, if there is no timely access to the spirometry for some reasons or other, we will go for the PF. At least some objective tests are necessary beyond 6 years to document that the patient is having asthma. In that cases, PF, though less reliable, but at least something to be done. And based of 3 measurements done in the morning, Dr. Kabra said earlier, in the morning and in the evening, and you take the average of it. Based of 3 measurements, we take it as a personal best. And bronchodilator reversibility is, if it is more than 15%, we take it granted. More the variation, more the chance of having the patient of asthma.
So we know that the airways are at its widest in the morning, minimum in the evening. So you take the morning and the evening, subtract, divide by the mean, and take a percentage, and that is the diurnal variation that you see over a period of time.
I'll just put one qualifying statement is that although GINA and the WHO has permitted the use of PFR for diagnosis of asthma, but that is a crude test. So even if you are doing PFR to diagnose asthma, start the treatment, ultimately you have to do spirometry whenever it is available. So don't get satisfied by doing PFR and think that I've done my job. No, spirometry is the gold standard to confirm asthma. So even if you are doing PFR to confirm asthma and starting the treatment, please get an access to spirometry and do it. Again, I want to repeat, it's an easy test to do, easy to interpret, and now it is available mostly across India.
Thank you, sir. That's a very, very important point, that spirometry is the gold standard. And then PFR is a very poor relative of spirometry. So you cannot compare PFR because it's mainly the larger airways. And what happens with the asthma, it is not the larger airways, it's the smaller airways that is getting damaged. And initially you will get the small airway diseases. So maybe the oscillometry is a better test, but then definitely you cannot use a PFR to diagnose. PFR should be used to monitor asthma. So that is very important. It should not be actually used to diagnose asthma. But for the time being, yes, you can do it, but it's used to monitor asthma. So we have the cough, wheezing, typical symptoms. The child has come. We know it's written all over the forehead that the child is asthmatic. But then we use control. But the child is not controlled. The child has come to us first time. We've never used inhaled corticosteroids. So how useful is the level of control before starting the treatment? So how do we say it's level of control? Who wants to? Kaustubh, you want to?
I think if we see the diagnosis of asthma, it's obviously a clinical diagnosis, and that is supported by your spirometry or PF. So when you are going for this simple diagram that is showing that the level of control in the form of whether these 3 points, that is daytime symptoms, whether it's getting more than twice a week, or limitation of activities, there is nocturnal symptoms, and lastly the need for reliever. If it is obviously there is something like controlled, then partially controlled and uncontrolled. So obviously according to the numbers, if it is following that at least none of them is involved, then obviously it is getting controlled. And if it's like 1 or 2 of these 4 points, then it's partially controlled. And if it is all of them are not like 3 to 4, then obviously it is not controlled at all. So to begin with, if we have clarified that as per the symptoms, the classification, then possibly with the treatment we can come to know whether an uncontrolled become controlled or partially controlled or not.
Yes, so Dr. Rawat, can you?
So basically the concept of control is in a child who is treatment naive is to find out what is his level of symptom to determine the long-term management. And a child who is under treatment, what is the degree to which the disease has been changed by the drugs. If the disease has been changed significantly, you can change the step, go down or up. So a child who is treatment naive, level of control decides the long-term management. And a child who is already on treatment, level of control decides how do you go ahead with the treatment, whether you step up or you step down.
But when we started, Professor Kabra, we started off with this intermittent and persistent, then mild, moderate, severe. Now it's all dumped into the Hooghly and it's not there in the GINA guidelines only. It's all control.
It is just to make it simplified and our life easy. So that you have a baseline characteristics of a patient, started on some intervention, and you are using the same parameter foreseeing whether there is an improvement or worsening, so that you can step up or step down. Earlier also we used to say intermittent, mild, persistent, there was more subjectivity. That's why this is to make our monitoring more careful.
So that intermittent, persistent and all that is not used anymore. So it's only the level of control that we will now see. The cough variant asthma, so all the symptoms may not be present and there is only cough. So is there something called a cough variant asthma? And how do we deal about it? Dr. Shantanu.
Okay. So amongst the asthma, this cough, shortness of breath, all these things are there. But only cough as a primary symptom, we can have many causes like chronic upper airway, cough syndrome or postnasal drip, sinusitis, GERD, all these things, eosinophilic bronchitis and all. So cough variant asthma is also one of that type where cough is predominant. There is a nocturnal worsening, exercise induced also is there. Sputum eosinophilia is there, FeNO is also increased. Airway hyperresponsiveness, spirometry is normal. Only airway hyperresponsiveness can be seen in bronchial provocation test. So in these cases, later on wheezing is more dominant and trial of ICS is usually done to treat these type of child.
Professor Kabra, we always talk about this FeNO and this TH2 and TH1. Is there a way where we can upfront decide whether this is TH2 and TH1 and have a patient-directed treatment straight away from the very beginning?
So we are in a process of getting some biomarkers which can help us in deciding whether it is a TH2 or low TH2.
Low TH2.
And those biomarkers are still in evolution. Otherwise, you can say that you do IL-4, IL-5 and IL-13, 17 and then this will be a TH2. But these are not standardized and not easily available and not possible to do. So we are waiting for the better biomarkers. As of now, if there is a peripheral eosinophilia, sputum is showing some eosinophilia, then we can say that it is more likely to be eosinophilic inflammatory disease.
Is there any role for doing a total serum IgE in these children, or should we do a specific IgE for all children?
As far as IgE is concerned, as we ourselves are very clear that some of them are having a eosinophilic inflammation. Some of them are having a eosinophilic inflammation by some other route. And many of them may be having a neutrophilic inflammation. So IgE would be raised typically in eosinophilic inflammatory asthma. So no role of doing it in all upfront. They can be done specifically if a patient is not responding and you are suspecting that it may be a allergic bronchopulmonary aspergillosis or allergic bronchopulmonary mycosis or something like that, then you can do it. Otherwise, no. Specific, it was discussed in the morning that as of now, there is no typical role in the beginning. In selected patients, you can do it.
And no role for doing a total serum IgE in any patient?
No role of total serum IgE in the beginning when you think that I'll be able to make a diagnosis of asthma.
Unless you're planning for omalizumab or something like that.
Yes, in case
of. Patients, confirming a diagnosis in patients who are already on ICS, Kaustubh, how do we do it?
The child is already on ICS, and if that is symptomatic, then possibly the symptoms on ICS. So you can always go for spirometry if it is more than 6 years and get the diagnosis. But if it is like the child is already on, along with that, the SABA or short-acting beta agonist, then obviously you need to give a gap of 4 hours before doing that spirometry study. And for LABA, it will be almost like 24 to 48 hours. And you can always check that FEV1 by FBC, just what we do in the spirometry. And also you can check the that variability of like FEV1 by PF, and if FEV1 is more than 70%, obviously you can step down the treatment because it's responsive for 2 to 4 weeks and reassess. But if it is less than 70% of the FEV1, then possibly the child is uncontrolled, and then you have to step up the treatment.
So, Dr. Rawat, how frequently would you repeat spirometry in a child who's on well controlled on
So before you diagnose asthma, first time at diagnosis it is important. So you do spirometry when you diagnose asthma, and after that you should do at least minimum after say about 6 months to 1 year, and 1 to 2 spirometry depending on the symptom. If it is an uncontrolled child who is not getting controlled by your step, probably you need to do it more frequently. So spirometry has got two roles. When you do at the beginning of therapy, it is important for diagnosis, and subsequently when you do spirometry 6 months or 1 year, it is more important to diagnose for his long-term management as a follow-up whether he is responding to treatment or not. And ideally, when you stop the treatment, you should do spirometry, all parameters normal, then you can stop the treatment. So it is important for diagnosis as well as for follow-up.
Now, Gina says that salbutamol alone should not be used as a reliever. And how often is this followed in practice? And why is suddenly this change in Gina? Why is ICS controlled containing therapy should be started right from the time of diagnosis in children over 6 years? And as sir was saying, maybe above 4 years. And what is an anti-inflammatory reliever?
So studies have clearly shown that if you are using only salbutamol as a treatment, as a reliever, and not using ICS, incidence of acute exacerbation, they are much more high as compared to you are using along with ICS. And a prolonged use of SABA would lead to airway hyporesponsiveness, more amount of airway inflammation, more amount of acute attacks, and more amount of exercise-induced symptoms. So Gina is very clear in the past 2 to 3 years is that whenever using salbutamol, you must use it along with ICS. Even at step 1, whenever using as required to reliever as a SABA, you should always add ICS. So that bottom line is there. Never use SABA alone, first thing. A new term has come in 24, which is AIR, anti-inflammatory reliever. Meaning to say that, again, you are not using SABA alone, you always are going to add an reliever. So a combination of salbutamol along with budesonide, this is an anti-inflammatory reliever. If you are using on, about earlier, combination of formoterol along with budesonide, because formoterol you are using as an reliever because it has got a dual effect, early as well as late. So a combination of formoterol along with budesonide, this again is an AIR because you are combining a reliever, formoterol, along with an anti-inflammatory. So this term AIR has come that whenever you are using at step 1, you never use reliever alone, it is always reliever along with an anti-inflammatory, short-acting reliever along with an steroid.
Professor Kabra, they say that you use budesonide along with salbutamol when you use this combination of SABA and ICS. So if I have a combination which is provided to me where there is a SABA and beclomethasone, can I use it? Like I don't have to give them two different this thing.
That can be used, possibly that can be used. One is ideal. Ideal would be budesonide and salbutamol combination, or both are given together in a different MDIs. But if this is available, it's also okay, but it will be an inferior choice than the combination.
And what about using salmeterol? So if somebody is, and supposing somebody is on salmeterol, can we use it as a MART, or if not, then what do we use as a reliever in such patients?
As of now, the recommendation is that if someone is taking a salmeterol and budesonide or fluticasone combination, then that should not be used as a MART. MART should be used when we are using this combination of budesonide, because studies are done on this combination.
Yes. So Gina says that MART is the preferred treatment, particularly in a little bit older children. And like we have discussed enough about MART, I don't think we need to go into MART anymore. So Gina recommends that MART is to be used in children above 12 years in step 3, step 4, and also in children above step 6. People are now using it even in younger children. And what we need to remember is that the maximum doses that is allowed for formoterol, that is very important. So when you are using MART, we should remember that above 12 years till adults, 72 micrograms is the maximum dose of formoterol, and 6 to 11 years it is 48 micrograms, that is the maximum dose of formoterol. So that's how you come to that figure of 12 puffs and 8 puffs. That is what is, because formoterol is fixed. So when you use the combination, the budesonide increases. So you remember that 12 puffs above 12 years and 8 puffs below 12 years. So that is the maximum that you can be used.
So only thing I have to add is that, as Saras told, we have got two types of LABA, salmeterol and formoterol. Salmeterol is a long-acting beta agonist. It has got an early onset of action, whereas formoterol has got dual action. It has got an early onset of action in couple of minutes, along with a longer action over a period of 24 hours. So only formoterol can be used for MARD because it has got a dual action, and salmeterol has got only long action. It's not used for MARD. So MARD is only formoterol along with budesonide, not salmeterol.
Okay, so we have a 13-year-old girl who's got a frequent cough and breathlessness, waking up at night 2 to 3 times in a week. Her spirometry was done, and FEV1 was 75% of predicted with a good bronchodilator response. So she was put on step 3 treatment with MART, and after 1 month she was followed up. She was not well controlled. So what other points should we check? So Dr. Shantanu, is there anything else that we need to check in this child? What are the risk factors that have been missed?
Yes, yes. So in this case, as there is night waking, it's already in step 3, and rightly pointed out that step 3 treatment is started. But then the child is not well even after 1 month. So the other things we have to take the drug dose delivery device. You have to check the adherence, the technique, and the dosage, and the drug, proper drug is given or not. The practitioner should check personally at every follow-up visit. Every time the patient comes, you have to check this drug dose delivery device, the inhaler dosage, all this. This is the most important step in the long-term management of asthma. And this is the gap that you are pointing out.
So this patient has come to me, 13-year-old. Her mother is very confident. She is giving the drug. The patient is taking the drug, but it's not getting controlled. And they come to me. They are using this they are using this thing, absolutely correct technique with a huff-puff kit. So what is going wrong?
So maybe there are some modifiable risk factors are there. So we have to check.
What we need to, Kaustubh wants to say something.
Sorry.
I think so if it is not responding inside of getting a good technique is followed, so possibly you need to look for the comorbidities along with that asthma, whether that is associated with other things like allergic rhinitis, something like GER, gastroesophageal reflux disorders. So those factors should be checked for, and then subsequently look for whether there is a need for any step up of the case or not.
One thing that is very, very important is we've seen many patients come to us quite old. They are still using this huff-puff kit which somebody had prescribed when they were quite young. And that, I'm sorry I'm taking the trade name, but it's basically the mask and the spacer. So the mask should be removed as soon as possible. That is very important. So above 4 years, there is no need for using a mask, because when you use the mask, the drug delivery to the lungs comes down even further. So you have to be very, very cautious. Every time we should ask the patient to get the device, to demonstrate in front of you, and you know that patients who are very well known to you, you know that they are doing everything right, but suddenly they can come up with some funny ideas which you never thought they could do.
Vallabh sir, studies have shown that whatever effort you may do to train the patients, 80% of them, they will have attrition of the skills in initial visit only. 80% studies have proved. So you might have spent so much of time in telling them how to use the device, but most of them, they do it wrong. So always, never accept your follow-up without a device. Always they should come with the device and demonstrate in front of you how they are doing it. That is very important step.
Okay, so I've noticed a few movements in the front bench over there, so I need to hurry up. So this was the modifiable risk factors that you were talking about. And now we come to the allergy test and the AIT. So what is the role? Gina says that slit can be considered for children. and particularly in children with, where how frequently, how many practitioners are advising allergy tests? And Professor Kabra, what is your take on immunotherapy and allergy tests in children?
As I said, this is one of the add-on therapy and may have a potential of changing the course of illness. But as of now, whatever evidence is there, that is based on the allergic rhinitis and sensitization to the house dust mite. So as of now, we do not have a very good studies which compare that if you give a standard therapy and you add a allergy immunotherapy, then whether it improves the quality of asthma control. So it can be used, but we need more evidence before we say that it is useful. Second thing is that it really requires a training. Someone expert should be doing it rather than every one of us starts doing it.
So basically what Gina says is HDM slit. So that is what they specifically write, house dust mite sublingual immunotherapy. The reason being that is the one that, so we need, if we are dealing with allergic rhinitis, asthma, there is no need to treat this child with a Coccus nuciferus, that is a coconut, or say camel, or say whatever. So, you need to be very specific. Cockroach allergy is very, very common in our country. It's extremely common. Put up your hand, which house does not has seen a cockroach in their house. So everybody will have cockroaches, but you can't do an allergy immunotherapy for cockroach. It's not worth it. It does not work. So HDM is the one that is recommended for two things. One is it has got a direct link with this with allergy and asthma, and the second thing is there is something called a immune tolerance. So if you can desensitize this patient against HDM, probably the reactions to others will also come down.
Pallab sir, one point I like to add is that immunotherapy is never the upfront therapy for asthma at all steps. Even Gina permitted at step 2, 3, 4. Step 2, you have to first try your optimum medical management. Come down to your optical management by ICS. Still the child is not responding. He has got a comorbidity of allergic rhinitis. Strong clinical history that child could be allergic to some air allergen. So optimal steroid therapy, along with that there is associated comorbidity of allergic rhinitis and a clinical correlation. Then that is condition you should do your allergy skin testing, confirm. If it is proved, you can go for immunotherapy.
So a few quick answers. Kaustubh, role of Montelukast.
So Montelukast is mainly used for if it is comorbidity like allergic rhinitis is associated, or if it is like exercise-induced asthma, then Montelukast can be used.
And what about my favorite Montelukast levocetirizine combination?
No, it's absolutely no. And if you would really want to use, then use it separately if it is
Short
allergic
answer,
rhinitis.
no. High dose episodic ICS treatment at the start of wheezing in preschoolers?
It's not a prepared one. Absolutely no.
Okay.
One thing, Pallab, this side effects throughout this GINA 2024, it is being told that side effects of leukotriene inhibitors, it is neuropsychiatric side effects are there, newfound night terrors and behavioral problems, even suicidal tendencies are there. So you should be very careful when you are using these leukotriene inhibitors for a long time.
Sir, your experience, Dr. Kabra, about the side effects of leukotriene inhibitors, because we see it not quite rarely, it's quite seen actually.
Yeah, we prescribe very minimal, occasional. That's why we do not have much experience of its side effect.
So no experience about effects also. Okay, irrational prescriptions to be avoided. I won't waste time. So oral salbutamol, theophylline, terifylline, rotacaps in young children, and mucolytics. So these are things that are not supposed to be used. And okay, so this is something very important that we need to come to is advice regarding how to avoid triggers and a written asthma action plan. Dr. Rawat, quickly can you run through this asthma action plan?
Again, this is a very important step to empower the parents regarding how to manage asthma at the home. because asthma is a disease with variable symptoms and variable time it can precipitate. So you have done a very good job, given a very good step, but child can again deteriorate, exposure on or trigger, sometimes viral infection. So you must empower the parents how to manage. So asthma action plan is a stepwise management where you tell what are the symptoms of uncontrolled, mild symptoms, what you do, moderate symptom, what you do, and at what time they have to come to the hospital. So it is a very good tool to prevent or to manage symptoms at home. And if they are having more symptoms, they can start treatment, come to the hospital so that partial treatment is being started and the child comes in a good shape. And very important, you empower the parents to start steroid at home. That is a very important step of asthma action plan, where a child who is having severe symptoms, before coming to the hospital, they give a dose of steroid and they come to the hospital because steroid takes about 4 hours to act. So giving steroid at home and coming to the hospital, child has already received a dose of anti-inflammatory, child has started responding, comes to hospital in a better shape, responds better. So I think that is a very important step which we should remember.
Yes, so and you have these three, the red, the yellow and the green, the traffic signals that you see, and then it depends on your PEFR reading and all that. So coming back to the asthma action, GINA, whatever this year's World Asthma Day theme, so as we started off with it, that asthma education empowers. So to summarize, in under 5 children, symptom pattern.
Just 1 sec. For oral corticosteroid therapy, this is worth mentioning that 4 to 5 courses of oral corticosteroids in a lifetime may be a cumulative risk for that patient. So remember, this is very important and you should be very careful in adding oral corticosteroids on and off.
So under 5 children, symptom pattern should be assessed as GINA boxes that we saw 3 boxes. Trial of ICS 3 months. Spirometry should be done in children above 6 years before starting treatment, and thereafter you assess the level of control using PEFR, and risk factors for future exacerbations always should be considered. Allergy testing, if you think it's appropriate, child is not getting control, you can consider immunotherapy. Avoid irrational drugs and combinations even if they don't sponsor your lunch. And parents and patients' participation extremely important in successfully managing asthma. Thank you for your patience and sorry for overshooting.
Last statement, never tried that you can treat asthma. Always tell I can control asthma because asthma cannot be treated. So never give a guarantee I can treat asthma. Always tell I'll control asthma. Treatment, there are no treatment available, but I can ensure child can have a normal life.
CRP. You said about highly sensitive CRP.
You might have seen in adult cardiology ICUs, they do highly sensitive. One is CRP, routine CRP, which is measured but in a larger amount, say more than 1 milligram, 6 milligram, and you are doing it in your pneumonia and other infections. Highly sensitive is when it is able to, say, measure even a smaller amount.
Sir, is it
the same, but it is measured in a smaller amount.
The cutoff is 0.5 probably in HSCRP.
Prognosticate asthma.
No, it is just we have used it whether it can be considered as a monitoring tool for control or uncontrolled asthma, not for the prognosis. So if there is an inflammation, it should be reflected in the blood, and because that is easier to perform even better than FeNO. So whether it can be one of the objective parameter for assessing the inflammatory response.
Thank you, everyone. Actually, we had kept this session till 9 p.m., but we had to cut it short because everybody has to catch their flight. So asthma is such a thing, we can't cut it, end the session. Thank you very much.
Thank you, Pallav, for an excellent session.
Panelists for the beautiful session. No, I think we can't invite any more questions because of time. Thank you.
Dipankar. Dr. Dipankar Das. Okay, note করে দিয়েছে Dipankar presentation? না. our last session, last but one session, not the last session, the session on radiology. And তুমি উঠে পড়ো ওর সিভিটা দেখি তো The chairpersons, Dr. Rana Chatterjee and Dr. Bidhan Bhuiya. May I request Dr. Rana Chatterjee and Dr. Bidhan Bhuiya to be on the dais. Dr. Rana Chatterjee, please. ও পরে হবে কোন Dr. Dipankar Das, his topic is MRI lung and unutilized organs.
I am myself Dr. Bidhan Bhuiya. I am a general practitioner, but I am very much happy to introduce our Professor Dr. Dipankar Das, the academic pillar in IC is also one of the pillars, and he will deliver his lecture. The MRI is not the unutilized ordnance in this modern field. The floor is yours now.
Height of modesty. Bidhanda is not a general practitioner. He's a consultant pediatrician. So I introduce my chairperson. So usually, previously, after X-ray, we used to straightforward go to CT scan for further delineation of lung pathologies. That was the trend when you started practice. Later on, ultrasound was used only for delineation of pleural fluid or any collection superficial because of air. You don't see the deeper structures nicely on ultrasound. So MR was primarily tools for brain and spine, and later some parts of the body like joints and muscles, and still later for abdomen, and almost lastly for lungs, because the principle of MR is based on proton. Proton is hydrogen ion. That means H+. So it has to be in a fluid state to get rid of the electron, and the nucleus contains only plus charge, that means proton. There is no nucleus in hydrogen atom, as you know. So that actually gives the MR signal. In our every body fluid, there is H+, you know. So they are randomly distributed and moving. When you put them in a magnetic field, they align themselves in a certain direction. If you give a radio frequency pulse, then they go to a higher energy state. And if you switch up the pulse, they come down to the normal state. So they release energy. That energy is the actually signal of MRI. So this is the basic principle. I hope I can make you understand that in a very lucid way. But the hydrogen or this proton content and their matrix, that means the macromolecules around the protons are different. So that actually characterizes different tissues in different ways. But unfortunately in lungs, air is the predominant thing, 70 to 80% is air. Air does not contain any hydrogen, as you know, and there is no proton. But in the vessels and blood, there is proton, so 20 to 30% is proton. So this is a basically proton deficient structure, lungs. So that was the main hindrance for lung MRI imaging. So later on, there was development, continuous development of hardware and software. how to get rid of all these things. Fortunately, when there is some pathology, there will be some amount of fluid collection, what you call edema. If there is some mass, then there will be soft tissue component plus fluid. If there is thickening of interstitium, there will be some increase in collagen tissue, some amount of increase in water. So that is the supplier of proton. That is a very fortunate thing. So we can expect to get MR signal from that. So here in the images you see the hydrogens are randomly distributed in the lower part of the image, and in the upper part here you see it is actually aligned in the field of magnetic direction, that is the Z axis. And these things, what is written, I have already described. You know T1 and T2 weighted, the basic principles, basic MR principles. That means they are the characters of the tissue. And depending on T1 weighted or T2 weighted, these are determined by the machine parameters. That is how much echo is given, at what interval it is given. That determines the T1 and T2 character of the substance in the body. And intermediate weightage may be there, which is called proton density. So there are so many types of sequences, and every day new sequences are coming for better delineation. But one thing is important for the clinician is resolution. That means whatever we see, how crisp it is, how beautifully we can see. So resolution is a very common term, high resolution image, better resolution of the equipment, these things. But resolution actually are of three types. One is spatial resolution, which is 2 points in space. How much you can differentiate, how well you can differentiate, how closely packed points you can differentiate is a spatial resolution. Space to spatial. And another thing is contrast resolution. That means if the brightness of two or intensity of the 2 points are different, then how better you can appreciate that. That is the contrast resolution. Another thing is temporal resolution. Temporal means related to time. That means this acquisition, how better this acquisition in a dynamic structure like heart, blood vessels. So that is called temporal resolution, which is needed in MR cine images for cardiac MRI principally. So for CT scan, this spatial resolution is the best. That means if two closely packed focus are there, 2 points are there, best resolved can be, best appreciated can be CT scan. But contrast resolution, that means intensity or brightness differentiation is better on MR. That's why on MR, soft tissue contrast is better delineated, and for soft tissue MRI always scores over other modalities. And temporal resolution depends on the speed of the capturing capability. How that means if it is a faster equipment to capture the images, then the real time or movie or cine images will be better. That is called temporal resolution. Another problem with terminologies to the clinicians are HRCT versus MDCT. There is nothing called high resolution CT nowadays. High resolution CT, the word came when there was a problem in the equipment because of the larger slice thickness. In the large slice thickness, if you don't process that in a sharp filter, you can't see the structures nicely. You have to have a thin section. So these were optional for the equipment. You have to create those things using the parameters for different pathologies in lung and temporal bone. These are the two areas where HRCT or high resolution CT was applied in the previous instrument. So it is now a history. Nowadays, all CT scan manufactured by all vendors are multi-detector CTs. That means the rows of detectors are many, and the source of the X-ray may be 1 or 2 depending on single or dual slice, dual source. So they will bombard the photon, and that will be received in multiple detectors. So the spatial resolution is very high, and at a time multiple informations, multiple rows of images are formed in a volumetric manner. That means when you scan the entire volume. Suppose you scan the lung, you will scan the whole thing in 15 to 20 seconds, breath hold. So after acquisition of the whole volume data, you can reconstruct that in any plane, in any thickness. So there is no question of HR or high resolution. You can make it in 0.5 millimeter, you can make it 5 millimeter as you desire. So there is no question of high resolution nowadays. All images can be made high resolution depending on your requirement. So if you write MDCT, then it is to be done. In some centers, there may be older models. They will not probably do this patient. Because if you write MDCT, that is sufficient. If you want to put contrast for a specific reason, you should mention that. That is one. Another thing is regarding radiation dose. Radiation dose guideline, you know, LRA. LRA means as low as reasonably achievable. That you know any amount of radiation is not safe or not desirable. But radiation is needed for diagnostic use. So for one chest X-ray, usually 0.1 millisievert is the dose which is given. But for CT scan, you can see 8 to 11 here in the last part of last line, 8.1 to 11 millisievert may be the dose in case of a thoracic CT scan. Especially if you do contrast, that means you do plane study, again you repeat. So it is doubling the dose. But there are ultra low dose CT scan nowadays available because of the increased sensitivity of the detectors. So the amount of radiation dose is less. That is 0.1 to 0.3 millisievert. That means this 0.1 is equivalent to one chest X-ray. So one CT scan, if it is equivalent to one chest X-ray, nothing can be better than that. Why MRI is not so popular, or rather it was not so popular, in spite of radiation safety, and there is less requirement of contrast. Because in CT scan without contrast, many a time you can differentiate lymph node from the vessels and better delineation of the lung mass, etc., or any vascular pathology. But in MR, fortunately, rarely we need contrast. Most of the time we don't need contrast because of the better contrast resolution, as I discussed. Soft tissue delineation and the difference in shades are much better in MR. So, but still it is problematic in children because of restlessness of the child. It takes longer time. The child has to remain motionless. We use oral sedatives routinely. If it is not, then IV sedation or by anesthesia. And there are other things that are involuntary movements like breathing, cardiac activities, and peristaltic movement in the abdomen. These are also produce motion artifacts. So traditional sequences, I am not going detail into the sequences. You can make a breath hold sequence or a triggered sequence. That means whenever there is stoppage of respiration in between, that means relatively shallow respiration, then that time the machine triggers, and that time the data is data acquisition starts. In that way, these triggered sequences are done, but it is time consuming. So these questions are often asked as for lung, MRI is better or CT is better. For abdomen, MRI is better, CT is better. These are very simple and childish question, because not only on the body part, it depends on the what pathology and what is clinical question you are asking. So that actually determines the modality you use, and maybe at times you need both. You need both CT and MR for particular pathology. So for MR, chest wall, mediastinum, pleura, these are very good. And for lung masses, MRI is basically not very good for interstitial lung disease when it is in early stage. And some small nodules, calcifications, tiny calcifications, these are not a good candidate for MR. So for CT, this interstitial lung disease is the best delineated or best appreciated by CT scan even in the early stage, and because of the increased spatial resolution, even 3 to 4 millimeter nodule you can image. More than 4 millimeter, 5 millimeter you can image on MR. So MR often is preserved for follow-up study. So this is one patient with CT scan. So these are differential ventilation or mosaic ventilation pattern. These are bronchi, these are on CT scan, we'll be discussing next. So newer things are there with ultra short T or 0T, which actually increases the speed of the scanner and reduces the motion artifacts. So I will show you the image. And another thing is hyperpolarized gas, that is helium or xenon. After inhalation, the images are taken, but unfortunately, they are limited availability and they are expensive, so not used routinely. So this is ultra short T images, only 21 seconds is the acquisition time. You see beautifully, you can see the lung vessels as you see in CT scan. This is done in our scanner. And this is another advantage of MR. See, in our equipment, this is not available in all equipment because our equipment is a high-end 3 Tesla unit. So we can do star angiographic non-contrast study. You see these vessels, you can see the heart and all the veins and arteries, everything, even the pulmonary veins, IVC, aorta. This is a non-contrast study. Without giving any contrast, these images are obtained. So this is a great advantage of MR, advanced MR equipment. And this is the hyperpolarized lung MRI. You can see the differential distribution pattern in different diseases. For pleura and pleural effusion, you can see these are the white fluid extending into the fissure. So this is in axial images, this is the pleural effusion. And if it is encysted, it looks like this. So this is the pleural fluid and this is the encystment. At times it looks like a mass. But this was a real mediastinal mass with superior vena cava syndrome. You can see distended veins here. So there was a pancreas tumor here, which is compressing the superior vena cava. Another mediastinal mass. And this patient actually came to us, known to us, for cervical pain. So that's a great advantage of MR. While doing cervical spine, we got some disc and other things according to his age, but the real pathology was here. There was a pancreas tumor eroding the ribs. You can appreciate here. So this is a speculated mass. This was a malignancy diagnosed by biopsy later on. So this is a great advantage of MR that you can see the additional pathologies. So middle mediastinal cystic lesion, the commonest thing is bronchogenic cyst. You can see the bright fluid containing cystic structure. Another confusion often happens in chest X-ray because of thymic enlargement. Thymus you can well appreciate by putting a suprasternal probe in ultrasound. But even then, if you are in doubt, as in this patient, say this is a diffuse opacity here, looking like some consolidation. And here also you can see looking like some bulging fissure, but this is actually an enlarged thymus. On MR, you see a homogeneous soft tissue intensity. Another important thing is diaphragmatic pathologies, often difficult even in ultrasound. So you can see the herniation of the liver beautifully. Here you can see how many times this bell will ring. Please stop. This is the Morgagni hernia. You see this colon is herniating into the anterior mediastinum, and in the frontal projection you can see the colonic outline here. But undoubtedly, confidently you can see that colonic loop here pushing the cardiac image, cardiac shadow posteriorly. So another thing, you see, consolidation is very well seen in MR. See, air bronchograms and some high intensity things are there inside. And this is a age-old image. When we had 0.2 Tesla images, far back, around 15 years back, we got some mass in the atrium. So what is the diagnosis? This is a star image. This is a T2 weighted and, this is a T1 weighted and this is a T2 weighted image. You can see a soft tissue intensity. So what is the diagnosis? Left atrial myxoma. No, this is not left atrial. This is right atrial because the anterior atrium. So the slide is intentionally it is written just to check the audience, their attentiveness. So another patient with hamartoma is cardiac rhabdomyoma. This is a known patient of tuberous sclerosis which produces cardiac hamartomas. These are small, characteristically small projections. And this is another image with our old machine. We could pick up this coarctation of aorta here. Huh? Okay. So, cystic fibrosis and all these things will come. So, we don't need to discuss here. But for follow-up study, this is needed. And this hybrid lesion, that means pulmonary sequestration and CPAM, that means congenital pulmonary airway malformation, they may be together. This is another example of that. These things will come in the next part of the presentation. This is a excellent image of lung. See in the same patient, you can see, this is the last concluding slide. You can see on the left side it is normal. On the right side you can see the bronchial thickening. You can see the encysted effusion. Here also pleural thickening and lymph nodes. Here you can see the lymph nodes here. You can see everything in the same patient. So that was the point of keeping this slide here. So this is a horizontal fissure. This is the oblique fissure. You can see the fissural thickening. You can see the interstitial thickening also. So that's why interstitial lung disease can also be followed up by MR. So thanks.
Thank you, Dr. Das, for your nice presentation. We learned many things about MRI chest, but only two things. We have to overcome the cost and availability, then we would be able to use it more widely. Thank you. Thank you so much. Now,
cost is nowadays not a factor, I think, because the price is much less than previous.
now regarding HRCT, if we compare the cost.
Compare with CT scan?
Yeah, CT scan.
No, but CT scan has got other disadvantages.
Anyway, thank you so much. Thank you. Now we have to move on for our next session, the panel discussion on recent updates of GINA guideline that changed our practice. Oh, no, oh, Poretta, sorry. Oh, the changing shades of gray, yeah. What is new in pediatric lung imaging? I would like to invite Dr. Shubhashish Rai, our moderator.
I'm there.
Please,
Already there.
Thank you, Shubhashish.
So, Shamik, Amita, Dr. Dash is here. Prabhash. Where is Prabhash? Prabhash Prashungiri. Oh, Atish, chale. So without wasting much time, let me start. Now this is a session on lung imaging. Basically, Dr. Dash has taken up the MRI part. So I will not be discussing the MRI part. I will basically talk on USG and CT of lung, and let us see how much we can, amar slide ta dao. And let us see how much interesting I can make the session. So basically, I am not going to teach what is MRI, what is USG, what is CT, and not the very basic things I am going to discuss. So we will discuss the common indications of each modality and to discuss what is new. That is the main focus of this 45 minutes. So we will discuss what is new here. So basically, so far as the modalities of the lung imaging is concerned, 1970s the world got the CT lung. And 1990, the spiral CT introduced. 2007, use of magnetic resonance imaging or MRI started. We started utilizing MRI lung from 2007. Slightly later in Indian subcontinent, in Western world, they started using it 2007. 2015, development of dual energy CT and providing better use of characterization and material differentiation. And 2020 onwards, and in coming 4 to 5 years, you will see artificial intelligence more and more to be utilized in the lung imaging. So my first question will go to Dr. Amita. Lung USG, how often you use in your institution?
So usually lung USG we are doing when there is a hemithorax, when we suspect there is a pneumonia and to see whether there is an effusion associated. That is the commonest time when we use the lung USG to see how much of effusion is there and to decide whether a chest drain needs to be put. So that was the commonest indication, and also POCUS has come up in a big way and it has revolutionized the treatment of many lung disorders, and in the ICU setups, it helps to diagnose and manage many things.
Right. So what is the relevance of this picture of World War II with the lung USG? Yes, any answer? Because in World War II, they used to use the ultrasound to detect the enemy ship or submarine. So used to measure the distance from one submarine to the other. So ultrasound is being used from 1941 to 43, 45. So next question to Dr. Shopon Roy, Professor Shopon Roy. Perceptions about utility of lung USG in general pediatrician. What I like to know, you have so many PGTs and students and you have many pediatrician friends. So how they perceive the utility of lung USG? How often they prescribe? How often they utilize this thing?
Actually, whenever we see something in X-ray and we find something abnormal or any pathological disease, if you want to confirm that particular pathology, say it's a peripheral or just subpleural, any radio opacities in the chest X-ray, we have to confirm whether it is the pleural thickening or something pneumonia subpleural. And sometimes to what we use in our hospital, if I just find any pleural effusion, to assign how much fluid is there, so we have to do a USG chest. And it is a very fantastic modality of getting how much fluid is there and all that. And nowadays, what we have seen, that pediatric pneumonia, now the modality has changed from chest X-ray to ultrasound. We can jolly well diagnose.
So students, your students and other friends, they are using the USG optimum. That's your perception?
Yeah.
Okay,
Very
so all of you agree?
Yeah.
In your practice, all of you see that the general pediatricians are using USG quite frequently?
No, not that. Because I work in a hospital, it's a teaching hospital, that's why I do it.
Right. Okay. So, Dr. Shamik Basu, what are the indications for doing lung USG for a general pediatrician? When they should do it?
Very easy. So you use USG for diagnosis of certain problems. Those are 4 Ps: pneumonias, pleural effusions, pneumothorax, and pulmonary embolism. These are very well diagnosed. There are other indications as well. As neonates, with Amita will say, we can diagnose RDS, we can diagnose TTN, we can diagnose other neonatal malformations as well. Now the second thing is therapeutic. You can give drugs, you can give streptokinase, you can give USG guided drains and pigtail catheters. And the third one is the most important. You can even prognosticate or follow up patients by USG in cases like pleural effusion, empyema, and other complicated lung conditions where patients are under ventilation in ICU. So it is a great...
Okay, Prabhas, a child who has come with a tachypnea and fever, you are suspecting a community-acquired pneumonia. Will you do a chest X-ray or lung USG?
No, definitely chest X-ray first.
Okay.
Because definitely even if we get any sorts of abnormality in the chest X-ray, we'll do the ultrasound in this patient. If we don't get any abnormality in the chest X-ray, again we'll do the ultrasound in this patient.
So what is a POCUS? You are doing it every day.
POCUS is basically the point of care ultrasound that we can do in the bedside basically. So in our ICU, we regularly do ultrasound. Not only the respiratory cases, actually all the patients, those who are on respiratory support, ventilated due to some other reasons, any PUO, any sorts of patients. So in PICU, most of the patients being admitted are undergoing a lung USG at least once in a day.
So the message is very loud and clear. Basically, we utilize the USG basically for any any lesion which is close to the pleura, any pleural pathology. In consolidation also, in the 22nd edition of Nelson also, they have said X-ray and USG lung can give the equal amount of information if the lung USG is not better. So I will spend only 1 minute on this. The physics of lung US, it is nothing very difficult thing, but lung US is unique because it's predominantly artifact based. Artifact based means it is showing something which is different from the structure of the tissue. Like in the cloud you see, the cloud formation is like a lion. It is not a lion, it is a cloud. So similarly, when you see the pleura, it is a bright structure, but it is actually because of the artifact produced by the interface of pleura and the air-filled lung. So most ultrasound waves are reflected at the pleura. Acoustic impedance mismatch. The lung is filled with air and the pleura is a soft tissue. So there is a mismatch of the impedance and that produces a shadow, resulting in a hyperechoic pleural line, or it shows a white line for the pleura. Air-filled lung parenchyma cannot be directly visualized in ultrasound because it does not reflect anything. You need to have a reflection from the tissue to the transducer, then only an image will be produced. So it does not reflect anything, so you can't see only the air. So A-line artifacts are the reverberation artifact of the hyperechoic pleural line. So that is the thing, that means the pleural line is, this is the pleural line, the A lines are these things, these horizontal white lines are A lines, and here it is produced by, there is an acoustic mismatch between the pleura and the air-filled lung. When the lung is filled with fluid, then we can see the B lines, that is a straight line, and when you find the B lines, A lines are usually not present. There are exceptional circumstances when you can get some A lines, but when the lung is filled with fluid, it is the B lines, and the B lines are, B lines are basically straight lines from the soft tissue to the lower part of the lung. Lung collapse or consolidation removes the A line, allows for the direct visualization of the parenchyma. Then you don't get the B lines. You can see the lung as the same opacity, as the same structure or composition as that of the liver, like this. Pleural effusions, both complex and simple, are also directly visualized because anything which is close to pleura or within pleura very easily can be picked up by the ultrasound. And if a pulmonary abnormality is not in the secondary bronchiole, deeper structure, then it is difficult to pick up by the ultrasound. And majority of the life-threatening or acute or severe events, fortunately, are juxtapleural. So that can be picked up very easily by the ultrasound. Prabhash, when you are doing a lung ultrasound, do you follow all these 6 segments?
Yes, yes. Whenever we are doing the lung ultrasound for a patient for the first time, so usually we put the probes in this region only, in the anterior chest wall, in the axilla as well as in the posterior chest wall. But whenever doing a follow-up study, then only the point where it got the abnormalities, sometimes in very hurry you only focus on that areas. But ideally, whenever you're doing a lung sonography of the chest, you have to focus all these areas.
So this is the parasternal line, this is the anterior axillary, posterior axillary, and it is divided a line, imaginary line through the nipple, and this is the paravertebral line. So it is done in the 6 segments, the image is taken in the 6 segments. And next question goes to Prabhash also. What is a bat wing sign?
So bat wing sign, basically if you put the ultrasound probe, so we can see you can get the lung parenchymal shadows that can be characterized by the equidistant hyperechoic A lines. And there are some subcutaneous tissue below that you can get the pleural line that is also hyperechoic, very bright. and you can see this rib shadows are there, the two rib shadows are there. So these two rib shadows are there, and in between these two rib shadows there is a lung segment is there. So it's imaginary findings that called as a bat wing sign. These are characteristics of the normal lung.
So the horizontal lines are A lines, and this is the rib, this is the subcutaneous tissue, and below the rib there is no reflection of the sound wave, so it looks like black.
The first thing that you need to identify the pleura. The pleura is very much hyperechoic, it's bright and it's moving on the respirations.
Right.
It will help to identify the pleura.
So this is the A line. When there is a reverberation artifact, that means the wave is coming and back to the transducer. So that's why it produces multiple A lines. When it is fluid filled, it gives a straight lines which is known as the B lines. And when it is consolidation, it completely a different thing. It looks like a liver or a homogeneous or inhomogeneous substance. So the next question goes to Amita. What are the utility of lung USG?
As has been discussed, obviously to differentiate between any solid or cystic lesion or utility, as we already said that in a pneumonia, whether how much of fluid is there, whether to put a chest drain or not, and to also follow. So instead of doing repeated X-rays, nowadays we all follow the ALARA principle, which is like as low as reasonably achievable. So that means like lesser radiation is always welcome. So instead of doing repeated X-rays for a pneumonia, when you want to see whether the child is improving or not, whether the effusion is reducing, and to take any decisions about chest drain, the best modality would be an ultrasound. And also it is more sensitive and accurate than the chest X-ray or even a CT for characterizing a pleural fluid, whether it is simple or whether it is empyema. In fact, CT, the role in a pneumonia has reduced very much. It is only done in very specific cases where when you have to go for a surgery or a VATS, and to also in very complicated cases of lung abscess or whether you want to decide whether there is any necrosis or not. So ultrasound has taken up most of the places. If you have a good ultrasonologist or even a pediatrician who is doing a POCUS, can decide, and also in case of neonatal RDS. So it is very important because neonates, we can reduce the chances of radiation also when we decide about surfactant and subsequent improvement.
So Professor Shrapan Roy, what looks black in ultrasound? Which structure looks black? Which structure looks gray and which structure looks white?
So I'll start rather way round. The hyperechoic will be the air and the deeps. And the soft tissue is the gray one. And the left one, which is a darker, is the fluid, or we call it anechoic.
So fluid will be black.
Hyperechoic is very important because air, usually we know, is radiolucent in X-ray. But here you have to keep in mind, if you see any opaque or whitish shadow, it is either air or bone. So in the lung, if you see air, it is the definitely it will be whiter, will be the air in the lung.
Right. So Amita, how much USG lung is utilized in NICU?
So we in the last 1 or 2 years, during the follow-up of cases of RDS, in fact it can be used to diagnose RDS also, because in RDS there is a score wherein you divide the lungs, both the lungs, into 3 segments: anterior, superior, anterior, inferior and lateral, and you give a score of 0 to 3 for each segment, and for total 6 segments the total score is 18, and any score round about 8, a median score of 8 helps you decide that it is a case of severe RDS wherein surfactant requirement should be there. And also to, there would be, I will just come to the scoring of that. So these, there will be a lot of B lines and coalescent B lines, and consolidation also would denote RDS. So these are some of these, this is the scoring, that is just as was said that A pattern is only if the A lines are there. That is a normal lungs. So normal aeration, normal lungs. You can also see the mirror image of the liver on the right side and the spleen on the left side. So that is a normal aerated lungs where only A lines are seen, the score is 0. If it is a B pattern, that is around 3 or more of B lines which are well spaced. So that gives you a score of 1. If it is C, that is severe B pattern, that is the presence of crowded and coalesced B lines with or without consolidation limited to the subpleural space, that is a score of 2. And a score of 3 means D, which is extended consolidation with maybe air bronchogram pattern or maybe simple consolidation which looks almost like a liver. A ground glass appearance, and in RDS remember that this will be bilateral and equal on both the sides,
Right.
whereas in TTN this will be only scattered in some areas. And to remember in TTN that it is more, the B lines are more crowded at the caudal areas, and in the superior areas they are very sparse. So this gives a gradation of the echogenicity which is known as double lung point. So this is seen in TTN, and in TTN the B lines will not be seen in bilateral regions, so they will be scattered, and also in TTN there will be normal lung sliding which may not be there in RDS.
So this is the double lung point, because if you see, this is a cranial and this is a caudal part. So in the cranial part, you can see a normal lung. But in the caudal part, you can see broad B lines. So this is the wet lung part, and this is a better part that is on the apical part, that is a cranial part. You can see some areas of normal lung. And this double lung point is very sensitive and specific. Earlier, we used to think it is almost 100% sensitive and specific for transient tachypnea of newborn, but now it has been found the specificity is close to 80% and the sensitivity is close to 50%. So, Dr. Shamik Basu, do you want to add anything so far as the neonatal use of the
Neonatal use is
ultrasound?
already good, but we can, the latest thing is we use now ultrasound for antenatal detection of risk of child developing RDS in premature child. And that would help us to determine whether we should give antenatal steroids, when and where, how much.
And the prognostication after
and the
giving
prognostication
the
is, Amita,
surfactant
as she showed the severity from A, B, C, D. Now, once you give surfactant, you have another beautiful thing is, if you do the insure approach, it is okay. But if you ventilate the child, you can come back to D, C, B, A and see whether the child is improving. And as the child is improving, you can extubate, and you can forget about the second round of, and you can prognosticate the child directly in front of patient party, and which will help in the counseling of the parents also.
Right. So this is a 7-year-old child, fever more than 103 degree Fahrenheit. The child presented with high fever and abdominal pain. The total count is 22,300, neutrophil 82 and CRP 86. Professor Dipankar Das, you are sitting idle for a long time. Can you describe this X-ray?
Sorry, I was sleeping. What is your question?
My question is that, can you describe, is there any abnormality in this X-ray?
No.
Dipankar, is this X-ray normal or not?
Inferiority complex
Left-sided
inferiority.
Need an MRI for confirmation.
Dr. Shapon Roy.
It is nearly normal, excepting the left costophrenic angle.
Right. Left costophrenic angle, there is an amount of opacity and it is siloting on the diaphragm. So this is the abdominal X-ray, which represents almost a normal abdomen. Nothing much is there, relatively less gas shadow. And this is the lateral X-ray. Professor Shapon Roy, what is there in the lateral X-ray?
Gladly.
Actually, there is opacity in the posterior fornix. If you see the posterior costophrenic angle, there is the opacity. So, yeah, that is the thing. And by taking the history and the total count, you can jolly well say this is a airspace pneumonia.
Right.
Because abdominal pain is the deferred pain, and there is some amount of opacification. Actually, if you look carefully in the first X-ray, the right dome of diaphragm is well delineated, but the left dome of the diaphragm is not well delineated. This is the clue in the diagnosis and the history itself. So it is the consolidations left lower zone. As the cardiac effects is not blood, it is blood. it is not a case of lingular segment pneumonia of the left upper lobe.
So, ideally, the diaphragm can be traced from
Another
the
thing,
claustrophrenic angle
just
up to the cardiophrenic angle. Yes, Dr. Das.
No, because Dr. Rai is deficient in some point. So I'm just adding that if you carefully look in the first lateral projection, the lucency usually increases from above downwards.
From top to bottom.
But you see the lucency is not increasing in the first one.
It has rather decreased.
So it is decreased and there is some opacification.
Yes.
That is a strong point which should point that there is some consolidation or some opacification in the left lower zone.
And USG was done. Shomik, what do you find?
USG, see there, if you see
What-
the left lower side.
What
there
is
will be-
this?
This is the yes side.
Dr. Shapon Roy, what is this?
Actually, you
Straight
were
side.
seeing some bright and hyper-echoic spots. So I told you earlier that the hyper-echoic shadows usually seen in case of the AR. So what we are seeing at the AR bronchogram. So
Yes.
it contains definitely a consolidation.
This is called the shred sign.
And what Dipankar has told, this is the basics of the chest radiogram. If you just see what is the adequacy, just the before one. So in the lateral view, lateral X-ray. So that in এটা সরিয়ে দাও এটা সরাও এটা এই আল্ট্রাসোনোটা সরাও. If you just see the vertebral column, more cranial the vertebra is, it will be opaque. More caudal the vertebra, that will be the lucent. So these transitions usually shows the adequacy of the lateral fin, that we have to keep it in your mind. And more the caudal, cranial one will be radio opaque and more caudal will be radio lucent.
Lucent. So in many of the literature, they have spoken much in favor of the lung ultrasound. You have seen that, you can see pleural effusion, the sensitivity specificity is close to 92-93%. For pneumonia, it is 95-90%, pneumothorax 87-99%, and systematic review. These are all systematic reviews and meta-analysis. And for pulmonary edema, it is 88-90%, whereas in chest radiography, it is much, much, much less. So we are definitely, day-to-day life, we are underutilizing this lung ultrasound. So a 2-year-old child, fever for 7 days, tachypnea, and total count was 12,800, neutrophil 78, and CRP was 82, and we started ceftriaxone. Now, after starting ceftriaxone 4 days later on antibiotic, no change in fever, and the maximum temperature was 103 degree Fahrenheit, total count was increasing, 13,000, neutrophil 80, and CRP 92. Will you do a CT or any other modality, Amita?
Subhash, may I pitch in?
Yes, please.
So why have you done after 4 days another X-ray? Because if the condition, clinical condition...
The child deteriorated.
So that's why this is the chance where you can go for a USG or SVT.
No, before
USG
doing
would be better.
Yes, before doing USG, we did a
We want to minimize the radiation as much as possible.
I completely agree, but it was done. The X-ray was done. So, Dr. Prabhash,
Yes, so
what next you will do?
So definitely I will do a lung ultrasound in this patient. So the diagnosis...
You will not do CT?
No, definitely not.
Okay. Because of radiation?
Not due to radiations. The information that I used to get from the CT, I also get from the lung ultrasound. So why you should go for the CT scan?
Okay, so the USG was done and it was found minimal pleural effusion is seen in the internal septation of effusion 6.5 millimeter. So how much fluid is there?
So 6.5 millimeter means around 130, 120, 130.
Right.
But that septations are there and it's insisted the amount may vary basically.
Right.
Around 100.
So we added linezolid, fever increased to 104 degree next day. The child was not toxic, the child was playing in between. And the total count was slightly high, 15,600. Neutrophil same, CRP was even higher, but the child was not toxic. Will you do a CT right now, Shomik?
No, I would wait.
You will wait. Why?
Because if you see the child is
not getting any toxic anymore. So child is clinically improvement. First we'll look at the child first and then the investigations later. If the child is improving clinically, we can jolly wait for some time.
So will you do another USG or not?
Yes, absolutely.
So the USG has shown even the fluid thickness has decreased. And ultimately it was found there was a thrombophlebitis which was causing the fever and which was the cause of leukocytosis and higher CRP. This is a question for the audience. A 2-month-old infant, breastfed, no fever, mother was on ATT till end of second trimester. Weight gain was normal, intermittent episode of respiratory distress. What is the diagnosis? Right-sided? Yes? Pneumothorax, okay. Any other opinion? Rotated film. Not exactly. If you see the, yeah, it is slightly rotated towards the left side slightly.
So definitely this is a right-sided hyperlucent lung.
Yeah?
Right-sided hyperlucent lung is there.
Yes,
So definitely.
You just consider the age. It is not 1 day or 2 day. What Joydeep was pointing, it is not 1 day or 2 day.
So it is a congenital lobar overinflation, right upper lobe and right middle lobe. Okay. So I have to move fast because only 13 minutes are left. 7-year-old child, fever, tachypnea, total count to 22,000 and neutrophil 77. Shomik Basu, this is the X-ray. Will you do a decubitus film?
In today's scenario, I won't do a decubitus film. I would rather do an USG here.
So we are almost the lateral decubitus film has gone oblivion. We all do USG, lung USG, and that picks up the pleural fluid much faster. And if you see, sorry, just 1 second.
Always remember, for fluid in the lung, USG is the best choice. USG loves fluids.
So if you see this video, you can see a collapsed lung which is floating in the fluid. So we will not do any lateral decubitus. The USG will pick up.
This sign, last slide. Please play the video. This video clip. Okay. This sign, the collapsed lung on the lung fluid, is called the jellyfish sign.
Yes, right. This is a jellyfish sign. This is an 18-year-old male, fell from a height, trauma to the chest wall. Mild tachypnea, what investigation you would like to do next? Prabhash.
So definitely.
Is there any abnormality or this is a normal X-ray?
Yes. There are some, I think, there are some breach in the rib as well, and there are some suspicion opacities in the left side. So I definitely go for a lung ultrasound first. If I don't get any extra info in the lung ultrasound as a history of trauma, some bony injuries may be there, then I can go for a CT scan.
Shomik?
So there is a fracture of the rib, and along with a little, if you see it very careful, there is a air trapping, there is a small pneumothorax above it. So you go for a ultrasound and we'll see the next. Yeah.
So this is a normal.
See the ultrasound.
This is a normal
this
ultrasound
is the
of
pleural
lung.
line. This is called the pleural line. This is the merging point between the visceral pleura and the parietal pleura. As the lung moves, one of the pleura moves. So there is a beautiful sign called lung sliding sign. So sliding lung sign, the line is continuously in movement with the movement of the lung. Now, whenever there is air between the visceral and the parietal pleura, this sliding stops. And if you see that the pleural line is present, but it is not sliding anymore. Now, this is the lung point. There is a rocket-like projection suddenly coming in between, and this is pathognomic of pneumothorax. This is the interjection point between the normal lung and the part where the air is trapped.
Right.
So, whenever you get this, and if you do an M mode, you will get a stratosphere sign or a barcode sign along with it. M mode means the motion mode of the ultrasound. If you put two pictures side by side at the same level.
Lung point is almost 100% confirmatory for pneumothorax. I have to leave the USG part because this is the left hand side. Just 1 second. The left hand side, there is this child is having a collapse here because you can see the crowding of the ribs, and there was a reconstructive surgery of the spine. This one, the child is suffering from a consolidation, retrocardiac consolidation, because you cannot trace the hemidiaphragm up to the spine, so there is a consolidation. Now, how can you differentiate between a collapse and a consolidation? In the consolidation, you can see the dynamic
Yes,
dynamic
Prabhash.
air bronchograms are there.
Yes, Prabhash.
So in both the collapse and consolidation in the lung USG appears like hepatizations, like liver-like structures. But this air bronchogram are more prominent in the consolidation as well as the dynamic air bronchograms there. Means the air bronchograms will keep on appearing and disappearing, keep on appearing or disappearing. So this is a typical sign of the consolidations. But this thing you will cannot get on the collapse. The bright spots are usually static is there. And you can get a sign that is called the lung pulse. As this is collapsed, the heart pulsation will reflect it on this collapsed lung and you can get a sign that is called the lung pulse.
Right. So how to calculate fluid? Already Prabhash has said that it is the Ballick's formula, maximal effusion in diameter, that is from diaphragm to the base of the lung in a supine patient multiplied by 20. So if the value is 6, then it is 120 ml fluid is there. If it is 10, then it is 200 ml. But ultrasound picks up the fluid fastest and the most accurate way. In a blunting of the costophrenic angle, you require 200 ml. Blunting of the posterior costophrenic angle require lesser amount, 50 ml. Lateral decubitus picks up earlier, 10 to 20 ml, but USG can pick it up in just 3 to 5 ml.
Shubhashish, may I tell
Yes.
something? In
Yes.
the USG, I don't think it is the 3 to 5. At least it should be 10 to 20 because
It is even 5 can be picked up.
yeah, but usually we get this in ultrasound. It's a 10 to 20. I don't know.
I have my references. So I am skipping the E-fast ultrasound. So in cases of trauma, we do this E-fast ultrasound examination is being done. 3 points in the abdomen and 2 in the second intercostal region. Earlier it was fast and now it is extended fast, or that is focused abdominal sonogram for trauma. Now, leaving that part, going into the CT, this is a child, AM 15
Just
months.
before going to the CT, just one comment that when you are doing a lung ultrasound for the pleural effusion, you can not only measure the pleural effusion, you can characterize the pleural fluid specifically, whether it may be a case of exudative or transudative. Is it transudative, how much it is an empyema, non-empyema, how much septation is there. Even you can guide the therapy, that what therapy you should do, which is can you give the drainage only or drainage with streptokinase or VATS, everything you can predict with the ultrasound scoring.
So this is a child, 15 months, abrupt onset of cough, and it is persistent. It is persistent for 15 days, mild tachypnea. The child has been treated with coamoxiclav, salbutamol, ambroxol without any benefit, cough persistent and fever for last 2 days. Amita, what the next test you want to do? Or what is the next step?
So this is showing a left opaque hemithorax, that is more of a collapse. So and if the history is taken and if there is absent like breath sounds, then most probably it would have been a foreign body. There's a mediastinal shift. The next best option would be to do an ultrasound or a bronchoscopy.
Okay, so there is an overinflation of the right lung.
Yes.
There is a complete mediastinal shift,
shift.
but there is no collapse. But there is an abrupt onset of cough. Shopon, what you will do in one line?
Bronchoscopy.
Right, but it was done HRCT. And in the HRCT, there you can see there was a complete obstruction of the right main bronchus and sudden obstruction of the right main bronchus, but it is a crime where there is an abrupt onset of cough, doing a CT where it is clearly showing the patterns of a foreign body. It is a crime of doing a CT scan, but the resident has done it. It was a peanut which has been aspirated, and after taking out the peanut, the lung expanded. So, Amita, Shamik, common indications for chest CT.
Usually, indications of chest CT after ultrasound are to delineate vascular malformation, vascular obstructions, or very small lesions which cannot be, solid small lesions which cannot be picked up by the ultrasound itself.
Shopon, when you will give contrast?
CT contrast, if you want to delineate any finer thing, particularly the vessels, or if you want to see the much more contrast between the two planes, so we have to use this contrast. And nowadays we don't need actually.
Yes. Prabhash, where contrast is not required.
This is not right. Nowadays we definitely requires contrast CT scan, because in CT scan if you want to
first thing, differentiate between lymph node and vessel. You have to do contrast CT scan. Any vascular lesion, you have to do. Any necrotic neoplasm, you have to do. Any solid and cystic thing, you have to give contrast to differentiate between solid and cystic things.
So in infective pathology, is contrast must?
For infective pathology, usually
Yes.
you need, because for lymph nodes and for delineation of necrotic component, you have to give contrast. Enhancement, how much, what is the enhancing pattern, if it is homogeneous or only heterogeneous, ring-like. So these informations are important. So
Right.
contrast CT is definitely, but on MR the advantage is without contrast you can get many things which we don't require giving contrast on MR. But that doesn't mean that contrast we don't use or contrast is not needed.
Actually, nowadays we can do some MPR, so multiplanar reconstruction or deformatting. In that particular cases, when we are equipped with that, so we may not use this contrast.
Multiplanar imaging and contrast
Now,
use are separate
just coming to that,
indications.
one very important clue where contrast is not required, like in ILD, in bronchiectasis, or follow-up of CF, you do not require contrast routinely. Okay.
Sorry, follow-up of?
CF, cystic fibrosis.
Oh, cystic fibrosis, huh? For that, often MRI is done to avoid radiation.
Right, yes. So next part is HRCT. Lot of doubts are there. I will spend 1 minute for it. Now, already Dr. Dash has said, nowadays all the CTs are being done in MDCT. But HRCT is still there. HRCT nowadays is a post-processing, where you increase some parts of the lung more sharp to see the smaller structures. Earlier what we used to do, earlier machines used to take the cuts in HRCT, in volumetric, they used to take the cuts here and pasted the information in between in the next section. So that was the earlier thing that we used to do. Sorry. And in HRCT, the information in between the slices were not available. Nowadays, all the data are taken into account and there is a post-processing in the HRCT protocol. But the whole information of the lung is being taken by the MDCT. And this is the MDCT scanners. There are high number of detectors. And if it is a dual source, then one beam is from above, one beam is from the side. And it calculates it takes the image of the whole lung, and there is a post-processing which is being done. I am not going into the details of this X-rays, the last part I am going to that. Yes, there are 3 slides only. 2D and 3D post-processing, this is a recent advance which has been done in last 5 years. 2-dimensional is a maximal intensity projection and minimum intensity projection is MINIP. And there is one term which is known as multiplanar reformation. What is the MIP? The pixels with the highest value are preferentially displayed. So white becomes more white. MINIP, the black parts are displayed more clearly. The 3-dimensional is volume rendering and virtual reality, that is virtual bronchoscopy. So this is the 3-dimensional is volume rendering and virtual reality. So a 5-month-old baby presenting with a stridor, in this axial section, you cannot see the pathology very clearly. But if you do multiplanar reconstruction in 2D axial segment, then you can see there is a complete obstruction of the trachea, and the left main bronchus, there is a large amount of obstruction in the initial part. So this is MPR, and that is the utility of 2D and 3D reconstruction. Second thing is that multiloculated air-filled cystic mass in a 4 days neonate with an antenatally diagnosed congenital thoracic malformation treated with antenatal drainage. And with the MIP protocol, white will be more white. And if you see, this part which is more white and which contains the vessels is very clearly delineated, whereas in mini protocol, you can see there is a lung which is overinflated, can be seen very clearly, and there is an obstruction in the left main bronchus.
I was referring this thing, the left one. You can see the vessels, it was without dye.
Pardon?
It was without dye, but we can see the vessels.
Yes. This is without a dye. This is without, yes. Thank you so much for reminding me. This is without a dye. So here it is without a dye, but you can see the vessels very clearly with the MIP protocol. So these are the recent additions which are being used more and more in 2D and 3D format. 5-year-old child with segmental left upper lobe overinflation. In the mini protocol, you can see the overinflated part so well, so delineated, and which cannot be appreciated so well by the normal axial cut. And volume rendering, it is a case with a 5 months old child with persistent stridor. Here also you can see by the volume rendering, you are seeing from the back, it is a double aortic arch with a right dominant and the left rudimentary, but it is encircling the trachea. So there is an indentation in the trachea as well as the left main bronchus, you can see very clearly. So this is schematic diagram of that. Now that is the last part. I am going to that. So one-liner, bronchiectasis initial diagnosis, MDCT or HRCT, Oberoi?
MDCT.
MDCT, all of you agree? Initial diagnosis.
Bronchiectasis initial diagnosis can...
Okay, so bronchiectasis in a 10-year-old child follow-up, Dr. Dipankar Das. HRCT, MDCT, MRI.
MRI.
Sorry?
MDCT, HRCT, MRI.
After discussing this type of should not be there. Na? MDCT oblique HRCT, then the whole teaching is lost. It should not be in this fashion. It is not an alternative terminology.
No, I am not. What is your preferred modality? Best of the three.
No, the question is, if the bronchiectasis is regressing, then you should not do MRI. Because you may not pick up the residue of this bronchiectasis. If it is very thin, very small, then you have to do
HRCT.
Multi-detector CT with obviously high resolution status.
Prabhash, suspected mediastinal mass, 15-year-old child.
MRI.
Right. Shomik Basu, ILD, MDCT, HRCT contrast. First time diagnosis.
First time HRCT.
HRCT. CF follow-up, MDCT, HRCT, MRI contrast. Amita. MRI in older children. Lung abscess, Dr. Oberoi. MDCT, HRCT.
Now MDCT.
MDCT, yes.
And you should give contrast also.
Definitely. Lung metastasis, Dr. Dipankar Das.
Obviously, once again, contrast CT scan should be the answer. MDCT is a technical thing. It's a machine parameter.
Yes. Pleural effusion, Prabhash. Not USG?
USG.
এতক্ষণ বলে তারপরে এটা বলছি
He was induced by me.
Non-resolving pneumonia, non-resolving pleural effusion. Shomik bhai.
CT করা যেতে পারে.
CT, yes. So, this is the last slide. Life is not always black and white, but a million shades of gray. Thank you so much for your time and attention. I am really grateful that at least 50 to 60 delegates are still sitting at the fag end of the day. Thank you so much. Thanks a lot.
We enjoyed much.
Next session is Chai Pe Charcha. So would request Dr. Debjani Gupta and Dr. Shomik Ghosh to please come up on the dais.
I have a small suggestion. We have chai outside, we can have the charcha outside also. আমি দেবজানি দিকে তাকিয়েই বললাম।
Dr. Gautam Ghosh, Dr. Arun Manglik, Dr. Subhashish Roy, Dr. Shantanu Bhakto, please come up on the dais. Dr. Bharat Reddy. Dr. Bharat Reddy. Come. Yeah. Chalo, Debjani. Let's discuss something. Any questions? See. We have.
May I please request all the esteemed panelists, Dr. Shantanu Bhakto, Dr. Pallab Chatterjee, Dr. Subhashish Rai, Dr. Atul Gupta, Dr. Bharat Reddy. Where is he? Yeah. So please come on stage.
This is
We have
basically
a
questions
fairly
from the
wide
audience.
range.
So any doubts you have regarding the whole day's.
Dr. Gautam Ghosh, Dr. Subhashish Rai, Pallab.
Start. Can I ask a question to the audience? Or rather to everybody here? A mother has, a father has sued you because the son attempted suicide. And why did he sue you? You had prescribed Montelukast to that child for 3 months. The fellow did not come to you for follow-up and gave the Montelukast for 9 months. This was a 12-year-old, and then there was an attempted suicide. The child survived, and then that man, he Googled up the literature, and he found that Montelukast can cause that, and then you have been landed up with a notice, a legal notice that abetment to attempted suicide. How do you respond to that? You leave it to the lawyer, but you'll have to give inputs to the lawyer. How will you defend yourself?
First thing what I would say is, if you have the indications right for writing Montelukast, and if you have given it for the correct duration and the correct dosage, then you can still stand your ground. But then you can always say that I did not write for 9 months. And then also that it's not really 9 months, even a short course can cause problems. But it's not that you take Montelukast for 7 days and you try to commit suicide because of that. So that is very unlikely. So what we usually see is these children tend to get very irritable. They sort of get disturbed sleep issues, and all these problems start coming. But suicidal tendencies probably, yes, there in adolescents, but not that common in very young children.
In medical legal perspective, considering that I've done medical legal degree as well, a lot of it is the side effects of any drug is known. So there are a lot of cases where people have gone to court saying that the side effect of a drug manifested, so doctor is responsible. The doctor is not responsible for the side effect of a drug because it is proven that every drug has its side effect. So as a doctor, like Dr. Pallab mentioned, if you mention very clearly 3 months in your prescription and the child has a side effect because of that, you have no liability in court.
So the clear-cut message here is very clear. Despite the fact that you may not have explicitly mentioned that Montelukast may induce suicidal tendencies, but as per a recent court ruling, it is very clear that since the side effects of the drugs are in public domain, so the doctor per se doesn't have the responsibility of mentioning each and every side effect when he or she prescribes the drug. So that is a very important message for us, that we need not highlight each and every side effect of a drug.
Okay, you have any idea that how long Montelukast can be given without any side effects?
Gautam, please come with your cup of tea, and maybe all the panelists can be served the tea on the dais, please.
So, with respect to Montelukast, there are two types
How
of
long?
reaction as well. Sorry.
Asking you, how long can you give Montelukast
So it
at a
doesn't
stretch?
mean how long. That's what I was trying to get at. Even with some of the children, I've seen they manifest within 7 days with hyperactivity and behavioral changes. So it's an idiosyncratic response, which is why some people will respond, some people will not respond. So they call it as an idiosyncratic response. It depends on your body type. You will react within 7 days as well. So there's no clear-cut duration that matters. It's your body type which reacts to it.
In that case, you have to mention, no? Even if 7 days, it can cause.
So more than suicidal tendencies, behavioral changes, yes. So we do talk about behavioral changes to parents especially. And though we claim in India we don't see it, when you start asking the parents, do you see any change in your child's behavior? Many of them actually start saying, yes, we just thought the behavior was, because they attribute every behavior as childish behavior.
Even newfound nightmares may be there.
Exactly. So a lot of nightmares as well as aggressive behavior has been seen in children as well.
Thank you for getting the session off to a very informal start without any introductions. But that is what Chai Pe Charcha is all about, that we will have a free-flowing interactive session. And myself with Dr. Devjani Gupta, we've been asked to just pose the questions and not even attempt any answers. Right? Okay. So we go on to the first one. These questions, none of the panelists know about, so we've kept it as spontaneous as possible. So the first question to my esteemed panelists is, which patients, we've talked about presumptive TB, suspected TB all through the day, they need to be hospitalized for diagnosis and treatment?
Well, per se, tuberculosis does not mean they need to be hospitalized. It is the criticality of the patient which decides whether the patient deserves hospitalization or not. So if the patient is serious enough to get hospitalized, fine. And that remains true for TB and non-TB as well. Let us be very clear. TB does not mean those days when in the 1940s, when patients of TB used to go to sanatoriums. Those days are gone. So what decides admission is how bad or serious the patient is.
So the message, I think so, is very clear that a clinically stable patient of tuberculosis doesn't require, but if there is any reason for this patient to be unstable and in a life-threatening situation, only that. The next part, I think so. Yes, Shubhashis.
Obviously.
Yeah, that's a critical patient.
And also TB pericardial effusion. Also.
All of them will be having some life-threatening things.
So critically unwell child would require hospitalization per se.
Yeah.
One more thing I would like to add here.
Yes.
One more thing I would like to add here is diagnosis of tuberculosis. So sometimes if you are thinking of a suspected tuberculosis and you are not able to come to a diagnosis, then maybe for doing a gastric lavage or to doing a bronchoscopy in a very young child, you might need to admit for a day or something like that.
Yeah. The question of isolating a patient with suspected active TB. When do you start? When do you stop?
Suspected active tuberculosis. If you're suspecting active tuberculosis, the possibility of dissemination becomes high.
Yes.
So you start away isolation immediately. That's one. When to discontinue? When the patient does not pass on active TB bugs.
So
usually after therapy,
yes,
you start on, if it is rifampicin riff sensitive, then most patients will become non-disseminative or they will not be exuding active TB bugs in a few days itself.
If we were to go by some literature, I mean, we were traditionally taught 2 weeks after starting anti-tubercular therapy, but there is some literature coming in that even within the first week, people stop disseminating. So any thoughts on that or any change on guidelines?
I'm not aware of. I would still stick to maybe 2 weeks to be on the safer side.
So message for the audience, as of now, we stick to 2 weeks after starting anti-tubercular therapy. Gautamda has something to say.
MDR, XDR, HIV.
So those are your exceptions.
He has a very valid point,
Yes.
If you are suspecting active tuberculosis and if there is any possibility even remote of MDR,
yes,
then you are in real trouble. So jolly well be careful of isolating them and keeping them isolated for enough length of time, because if that MDR TB is disseminated, you are in real problems.
And definitely the taking of ATT should be uninterrupted.
Sorry?
If it is an interrupted intake of anti-tubercular drug, then 2 weeks time limit does not hold good.
Yeah, I mean, with the NTP protocols coming into play and with the monitoring being a little more strict, I think now we can be a little more sure about the compliance. Debjanidhi, Alex, the next slide to you. Okay, Debjanidhi, I think so. I'll go to your questions later. I'll take this question. Now, this question is not so much about the technicalities as it is about counseling a woman with a fetus with a large congenital thoracic malformation. So the whole purpose of the slide is that we should be aware of the risks of terminating pregnancy, and at 20 weeks of pregnancy, I see a woman with a fetus with a large congenital thoracic malformation. What would be my counseling to the obstetrician? Has sent it to you for an opinion. What would be your counseling?
The answers could come from the house as well if anybody has any inputs.
So one is the risk of primary lung malignancies is quite low in congenital thoracic malformations. So we do get quite a number of mothers who come with this for opinions, second opinions, especially the pulmonology point of view. Firstly, we tell them that the outcomes of a lot of congenital thoracic malformations is relatively good. We do not see much complications. Many of them get undiagnosed even till adolescence, even till adulthood. Congenital thoracic malformations are completely missed. So that is not an indication for termination of pregnancy most of the time.
I mean, as it holds good possibly in any counseling session, that you place the facts before them and you allow them to take the chance, isn't it? Rather than you dictating to them as to whether they should go in for a termination. Whether they are willing to go in with that chance or not, that is what I think so is more important.
One more thing is very important, that many of these congenital thoracic malformations tend to regress spontaneously after birth. So we have to be like following up these children.
And regress during pregnancy as well. So what is visible at 20 weeks of pregnancy may actually not be the same at term. Yes.
So I think Shangjukta is not here, I think. With SMA, we are seeing a marked difference in treatment and in improving the quality of life. So my esteemed panelists, have you handled SMA patients at home with non-invasive mask ventilation techniques, which has helped them have less complications in their day-to-day life?
I can take this question because we do it a lot in our sleep clinics as well.
Yeah.
So not just SMA, most neuromuscular patients, we do a lot of non-invasive ventilation at home. So I would still say we do a sleep study first.
Yeah.
Before we decide what pressure this child needs to go on, what is the level of obstruction and hypoventilation. So in the sleep study, we also look at the level of carbon dioxide accumulation over a period of the night, and we classify what is the level of hypoventilation. And then we decide whether they go on to CPAP therapy or BiPAP therapy. Eventually, they may require BiPAP therapy, but do we start with CPAP or BiPAP? So to decide CPAP or BiPAP, we do a sleep study with level 1 study where we look at the carbon dioxide accumulation as well. Even the sleep study gives us a approximate idea as to what the pressures need to be set. We then do what we call as a titration study. So after 6 weeks of initiating mask ventilation, we do a titration study. What is a titration study? Is let us say I set a pressure of 8 by 4 or 9 by 5 on the BiPAP for these children. Is that pressure really sufficient or not sufficient? That answer is very clearly visible on a sleep titration study. And in that night, we set the exact pressure which is required to ensure that there are no apneas, no hypopneas, and there is no hypoventilation. If we follow this proper protocol, then yes, the mask ventilation is going well. The most common problems why it doesn't go well is one with respect to adherence, compliance, and if the pressures are not initiated in a proper manner. So in our sleep clinics, we do a very proper protocol that we first start the first day only with the interface. Just like with asthma, the device is the biggest problem in NIV. They don't accept the device. So we start with teaching them how to use the mask first. So one day goes in just making a child comfortable with the nasal mask. The second day we give a very minimal pressure. We put a pressure only of 4 and make them just get used to the minimal pressure. And only on the third day do we set the actual pressure. Again, this is not followed in many places. So which is why a lot of them start refusing and the real effect of your CPAP and BiPAP is not seen. But if we follow this proper protocol and adherence is good, we do see extremely good effects.
So the message is ventilation is going from the hospitals to the homes, and it is going to improve quality of lives.
Dr. Bharat, I was thinking most of these children, instead of CPAP, do they do better on BiPAP? Do they tolerate it much better?
No, so the reason why CPAP is more easily tolerable by children. The discomfort of pushing positive pressure. Now CPAP is not pushed in. CPAP is just a continuous positive pressure which is going in, so it's not uncomfortable. BiPAP technically is more uncomfortable because you're pushing an IPAP. So when you push an IPAP, a child may be breathing out when you're pushing it in. So they fight BiPAP much more than they fight CPAP. So ideally, that's why we don't just start BiPAP for everyone. We have to really see whether they've reached that level where BiPAP can be initiated or not.
Thank you, Dr. Reddy. Devjaniti, this question.
But I suppose this question needs further info being given, honestly speaking. I think this is a bit of an unfair question. So a term infant with breathing problem at birth, the question just mentions respiratory support in terms of ventilation and surfactant. It does not mention, the other things, the fluids, the inotropes, the other investigations. Diagnosis could be anything, starting from a respiratory cause to a cardiac cause to a CNS cause. So I think a bit of an unfair question to the panelists, maybe, but anybody willing to take a bet could do so. So anybody from the house or from
basically the point over here is that this is an NICU setting and we expect a holistic treatment. And we've done everything in terms of fluids, nutrition, electrolytes, when we are giving assisted ventilation, right? Okay.
Yeah, but what I'm trying to say, a breathing problem is not always the lungs. A breathing problem is not always the lungs. It could be other organs as well.
Yes, possible, very possible. But let's presume that everything has been taken care of. You have given surfactant and this child is not responding. Any thoughts?
One of those rare conditions where basically you have almost what they call a permanent surfactant deficiency.
Yes.
I'm sorry, I'm forgetting the nomenclature.
Surfactant protein deficiency?
Yeah, maybe.
Protein
where you give 1 dose, 2 dose, 3 dose, 4 dose. Finally, you end up with realizing that n number of doses you may give, it will not salvage the patient because that dose will last for maximum of 72 hours. Finally, you have to repeat again.
So there is no endogenous production of the surfactant. There is no endogenous production of the surfactant, as a result of which your external administration is just a holding operation. And this is something which requires a genetic diagnosis, which is autosomal recessive.
The surfactant is being produced, which is not.
But having said that, I think what Devjaniti was also pointing out, sometimes cardiac disease also can present just like HMD. One of them is a TAPVC obstructive type. Yeah. So try to rule out because that may have no murmur also. So clinically you may not get that murmur.
Thank
Only
you.
your point is very well taken. In fact, it was assumed that all other parameters had been taken care of and they were normal. After that only we come to this conclusion.
So we classify some of these conditions as neonatal ILDs or neonatal congenital, though it's termed as interstitial lung disorders, it's a misnomer. They come under this entire group of CH-ILDs, which could be surfactant protein defects, or there are certain defects which are also called as alveolopulmonary dysplasias, which also manifest like this in the neonatal period itself. Though broadly classified under neonatal ILDs, they're not interstitial pathology at all.
And some of these, like the NEHI and all, no, they have a very good prognosis. So they can, if you can pull on for some time, they'll actually come out of it. And even the surfactant protein deficiencies, no, the A and C are good. The B, A,
there are 4 proteins, so they are A, B, C, and D.
Good. B
so
and
it's
C.
the B which is the most severe. A and D are mildest, and the B is the one which is most pathological.
But NEHI will present slightly later, not so early.
Not so early, not in the neonatal period.
There's a question from the house.
Yes,
so
please.
Dr. Bidhanda has sent this question. Use of oseltamivir in office practice.
Use of?
Oseltamivir
in office practice.
In office practice. So any of the experts, please?
Oseltamivir would be used only if you have a diagnosed case of influenza A, and sometimes in a setting where you have the ongoing epidemic of influenza going on and you have a very sick child who's admitted to a PICU. So you may start off oseltamivir, send the swab for influenza, and if it turns out negative, you stop it. You don't continue for the full course. But then just writing an oseltamivir as an antibiotic and something like using a cefixime for a cough. So all these things should not be used. There are some specific things. So should avoid oseltamivir using empirically, because now influenza has been like resistant, oseltamivir resistant flu is like there are strains of oseltamivir resistant flu also.
We'll probably be inducing it.
I'd like to take this question further, probably to Dr. Arun Manglik. From continuing from where Pallav has just left it, the empirical use of oseltamivir. By the time you get your results, are you legal? Are you? You've kind of written it down. You've documented the use of the drug. Are you legally liable in the the swabs come back negative? Where do you stand? Number one. Number two, there is a so-called finite time period as to when you should start the drug during the course of the illness. You have missed the boat, but you have still started. The patients probably come to you on day 6 of the illness. You've sent the swabs. You've started the drugs empirically. The swabs come back negative. A, you didn't start it fast enough because the patient didn't present, and B, you started it empirically. So how rational? How are we legally liable?
Depends on what is the standard of care. It does not depend on anybody's whims or use. The standard of care as such does not warrant that you start oseltamivir with every patient who comes with any fever. It will boil down to something like when you have a meningitis, suspect meningitis, you start your drug straight away because you are dealing with a life-threatening situation. You get the cultures later on and then you may step down. But here, situations, nothing like that in this particular area. What we have done, as of now you pointed out that the child has come, you suspect this child has an influenza. Now if there is an epidemic going on, then if you start off up front, take the samples, the pharyngeal swabs are. The reports usually take 24 hours. They come back 24 hours. Negative, you can stop. Positive, you continue. That's one part of the story. But if there is no epidemic going on and you start off, maybe you are doing wrong in most of the situations. Now, on the other side of the story, you wait. You don't start off oseltamivir, but you do the nasopharyngeal swab. Again, the question clearly mentions sending nasopharyngeal swabs in OPDs. How justified or logical is that considering the costs? Okay, so now in the situation where you have not started oseltamivir, there is not an epidemic situation, you have sent the samples despite you're not being expected to send samples on day 1. But since you know very well to start oseltamivir, you have a window for around 48 hours. So you send the samples straight away and you get the results maybe at the end of 36 hours fever. assuming 12 hours was taken, but the patient came to you, and then you started off, maybe you are jolly well fine. As far as law is concerned, there is nothing against you. Because there is no standard of care written down that you got to start off oseltamivir on day 1 of every patient.
The standard of care, clinically stage 1, stage 2, stage 3. Stage 2 and stage 3 we can start right now without sending it. Stop. And when you want to treat by oseltamivir, do it within 48 hours, 2 to 3 days. These are the clues. Except rest is a clinical oriented approach.
I would like to ask Dr. Reddy.
I have a point which is in disagreement of the standard what the other speakers have said. Suppose I am practicing 100 kilometers away from Calcutta where there is no facility for doing NPA. Second thing, I have been advised to do NPA and I don't have the money to do the NPA because it's quite a costly test. Many of the family members are suffering the similar illness which is very close to influenza infection. What is the harm if I start giving oseltamivir? And oseltamivir, if it is being started even after 48 hours, it works wonder in many of the cases. It is not that you have to give only within first 48 hours. In your clinical experience, all of you are practicing. I have seen many of the cases where the child improved dramatically even if it is given on third or fourth day. If I don't have resources, if I am practicing quite far away, is there any law which will prevent me starting empirical oseltamivir?
No law. You are fully justified. I mean, the law depends on whether you can justify your action.
Yeah.
It's as simple as that. If you can show enough proof or evidence that what you have done has got a scientific basis, analogical and a rational basis, then it's perfectly fine.
So Dr. Reddy, can you just enlighten us? In your hospital, is NP swab purely an inpatient investigation, or do you also send it from the OPD?
So we send it mainly for all inpatients admitted with pneumonia. But even there's a lot of arguments of saying, why even sending it for an inpatient also who's not in the ICU? But there I would differ as a pulmonologist because a lot of the referrals, so we have an entire case series of obliterative bronchiolitis that we see who come to us after their admission somewhere else and the visas persisted. So they're talking about the after effects of adenovirus and RSV. So we are seeing a huge chunk of post-adenoviral obliterative bronchiolitis today.
Right.
Because this adenovirus epidemic happened some time back and we have no idea about it, and now they're coming with persistent visas. We do a CT scan and the CT scan is quite obvious OB. We are ending up giving them methylprednisolone pulses over a period of 12 months now. But if we had that swab, which was done 2 months back when the child was admitted in a different hospital saying it was either RSV or adenovirus, and today the child came back with persistent wheeze, my diagnosis and the management of OB would have been much easier.
Easier, and prognostication to the
would have been
parents
much
would also
better.
be easier.
So now in our inpatients who are coming adenovirus positive, which we are seeing, we tell the parents saying that yes, it is adenovirus positive, the child is going to go to the hospital. But there is a high chance that the child will develop OB later. And if the child develops OB, have a low threshold to start MDIs, start steroids earlier.
Absolutely. So all through our sleep lectures, we heard a lot about the insomnias and the altered sleep. So what is parasomnia? What are the types of parasomnia? Just a brief outline on how would you plan tests for sleep disorders, and does iron deficiency anemia affect sleep?
Parasomnias are usually grouped into two groups, NREM and REM.
Okay.
NREM are usually clinically you take 3 points. Usually in the early part of sleep, unconsolable and never reciprocate or remember the terror. So these 3 issues are more in favor of NREM. And for REM, there is a late part, nightmares like, they are arousable. They remember this point, they can get aroused, and they remember the situation. There are other many issues like sleep paralysis, sleep movement, nocturnal enuresis. So parasomnia are abnormal behaviors during sleep.
So could we say that these are disorders of sleep where there
Absolutely.
is a motor movement along with the sleep disorder?
Yes.
Yeah.
And there are
So
also
sleepwalking, sleep talking,
First
night
part.
terrors, all of that.
All of that.
Right.
Only to diagnose. The types are, as you say, we are differentiating NREM by REM sleep. And test. Usually we don't advise PSG in parasomnia. It's always a clinical diagnosis. The only clinical general practitioners in periphery to differentiate is parasomnia from nocturnal epilepsy. Okay. That's a very important issue that they, and in fact that is the only issue there are. And finally, yes, iron deficiency and low ferritin are mostly associated with these groups, especially the restless legs syndrome.
Yes.
But there are another group called PMLD, that's a movement disorder that needs PSR. But final.
Sure. So what happens with parasomnia? What is a parasomnia? That is the question which you first asked. So I spoke about the different stages of sleep. Normally we transition between non-REM, REM, non-REM, REM and different stages of sleep. Sometimes that transition gets stuck somewhere. So what happens is part of your brain is in non-REM, part of your brain is in REM. So for example, in REM your tone is extremely low. But that doesn't happen. So your tone may still be high in REM sleep, but your brain may be in non-REM sleep. So when this disbalance happens, you end up having abnormal behavior. So that is what is actually a parasomnia. The test for sleep disorders is polysomnography, not indicated for this. Iron deficiency, I wouldn't say anemia. So what has happened in restless syndrome is many of them don't have anemia. So they manifest only with iron deficiency, which is diagnosed only by low ferritin. They do not have anemia at that point in time. So which is why many of them will have normal hemoglobin, everything, but have restless legs. And then we diagnose ferritin levels to be low and treat them with IV ferritin or oral ferritin. Oral iron, sorry.
Thank you, panelists, for having sat through this. And we will have to end the session here. But the very fact that this session ultimately took place, thanks a lot to the organizers. And hopefully, we've had an interactive session. Thank you so much.
One line to end. Remember what Pallab showed in the first slide? 2 rules. Rule number 1, boss is always right. Rule number 2, refer to rule number 1.
এই কে, হ্যাঁ একটু ছবি তুলে নাও কে কে রয়েছে, তাহলে ওটা থেকে বেরোবে। ফার্স্ট হচ্ছে কনফার্মেশন অফ দ্য মিনিটস অফ দ্য লাস্ট মিটিং। পাস। এই যেটা which is most important, the মানে selection or election whatever it is of the next year's office bearers. that ওরকম বললে হবে নাকি? হ্যাঁ না, পল্লব সেক্রেটারি থাক। তুমি কৌস্তবকে সায়েন্টিফিক কমিটি করে দাও। তুমি জয়েন্ট সেক্রেটারি শ্রমিক বাসু। অরুণদা? আমি তো বলছিলাম, হ্যাঁ আমি সায়েন্টিফিক। এক মিনিট অরুণদাকে করো। আমি না অরুণদা চেয়ারপারসন, তুমি সেক্রেটারি। না আমি তো সেক্রেটারি ছিলাম, একই কথা। না গৌতম দা রিটায়ার্ড, গৌতম দা হচ্ছে মার্গদর্শক। আমি ওই সায়েন্টিফিক কমিটি কোথায়।
আচ্ছা, অরুণ মাঙ্গলিক চেয়ারপারসন, পল্লব চ্যাটার্জি সেক্রেটারি, শ্রমিক ঘোষ ট্রেজারার।
আমাকে শ্রমিক ঘোষের সাথে জয়েন্ট ট্রেজারার করে দাও। আরে আমার সিগনেচারই লাগবে, আমার সিগনেচার লাগবে, আমার সই লাগবে তো। আর
তাহলে তুই জয়েন্ট সেক্রেটারি থাক। আচ্ছা ঠিক আছে। আরে সবই তো হচ্ছে।
কি হয় না? আমি ওই জয়েন্ট ট্রেজারার হয়ে যাচ্ছি।
জয়েন্ট ট্রেজারার কোথাও নাম শুনেছি? জয়েন্ট ট্রেজারার।
এই তো গৌতমদা, যাই করো নর্থ ক্যালকাটার কিন্তু মেডিকেল কলেজের নাম নেবে না।
কিন্তু আমি একটা কথা বলতে চাইছি, যেটা নর্থ ক্যালকাটা বলে নর্থ বেঙ্গল নেবে না। একটা সায়েন্টিফিক কমিটিতে না কৌস্তবের সঙ্গে দেবযানী থাকো, এই কিছু প্রোগ্রাম করার জন্য। আর সায়েন্টিফিক কমিটির তিনটে মেম্বার করো, একটা কৌস্তব, দেবযানী আর আরেকজন কাউকে নাও, যাতে আমরা মান্থলি বা বাই মান্থলি একটা প্রোগ্রাম করি। কেন অনিতা আছে না? সরকারকে নিয়ে নাও। আমি একটা কথা বলি,
একটা সাজেশন, একটা একটা সাজেশন দিই, সেটা হচ্ছে তুই সায়েন্টিফিকে থাক, তোর সঙ্গে কৌস্তব থাকুক আর দেবযানী থাকুক, ব্যাস তাহলে হয়ে গেল। ট্রেজারার শ্রমিক ঘোষ। সায়েন্টিফিক কমিটি হেডেড বাই শুভাশিস রায়। আচ্ছা ঠিক আছে, কৌস্তব আছে আর তুই আছিস, ব্যাস ঠিক আছে। হ্যাঁ থাক অত অরূপদা এখানে নেই, নেওয়া যাবে না ওরম ভাবে। অমিতাও নেই, সুমন্ত্রও নেই, নেওয়া যাবে না। যারা আছে তাদের মধ্যে করো, বাকি পরে নিয়ে নেবে, সেটা কোনো অসুবিধা নেই। ঠিক আছে, আর কিছু? ভোট অফ থ্যাঙ্কস
না, কটা জিনিস বলার ছিল। একটা হচ্ছে যে উই আর গ্রেটফুল টু এভরিবডি অ্যান্ড উই আর ভেরি লাকি that we could generate a lot of funds for Respicon, And that is why this conference was actually done from the Respicon funds. So we did not really take a lot of help, and we did not go beg with a begging bowl to the companies this time. So we could manage this conference, and God's grace was on us, because in spite of all these problems, we had a good show. And the reason that we could not postpone this conference by any means was because there was a lot of renovation going on in this hotel. So if we had postponed this, probably it would have gone down for another 2 years. So we had to do it this time, and luckily everything went on very well. Now, the other thing that I would like to say is, from our funds, because this time we were holding this conference with a very heavy heart. So we are sorry that we could not take everybody's permission, but we decided that let us give amount of donation from the chapter to the West Bengal Doctors Forum, because they are incurring a lot of expenditure. They have lawyers there who are there at Delhi Supreme Court and all. So that is why we gave 75,000. No, we have already given 75,000. So we have given. So yes. So so. হ্যাঁ, হ্যাঁ, তিনজন তো হলো তো, তোমরা তিনজন তো হলে তো, কৌস্তব, দেবযানী আর তুমি। নন্দীকে হ্যাঁ, নন্দিনীকে ট্রেজারার হিসেবে রেখে নাও না, শি ক্যান অর্গানাইজ দিস ভেরি ওয়েল। সো দুজনে মিলে তোমরা ট্রেজারার থাকো, দুজন ট্রেজারার থাকুক না, কি অসুবিধা। হ্যাঁ, জয়েন্ট ট্রেজারার করে দাও না। Yes, very nice. We are very, very grateful to Nandini, because after she came, she managed the whole thing so well, particularly the sessions and getting the people ready for the next session so good. So really hats off to her. So thank you, Nandini. Joint treasurer থাকবে Nandini can be joint treasurer with us. Very, very well organized. So even the speakers were saying that she is coming, and she is saying that, madam, you please complete your meals because you have the next session and all. So thank you very much, Nandini, for all the help. And all this she does out of herself. So even if, like, if you give her some job, then our Respicon went off so smoothly because of Nandini and Amita. Yeah, splendid job. Lokesh was very, 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 very particular. And I think that is all. We had planned to go to Shahid Minar from here. So shall we continue with that? Okay, thank you. So we end the GB here. Acha, we'll end off with the national anthem then. Sure, 100%. 100%. Yes. Absolutely, 100%. Fund নেই, fund আছে। হ্যাঁ, absolutely. Thanks a lot to Somnath da and Rohit for all their help continuously whenever we wanted all these things, no? The background music that you saw during the lamp lighting, it was heard. No, there was also this thing, no? There was, video was there. So all that was done so fast. So thank you very much. Thank you. Okay, national anthem. हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंग। तब शुभ नामे जागे तब शुभ आशीष मागे। गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।